荣誉院长、林院长，还有陈副，还有正副，还有室主任，还有各位在场的就是国内外的贵宾，大家早安。那我是伟婷，我是今天的主持人。那很荣幸今天事实上可以邀请大家来参加，就是心动30创新不止奇美心血管国际研讨会。那我们邀请了许多国内外的专家跟贵宾，那相信大家对于心血管相关的知识，今天会更上一层楼，我们会有非常就是收获丰盛的一天。So, distinguished guests and ladies and gentlemen, today it's my honor to be the host today, and especially actually we invite a lot of experts from Taiwan and also from abroad to share the advanced knowledge in cardiovascular medicine. So today I think everyone will be very excited to join me and to have very fruitful today. So I think first of all, we'd like to share a short video. 首先，我们想要分享一段有关奇美心脏科相关的一些影片，那就是请各位可以就是我们花一点时间来享受这一段影片。I hope everyone enjoyed this movie. So after this movie, actually, I want to invite our distinguished leader, Honorable President Cho. 我们现在欢迎邱仲器荣誉院长来替我们开场，谢谢。
林院长、陈副院长，还有各位贵宾，大家早安，大家好。
好。
那很高兴今天能够来参加，来见证奇美医学中心心血管中心30年的这个历程。那我是在民国86年到奇美医院服务。那在到奇美医院之前，就听说这个我前任的院长詹院长，这个 recruit 了很多优秀的心脏内科医师，还有心脏外科医师的人才来到医院服务。所以我来到奇美之前，奇美的心脏内科已经是相当的发展的相当好。那在民国96年，我担任院长的期间，心脏内科扩充了很多的设备，那延揽更多的人才，发展更多的新医疗科技。那因为我们医院有规定，这些新的科技呢都要到经营决策委员会报告，所以呢，我们在这个决策的历程当中，也看到了很多心脏血管这个新科技的进步。 所以几乎在这个经营决策委员会提出要买这个 LOTA， 买这个 IBRS， 买这个 OCT 震波，甚至呢这个放射科配合这个心脏血管高功能的这个影像检查，包括152切的 CT、FORCE， 还有3T 的 MRI 呢，医院都为了这个心脏内科的发展呢，都很快的答应就充实了这些设备。那在心律不整方面的设备呢，也都是最新最高级的设备。所以今天很高兴呢，能够来见证这30年走过来呢，能够有这么多好成果跟大家分享。那也感谢各位先进对我们医院心脏内科的支持。那我想今天会是一个很丰盛的一个研讨会。那祝大家有满满的收获，祝大家身体健康，万事如意，谢谢。
好，非常感谢邱永玉院长给我们的一些鼓励。那再来的话，我们想要邀请林院长帮我们致辞。Let's welcome the President Lin to give an opening remark.
Our honorary distinguished guests from all over the world， 还有台湾的好朋友，那奇美医院的同仁，大家早安，大家好。那我是民国84年来到奇美医院服务了哈，当时这个心导管室正在建设哈，所以从民国85年开始。包括当时心脏外科的郑博士主任的加入，那我们心脏内外科的团队非常的努力。那么在这些年里面，那么我们有很好的一个成绩哈。那我担任这个医务秘书副院长到院长，那我见证了这个心血管中心相关团队的一个成长的努力。那很多的礼拜六，我们邀请了很多的这个国内外的专家来指导哈。那从全世界的各个国家邀请了很多专家来指导，我们发展了很多先进的手术跟治疗哈，所以我必须要对这个心脏内外科的团队、心脏中心的同仁的努力来表达感谢。第二个是透过团队合作，所以我们心脏内外科包括了麻醉科、放射科，还有其他重症相关同仁的一个努力，那么我们的这个技术能够不断的突破，照护的病人能够朝更严重、更需要这个医学中心照护的病人去努力，因此有很好的成绩跟突破。那我想今天这样子的研讨会就是要来见证以及总结我们过去30年的一个成绩。再一次感谢，也欢迎大家来参与，谢谢。
感谢林院长给我们的鼓励，然后再感谢。那再来的话，希望邀请各位在座的专家和与会的贵宾们，我们等一下来个大合照，所以大家要尽量往中间坐，然后大家维持就是现在的状态，然后我们等一下来一张非常好的，希望今天会议可以很圆满成功的一个大合照。Okay, so we're going to have a group photo, so please just be seated. 感谢各位贵宾的配合。那再来的话，我想要邀请就是我们的陈志成副院长，然后在我们这一段时间心血管在奇美的发展，想要做一个小的一个相关的 demonstration. Let's welcome the Vice President Chen, and he will give a brief talk about the cardiovascular medicines and how the improvement in奇美Medical Center.
Dear distinguished guests and colleagues, since most of the audience speak Mandarin, I will deliver the speech with Mandarin. 在30年前，就是1996年，民国85年的时候，就是这个月3月，那在奇美医学中心呢，我们开始做了第一台的心导管，那从此就开启了心脏内科、外科一起合作。那么在心脏血管领域的一连串的发展，那这30年过得很快，但是很快的大家就会看到整个世界，那么有很多方面都跟现在又不一样了。所以我们除了刚刚看的那个影片代表过去的成就，我们也想知道，那么在未来还会有什么样的进一步的发展。那大家可以看得到，在以前我们的疾病的治疗，大部分都是有一点反射性的，看到什么样的疾病，我们就这样来治疗。但是随着这个基因剪辑的进步，还有这个机器人手背的这个发展，以及现在的很热门的 AI 的发展， 那么我们对整个疾病有一个整体的一个概念。那所以呢，在以前疾病的治疗呢，是一个 organ 跟一个 organ 这样来看，就是譬如说像动脉硬化疾病，它会从心脏、肾脏还有新陈代谢，也就是糖尿病的角度来看。但是现在呢，随着整个诊断的技术的发展跟药物的发展，现在的做法会是整个全面性的考量。那么所以呢，我们对于整个这一个有一个整体的合在一起，称为 CKM syndrome。那我们会有分成 Stage 0到 Stage 4， 那这5个阶段。那么比较高阶的这个 Stage 3跟4呢，它会有这个就是比较高的死亡率啦。所以我们的考量呢，必须希望是在比较早期的地方，那么就要把它做一个治疗哈。那么刚刚有提到，就是我们现在对于整个新陈代谢的观念，还有药物的进步，以及这个基因工程的这个基因的剪辑，还有 AI， 还有这个机器人的进步，我们现在会变得更全面、更积极、更系统性的来治疗一个疾病。那所以呢，你可以看得到，现在有一个新的名词叫做 Metabolic Cardiology， 它就是运用现在比较新的这个药物，那么我们对心脏功能，还有这些非糖尿病的肥胖病人，都被证实，都对于减少这个心血管的不良事件的发生，都有很明显的进步。那尤其呢，在以前我们对血脂的治疗，都认为说只要吃 statin 就可以了，但是现在都认为不只是 LDL 降低，还有一个叫 lipoprotein little a。那这样的小 A 脂蛋白呢，如果它高的话，它还是有额外的风险。所以在这几年呢，开始有一些针对 lipoprotein little a 的治疗。那么有口服的，有针剂的。目前最进步的就是已经做到了 Phase 3的这个每3个月打1次的这个针剂。那另外呢，也有口服的，那也有1年打1次的这样的针剂。那目前看起来都有很好的一个进展。那除了这个以外呢，更让人家兴奋的是，因为基因剪辑的进步呢，我们可以利用这个 lipid nanoparticle， 那可以把这个 CRISPR-Cas9 的这样的一个基因的整合物，那再加上钙的 RNA， 它可以把它打到人体去，那么进入到细胞里面，那么它就可以对于 ANGPL3 呢这个基因呢把它关闭掉。那这样的，它可以大幅减少，那么 LDL 达到 60%，TG 减少 55%。这个对于那个家族性的高胆固醇的患者，你只要打1次针，输液1次，那么你就可以得到整个几乎是 cure 的这个情形。那这个是有赖于这个基因剪辑的进步。那除了这个 lipid 的进展以外呢，我们现在还有针对这个 inflammation 的看法。那在今年呢9月的欧洲心脏学会预期呢，这个 interleukin 6 inhibitor 的这个研究第3期的研究会有报告。那另外呢，就是对高血压，我们现在对于新的这种 dual endothelin antagonist 跟这个 aldosterone 的 synthetase 这样的这个 inhibitor， 那我们会有跟以前不一样的机转的这样的新药的发展。那另外呢 ，AI 的进步呢，它也可以协助我们很快的，那么把这个在做超音波的时候，把它的边线画出来，可以提供很精确可靠的 LV 的 ejection fraction， 以及还有 global longitudinal trend。那么同时呢，它也可以让我们有在很标准化的一个检查的系列里面呢，提供我们比较没有。就是每个人不同 operator 之间的 BIOS 的发生。那 AI 也很进步啊，你只要给它心电图。那么昨天我们的 Dr. 也会有提到这样的议题。那现在呢 AI 他们也宣称可以对于 cardiac arrest 的预测有几乎将近 99.89% 的诊断率。那对 silent ST myocardial infarction 的也有高达 92% 的 sensitivity 的这样的诊断率。 那所以呢，借由 AI 还有 wearable device， 我们可以像智慧的戒指、手表、ECG 贴片等等，我们把它收集到资料汇到医院的中央医院的云端，那我们再做一个整体的整理之后，会对于病人的病情提供一个有系统的一个报告出来。那这样子呢，对于整个偏远地区的治疗，那么医疗的这个的更迅速，而且可靠，而且更普及，都有得到这样的好处了。那也因为这些智慧医疗 wearable device 的进步呢，所以因此也带来后面 arrhythmia 的治疗。所以呢，现在对于慢的，我们也有这种 leadless 的 pacemaker； 对于快的，我们也有 dual energy 的 ablation。那另外呢 ，structural heart 方面也有很大幅的进展了。像大家所知道的主动脉瓣的置换 TAVI 这个手术呢，大概1年有60万个 case， 而且呢，现在都认为 TAVI 呢，那么不需要说一定要等到病人很老的时候才来处理，现在把他年龄降到70岁，那么只要病人70岁以上就可以建议，这个是一个标准的一个治疗方式，而且 TAVI 呢，现在只要2天的住院，那不只是aortic valve， 那包括 tricuspid valve、mitral valve 都有不同的 device 可以来处理。那所以呢，再搭配上 AI 呢，目前我们也认为它有很高的诊断率。那么甚至机器人也可以运用在 TAVI， 那么整个来用机器人来置换，那也可以在很远的距离，就2500公里外，也可以来做这样的遥控的这个机器手背的置换。那再加上材料科学的进步呢，现在呢，我们这个 valve， 那么目前预估呢，它可以使用35年了，那也可以用3D 列印方式来列印出来。那所以现在呢 ，FDA 已经通过说，对 asymptomatic 的 AS， 我们现在建议是可以早一点来治疗了。好，所以在这种种的这些进步呢，我们就可以扩展了很多以前想象不到的。那甚至连这个人工心脏，那么人工心脏以前呢是必须要有一条电线从体内拉到体外，这样就增加了 infection 的机会。那现在呢也有可以从体外无线充电的方式，让病人不再有电线暴露在外面的这样的风险。那这个也是在目前在积极在检查，在发展中。那另外呢，我们呢，在以前呢，每一个心脏移植的病人都要做 biopsy， 但是现在呢，也有所谓的 liquid biopsy， 就是可以在移植病人的身上呢，那么给他抽取血液，看看有没有这个 donor delivered 来的这个 DNA。那这样的方式再用一个 2TA 的这个程式来运算，就可以知道它到底有没有发生排斥，这样子就可以把这个在检查的时间更加的缩短，那么也减少 invasive procedure。那另外呢，对于大家很有感兴趣的那异种移植呢，那么在2022年，在全世界就发展了第一个用猪心来置换。那这个猪心的第一例呢，就发现了有这个猪的 CMV virus 的 infection。第二例呢，是发现了它有超级性的这个感染，所以这后面就发展了有一些题目，就是我们未来要发展的。那在这几年呢，也随着这些技术的进步，基因剪辑的方式，那我们现在认为说，这些从同情使用的计划，现在变成一个正式的 Phase 1的 try。那么尤其是在这个月3月初，那么 International Society of Heart Lung 的 Transplantation， 他们有一个临床的共识，那么他们现在对这个有一个统一的建议，那就是说那个猪呢，它必须要把3个基因给它除掉，减少它的细胞上面的碳水化合物的抗原，那也要把这个人的基因呢，把它植入6个基因，那调节对人的这个凝血的这个反应，还有部分的免疫的反应。最重要一点，还要把猪的这个它的 growth hormone 的 receptor 那个基因要敲掉，因为猪啊会长得很快啦，总不能是放进一个猪心，那以后这个猪就那个猪心长得很大，那就有一些风险。再加上免疫的疗法的发展等等，这个都是未来的发展，会在大家到未来的30年应该都看得到了。 那所以呢，随着这一些进展，大家在未来的30年对于心脏血管的治疗呢是很精彩可期了哈。那希望借由今天的演讲，那么让大家了解到目前为止在心血管方面的治疗，让我们也期待未来有更好的发展。谢谢。
感谢陈副院长对于心血管发展还有相关愿景做一个非常好的阐述，相信大家对于未来心血管的发展都非常的期待。那紧接着我们就要开始我们第一段的演讲。那我想要邀请我们的曾成全顾问到讲台上来介绍我们第一位讲者。So we're going to begin the first scientific section. So I would like to invite Dr. Zheng Chengquan to introduce the first speaker, Dr. C. Dikui, from the United States. Please get on stage.
Good morning. Welcome to join this meeting. The first topic will be presented by Professor Stich with the title, A New Resolution, Dual Energy Technique is Transforming AF Ablation. I briefly introduce Professor Stich. Currently, he is the EP Director at the Adjunctive Celebration Health and Coloston in Florida and USA. Let's welcome Professor Stich.
Good morning, everybody. Thank you, Dr. Chen and the Chiami Medical Center for this warm invite. Quite impressive that what you guys have been able to put through. I'll try to speak a little slow so the translation can follow. My job today over here will be introducing this wave of mapping and ablation in one format, which has really taken over United States. The adoption of this technology is quite fast, quite rapid, and we've been able to do procedures that we were quite reluctant about doing in the past. So this system consists of a mapping software, which is referred to as PRISM software. It is a catheter which is extremely unique, and I'll go over some of the characteristics of the catheter all in one. The catheter is then able to deliver PF energy, pulse field energy, as well as radio frequency energy, all from the same system. And it also has a mapping unit in it with an irrigation pump. So this is what the catheter looks like. It is a quite soft and conformable catheter. For electrophysiology procedures, one of the most important things is actually stability of a catheter. The catheter has been designed in a way that it sits on cardiac tissue and actually able to deliver energy in a much more stable fashion. It has 9 electrodes on the tip, which you can see, and these are unusual in a way that they're microelectrodes. These are small electrodes which not only are able to detect electrical front, but they also detect temperature at the interface between the tissue and the system. If you have a marker, I can show them. The way it detects electrical activity is through wavefront. If I show my mouse, it'll show up over there. Yeah, perfect. This is the highlighter. Again, highlighter. Yeah, perfect. So these are the 9 mini electrodes that you can see. And this is very unusual because this is the first time we're using a wavefront which is called closed unipolar technology. We're able to see electrograms as a combination of bipolar and unipolar. There's a central electrode terminal where the wavefront is traveling from these microelectrodes to this central terminal. It gives you a very robust unipolar directionality as you're moving the catheter around. So if you have a tachycardia sitting over here, that's where the focus is coming from, the electrical wavefront can be detected instantaneously as you're moving around, which makes the mapping technique and determining the tachycardia where it's coming from very quickly. Why weren't we able to do this previously? Because with unipolar, you get a lot of far field potentials. By putting this electrode right in the center, you prevent these far field potentials and you get a really sharp electrogram. So the catheter is able to give pulse field energy and radio frequency energy in both. Both kind of energies have their advantages and disadvantages, and I'll go over them in a second. But pulse field really has taken over. For atrial therapy, it appears to be the safest energy because it has selectivity towards myocardial tissue. The lesion that this catheter creates is quite large, almost up to 15 millimeters. So we can give really large lesions very quickly. The depth is 5 millimeters, which goes typically for atrial tissue, works quite well. So why pulse field electroporation? And this is a video demonstrating that. When an electrical field is applied to a cell, the cell membrane opens up. And when the cell membrane opens up, that's when the cell slowly starts to lyse. And this appears to be the safest way to damage these abnormal myocardial cells, which are driving atrial fibrillation or any kind of arrhythmias, as a matter of fact. And with pulse field energy, we get quite a high therapeutic window. What does that mean? Well, if you look at it, the nerve cells or vascular muscle cells or the red blood cells get damaged when the voltage is much higher. But if you stay around this area, there is quite a wide therapeutic index. So you can do these procedures without damaging all these coexistent things that we have to work with. Now, when we do RF, this therapeutic window is much smaller. So when we're damaging the myocardium, there's a risk of damaging nerves, smooth muscles, esophagus, and whatnot. So that's why the safety profile. And a word or so about contact. Much has been talked about how the contact is and how the contact is important. Contact, even in pulse field electroporation, is important. However, contact force doesn't appear to take as much of effect. This is an example showing this, where at multiple contact forces, when a lesion was created, the change is not much. But it's important to touch the tissue, be close to the tissue, be stable, but you don't have to push the catheter deep into the tissue. So there's a little learning curve as we're adopting with this newer technology. This is an example of proximity. Even if you're not touching the tissue, if you're close enough, you will create some sort of lesion. But as you get closer and give a stable lesion, and that's why catheter stability is important, you get a very nice lesion. So all you have to do is have the right catheter with the right waveform, and it makes your job easy to give durable lesions as you move. But it has its own limitations as well with PFA. If you end up ablating without touching the tissue, you can cause hemolysis, which as you damage the red blood cells, as you can see over here. So having the right catheter with the right kind of contact and the right kind of waveform is important, so you keep the damage to the red blood cells low. This is an intracardiac echo picture. I recommend that when you start using a new technology, always use ice first to make sure there's a lot of bubble formation, as you can see over here, which typically corresponds with hemolysis. So you want to be able to be using the right kind of technology for this. So after introducing the basics, let's move to this technology. Why is this catheter able to do what it's able to do? This is an example of a moving heart where we work in. And you can see with the standard catheter, the catheter moves around. But with this conformable catheter on the ridge, areas where typically stability was an issue, you can have catheter contact really, really well. So it makes the operator's life much easier and also gives you a very durable lesion. And to that, if you add up the mapping and ablation part, it makes it even much easier. Now, this is the example of standard radiofrequency. This is a very robust ablation system for RF. What does this show? Well, essentially, this is the old ways we used to do RF ablation. When we're doing RF ablation, our purpose is to cause heat in the tissue. For that, we use power. We give power, current travels, current, depending on the impedance of the system, some of this current will go into the tissue and cause heat. But we cannot really predict how much of the current is actually going into the tissue and causing the heat damage. With this new system, the ablation is actually temperature-based. These microelectrodes will actually detect the temperature which is happening on the tissue interface and give a feedback to the power to say, hey, listen, you're ablating too much, dial the power down. So it increases the safety of the procedure with this feedback. And hence, the risk of steam pops. Steam pops means that if you dump too much current in the tissue can desiccate. So it appears to be one of the safest ways of doing RF ablation because of this loop. Also, this catheter, because of its mesh, has lower impedance. So the current density is much lower. So even at 15 watts, 20 watts, you're able to give more current to the tissue to could cause a heat lesion than a standard catheter. So a very efficient way of doing RF ablation and an extremely efficient way of doing PF ablation. So let's put it all together. None of this is good if you cannot map with the system. With this 9 microelectrodes and a very robust mapping system, you can create a map very, very quick. See, as you're moving along, the map creation is instantaneous. And you can get voltage information as well as activation information right away. So some people can argue, because we use electrodes which are much higher, 64 or sometimes even more than that, that the map creation may be less. But in this case, because of the microelectrodes and the software that it has, the map creation actually works very, very fast. So once you've created the map, the next step is, how do we do the ablation? The green tag represents the PF ablation, and the red tags will indicate RF ablation. So the big question comes in, how do you know you're touching the tissue? So several factors happen. When you come close to the tissue, an area on the sphere, white area lights up, which tells you that you're touching the tissue. And the way it determines is because of impedance changes. You will see, not only that, each of these microelectrodes as a sensor. So if only this area is touching, it will light up. If this area is touching, it will light up. If this area is touching, it will light up. This is extremely unique for this system. We have not seen a system like this which can show directionality of how you were touching. Similarly, when you give a lesion, temperature will rise up. So this electrode was touching the system, and that's when we give the PFA. Local temperature changed, and that's why an automatic tag was created. So I can actually tell from which electrode I was actually doing ablation. Also, these tags, as you mentioned AI in your lecture, has automatically, you can determine the shape, by the shape of the tag. So if you go back and review the case, how the operator was touching. So if you have a flat tag, like an M&M, that means only the lower part of the catheter was touching when you gave the ablation. If you have a round, that means most of the electrodes were touching when you gave the ablation. Okay, and this is the activation map. And then following that, another example of how you know you're touching. You can see the electrode light up as you come closer. White disc on the sphere, white disc appears. And when you know you're touching, this green band appears on the electrode that you were actually having contact with. So you have all these parameters which can actually tell you that you're close to the tissue, and now you can go ahead and do the lesion. So local impedance to tell you contact, a temperature display during RF, which tells you if your lesion was good. So making the operator's job easy. A lot of artificial intelligence put into this to determine that you're giving good lesions. And similarly, when you're giving PFA, temperature changes on that local electrode. And automatic tags as well, and the connect line as we talked about. And the other advantage than a standard catheter is with a lattice tip is that it will always give you a more spherical kind of lesion. So a broader lesion, which with significant overlap. So the chances of reconnection of whatever lesion you're giving is much lower. A couple of things about repetitive applications. If you do PF over PF, you can drive the lesion a little bit deeper. So that's why having overlap is important. We used to, with all the systems, and especially in Affera, we try to overlap these tags. And this is an example of giving RF energy on PF energy. So for example, you're running into a tissue which is extremely thick. You can give RF over PF to drive the lesion even deeper. And these are examples of that. So what about the evidence? So it's pretty amazing that what this system has been able to do over the course of last 6 years. It really started around 2019, 2020, where the first FIH, first-in-human trial was done to look at effectiveness. Following that, there was the pivotal trial, which we were the part of, as well as the IDE, where the results were to a SmartTouch STSF catheter, and now more than several 100,000 cases already done. This is the original first-in-human trial. This is one of the trials where actually durability was looked during the case. What does that mean? Well, when patients were treated, all these patients in the first-in-human trial were brought back in 90 days, and the durability was looked. So if the lesions were not good, the pulse waveform was changed till you have a durability more than 90%. So the current clinical waveform is the pulse 3 that we have, with a durability above 90% range. So this has been tested and very durable lesions. And then this is something which no other catheter has been studied for linear lesions, because linear lesions such as mitral isthmus line, cavernous-tricuspid isthmus line, or the roof lines, a lot of times that's what operators struggle with. And when we do, we can get acute block, but we don't know about long-term block. In this catheter, there is actual data about durability of this in the first-in-human, where you get reaching almost up to, in some cases, 70 to 80% in all kinds of lines. Now, this is the actual IDE trial. The company this was before Medtronic acquired this. The company was really bold. They took persistent patients for their approval, and they compared it not to drugs, but to actual standard of care Smart Touch ST-SF catheter. So they're comparing it to a contact force catheter. No contact force, large sphere PFA, RF2 PFA. And the safety rate, even without contact force, was really, really good. If you can see, the risk of anything bad happening was less than 1.4%, so really, really good safety profile. And then look at the effectiveness. This was a non-inferiority trial, but it tended to do better than the Smart Touch ST. Now, these operators, which were part of the trial, have done thousands and thousands of cases with this thermocool Smart Touch. Despite that, this new technology seemed to be doing a little bit better. It was concluded as non-inferior because the trial was not designed for superiority. And then look at the linear lesions. The operators were so much more comfortable doing linear lesions with this as compared to the standard catheter. So we are able to do things. We get much more comfortable in doing things that we were not before. And I'll show you some examples in the next few minutes. A thing or two about plasma-free hemoglobin. This is the first generation of PFA where you were seeing quite a bit of hemolysis. As you dive down to the second generation, things have become much better, even safer with PFA. And if you compare it to it appears to be the best catheter at this time for persistent atrial fibrillation. If you compare, this is not a head-to-head trial, but comparing Advantage AF for pentaspline catheter versus Affera. Okay, so let me show you a video. This shows 9 minutes. How much time am I left with? 8 minutes, okay. All right, so this is a video I'll play. So to visualize the catheter, I know intracardiac echo is not very common use here, but this is one thing I wanted to display how the catheter moves around. This is how we put intracardiac echo into the left atrium. We do a transseptal puncture. We'll pull our sheath into the right atrium. We'll use this wire as a rail, and then I'll see that I'm advancing my intracardiac echo catheter, just using the wire as a rail without even using fluoroscopy. You can get the intracardiac echo into the left atrium. So once you're in the left atrium, you can now visualize really nicely. You can see the appendage is sitting over here. You have the pulmonary veins here. You have the valve here. And your catheter is going to come out there in a second. And this is the ablation, and this is how the catheter looks like on intracardiac echo. You can see it's very echogenic, and you can easily identify contact and confirm contact and see if the system really delivers what it's planned to deliver. This is real time. You're not sped up. This is actually me doing a case. Now, with paroxysmal atrial fibrillation now, we have adopted pace and ablate strategy. We don't even do the whole map. If we find the right circuit, we'll go. So you can see I'm sitting in the left superior pulmonary vein. There's sharp electrograms. These are PV potentials. So the catheter actually gives you really sharp electrograms. You can see my catheter is going to come back right at the carina. And I want you to see how the catheter sits on the carina. I'm not even holding the catheter. I'm just using the sheath. During a moving heart, it's extremely comfortable and extremely stable sitting on that carina. And that's where I'll give the application and the whole vein gets isolated. If you see over here, this is my sheath. This is my catheter coming out of the vein. And you can correlate to the map, see how sharp, and this is where I gave the application, and the whole vein becomes isolated because there was a pulmonary sleeve activating the vein. So with one lesion, you were able to get this. But of course, you move on and finish the whole lesion set. And this is how we will create the ridge. You can see the ridge over here, very well on intracardiac echo. This is the ridge between the pulmonary vein and left atrial appendage. See how comfortable the catheter sits. And so you can finish your circle very, very quickly. And similarly, you can see on the right side as well, as you move on, you can give applications. This is the, I can't see very well from here, but this is the right inferior pulmonary vein. And you can see the sheath and catheter contact over here. In some cases, we choose to do RF if the tissue is really, really thick, because some of the data that I showed you, this is the posterior wall. The other beauty of this system is that the lesion that you create will not spill over. So posterior wall is still beautiful and intact, and the lesion that you're creating is still at the area where you ablated. So this is the post map. After doing your vein isolation, you can see when you do the map, everything looks exactly the same where you wanted to do the ablation. You can also pace from the system. So I'm going inside the veins and make sure it's quiet, and I'm pacing from the system to ensure that there is no capture. You can see the rest of the voltage looks quite normal during a remap. This is a good example. You can see there's no spillover over here. The voltage is exactly where, and this is me pacing inside the vein. This is right inferior pulmonary vein. I'm pacing, and there's no capture. So you can pace, you can map, you can ablate, you can do everything with one catheter system. So in this next few minutes, I would like to get over some of the cases. And I apologize, we may not have too much time for questions because I have another commitment in Type A after this. But if anyone has questions, you can stop me in between and ask. So I was giving an example of how we are able to handle some of the sicker patients. You can see this is a patient in atrial fibrillation with an ejection fraction of 20%. Heart failure people, transplant team referred to us. Patient has very large left atrium and a lot of scar on the posterior wall going all the way to mitral area, and a lot of scar in the veins. So of course we can do very safely. Our goal over here was to do pulmonary vein isolation and posterior wall isolation. This is the PFA lesions, most on the posterior wall and on the roof. We were of course doing quite a few lesions originally. This is one of my first cases, just to make sure there's significant overlap. As we do that, patient's AFib terminates into a flutter. Now in a standard case, you would have to take the catheter out, put another catheter in, and map. Here you don't have to do that. With the same catheter, you can do a very quick map, and this is the map, and it confirms that this is an atypical flutter. So you terminate atrial fibrillation in a long-standing persistent patient into atypical flutter, you map it, you confirm that it's mitral isthmus, and then you don't have to give any PFA close to the valve. PFA close to the valve is not safe. So we did RF close to the valve, and as we come close to the appendage, we give PFA. And as you do PFA, you will see over here, patient has atypical flutter. As you give PFA over here, it terminates into a different kind of flutter, flutter number 2. And we deal with this all the time. The activation is different. Now what do? Do we cardiovert the patient and go home because the patient's too sick? No, we have a catheter already in there, so we do a remap. We can do it quickly, remap in 1 minute, and we confirm it's not a left-sided flutter. This is the application. So we go to the right side. When we go to the right side, we confirm that this is a CTI-dependent flutter. Now we don't have to give PFA close to the valve. We don't have to give nitroglycerin, none of those things. You can do RF on the CTI. So with the same catheter, you can do everything. So you give the application of RF here, you terminate into sinus rhythm. So this kind of case, before this, the Affera Sphere-9 became available to us, would take us 2.5 hours maybe. And sometimes we'll just cardiovert the patient and bring them back if they get sick. But something like this you can do much quicker with a very good outcome. So it gives us a lot more confidence to do these procedures. And this is an example of video as it's playing. As I'm giving RF, this is an example of RF, not PFA. You can see the temperature goes up, so you don't need contact. I got 70 degrees here, and I terminate with this lesion over here into sinus rhythm. And this is a post-voltage map you can create. This is another case, a similar kind of case you can see. And then a very high voltage, a very abnormal voltage. So as we ablate these and do an anterior mitral isthmus line, as I go on the posterior wall, you will see that AFib terminates. So we have seen more terminations of atrial fibrillation with this technology than I've seen in 20 years. You can do, as I'm doing application, AFib terminates into a flutter. Looks like a typical flutter. So we remap using the same catheter. You can see over here. And you can see how I can tell that I'm touching because my temperature is going up on this. So I had a good lesion, terminates into a flutter. We map the flutter, and the flutter proves to be a CTI flutter again. And we ablate here, and it terminates into sinus rhythm. So durability of lines, terminating atrial fibrillation, all of that appears really good with the system. All right, so there was a question about whether these things have good mapping or not. So this is an example of a lateral flutter. You can see the electrograms over this catheter is something which we use with. See how beautiful these this is a lateral atrial tachycardia from the right atrium. And these give you electrograms almost as good as something we use to age-degrade Optral, mid-diastolic. And of course, you give applications here. And because of the wavefront technology, you can get this right away. You can get the propagation right away. And with this, you'll have to look at those electrograms. So even though this is not a 64-electrode catheter, it is able to give lesions like what we used to. So I'll skip this. I'll show you what's new coming, and I'll stop over here for some questions if you have. Most effective versatile mapping and ablation tool available, potential for zero and minimum fluoroscopy, stable and durable lesions, zero exchange and less risk of venous complications. This is something we're excited about. This is the early feasibility study for sphere-9 ventricular tachycardia, 20 patients which have been done in US already. The one-year results will be presented at HRS. So this catheter, because of its stability and able to give really, really deep lesions, may make the difference in ventricular tachycardia where we struggle right now. And this is data from Europe, same way. And we're hoping that Taiwan will get sphere-9 and do some really good work with ventricle because in US we are a little restricted. We can only use it in certain centers. But here they may have an opportunity. This is the 360 catheter, which is the bigger version of this, which is currently in trial at US as well, the ID trial for paroxysmal and persistent. So that data also looks really good. So I'll stop here, and if we have time for questions, we can do. Thank you.
Thanks, Professor Stitch. Excellent talk. So, because time limit, we allowed 2 short questions. Any question or comment from the audience? No question. Professor Lee.
Thanks for Professor Stitch's excellent talk. I think a FERA system is a very good and rapid and effective system. But how about safety issue? Because complication from RF, we know esophageal injury and other problem. And because a dual energy system, maybe another complication. Give some example and how about the safety issue?
Yeah. Excellent question. The safety profile, as you saw in the IDE trial, and as you saw in the first in human trial, is very, very low, 1%. Why is that? Well, in the atrium, in most cases, just stick to PFA. Try to avoid RF because it's a very strong RF system. So the only time I would use RF in this is when you're close to the valve, so mitral valve. And then that's where we struggle with other catheters because you don't get stability. So like yourself, I used to do alcohol ablation for mitral lines. After I've started doing this, I don't need alcohol ablation anymore because the lesions are very good. So as long as you're careful about that. If you're anywhere close to the posterior wall, you should not be using RF at all because of, if you're close to the phrenic nerve, you should not be using it. If you're close to the pulmonary vein, you should not be using the RF part. But the PF part is really safe because it's a smaller catheter, so the risk of hemolysis is low because you're not ablating the red blood cells. And then any other, it's a smaller sheet, so catheter exchanges is much easier. So safety profile is actually better. Now, as far as safety from contact, because it's conformable, Even if you're a little pushing the catheter, it bends. So that's why we didn't see any perforation at all in the IDE, and has been no perforation reported in so far cases, at least from the catheter. So I know we used to contact force, but remember that's a rigid catheter, so that needs contact. This is conformable, so it doesn't. So safety profile is really good. So, and then at the same time, if you're addressing a really thick tissue in the ventricle, where you actually need a deep lesion, that's where you need RF on top of PF to drive the lesion almost down to 1 centimeter and stuff. So really a good combo over here.
So how about coronary spasm? Coronary spasm.
Excellent question as well. Coronary spasm typically is restricted to PFA usage close to the coronary artery and the kind of waveform that you're using. So in this case, coronary spasm can happen with any kind of PFA. So number one, we have to understand that if you use it close to the vein. But then it also depends on the kind of waveform that you're using and how your catheter is designed and how big your catheter is. In this case, because when you're close to the valve, you're using RF, you're not using PFA at all, the chances of coronary spasm will be the same as having coronary spasm with RF on the coronary artery, which happens very, very rarely. It can happen, but very rarely. So coronary spasm, because of that, is kind of negligible in these cases. When you're close to the valve, we only use RF. We don't give any nitroglycerin with these catheters. In other catheters, when you're using PFA, you have to give pressors to get the pressure up, then give nitroglycerin, then give your application, and still watch. And even if you do that, there's some case reports of delayed coronary spasm, so we don't understand it. So I think the safest thing to do is to maybe, if you're possible, use RF close to the valve.
Okay, thank you. Because time is limited, we thank Professor Stitch again. And I will move the chair to Professor Lee.
Good morning, everyone. I'm Dr. Lee, an electrophysiologist in Ximei Medical Center. Today, it's my pleasure to introduce Professor Young Guk. He is an associated consultant at EP Field in Queen Elizabeth Hospital in Hong Kong. And he also is an associated professor in Chinese University of Hong Kong and Hong Kong University. He is a very famous EP interventionist and a speaker, and joined many EP international society. So today we join me in welcoming his talk about leadless and dual physiology pacemaker.
Thank you, Professor Lee, and thank you for inviting me to give a talk on the new era of the heart rhythm care, leadless and dual physiology pacemaker. And I'm from Hong Kong, and it's my pleasure to introduce you the dual chamber leadless pacemaker. And we have been using the transvenous pacemaker for many years, and I think the leadless pacemaker has been a great breakthrough over the past 10 plus years. And I think all of you have seen the success of the other pacemaker from the Medtronic, the Micra system, and they have been improving over the years. And now we have another newer form of the dual chamber leadless pacemaker, which it has its own characteristic. And from the photo, you can see that this can be split into two systems. One is putting in the atrium, one is putting in the ventricle. And because of this design, they can overcome some of the disease that you cannot treat it adequately with the single chamber pacemaker before. And there are subtle changes in the design. The atrium one have a double helix, and the orientation of the distal grid is different. The design is for the stability and also helping it to being able to put it in the chamber. And the other characteristic about this system is that there's eye-to-eye communications. That means the two pacemaker can talk with each other via wireless communications. And this is something that's very important because you have to avoid the synchrony, and then you have to let the two chamber pacemaker to communicate each other in order to achieve a good physiological status. And this is very special about this pacemaker. And this eye-to-eye system has been tested in the IDE trial, and they can show a 98.2% of the successful AV synchrony, and as defined by the study endpoint. And it doesn't change a lot in different posture. This is very important because if you have this different in the synchrony when you do a different posture, then the patient may feel the difference in the may feel it in their own exercise, or when they change from supine to standing, they may have problems. They may feel dizziness. They may feel discomfort, and which can happen if you use other technology. But this is something that is very performing good in this pacemaker. And I think one of the great advantage for having the dual chamber pacemaker is that now you can extend your spectrum of the disease that you can treat with the leadless pacemaker technology. In the past, if you have encountered patients with a six-sinus syndrome, the only things you can offer is probably a transvenous pacemaker. And now you can talk with them, and they may be able to switch to the leadless pacemaker by putting in a fair AR device. Of course, that depends on the financial status and also the reimbursement policy in different countries. And for the fair VR, it is actually a quite good device. You can, if the patient has been in chronic atrial fibrillation or just very intermittent AV pause, then this is a very good device because it's a longer device. So it has a longer, larger battery, and it has a longer longevity. So this is one of the things that I think is this device can provide you a even longer longevity compared with other leadless device. And in patients with combined six-sinus and compare block or compare block, then you can still consider the Affair DR system as a pair. And of course, you need to do two devices together in the same setting, or you can upgrade it in the future. And but if you do it in the same setting, you're using the same introducing sheath, so there doesn't need to get another puncture. And to that, I would like to share with you a few cases in real setting, because it's easier for me to talk with you a lot of study, but at the end of the day, we are seeing the patient. So it's better to see how we are able to use this kind of technology to help our patient. And the first case is a patient with paroxysmal atrial fibrillation, and we are implanting the device in sinus rhythm. And she had usually hypertension, diabetes, hyperlipidemia, and paroxysmal atrial fibrillation on the anticoagulation. And she had a history of syncope, but at that time, the patient was discharged with a diagnosis of vasovagal syncope. And of course, the patients do not have just one syncope. Unfortunately, she has another one resulting in head injury and laceration. And you can't see much problems in the ECG, except there's some incomplete right bundle, but there's nothing that you can catch from the resting 12 lead. Of course, you do some more investigation. This is the Holter. And the Holter detected a conversion pause, and I don't think it's a conversion, but it's sinus pause. It's still sinus at the front, at the bit before it. So it's, there's also episode of atrial fibrillation. And the thing is, there's two things. Either it's indicated for pacemaker, so we given the patient a choice. And of course, you can talk with the patient whether she wants a transvenous pacemaker or she wants a leadless pacemaker. And of course, most of our patients, they are very concerned about the wound care because there is the family feel it may take a few weeks for old people to heal. It's very common in Hong Kong, and for leadless pacemaker, they favor it more. They just have a wound over the groin, and then the patient is discharged. And so the patient opt for the leadless pacemaker. So this case, we put in a pair of the device, a fair DR device, and the patient is able to afford it. And this is from eyes, you can see that the device is sticking it firmly on the atrial and atrial tissue. This is a fair AR device. And you can see in fluoroscopy, actually you can see that the atrial device has some slightly movement because it's attached to the atrium. Atrial contraction is much more, the degree of the movement of the atrium contraction is much more than the septal movement of the ventricle. So you can see that this double helix design helps to stabilize the device in the atrium. And so the workflow is simple. What I usually do is I do the ventricle first and then putting the atrium, which is because you have a backup and then you don't worry about anything happens during when you put in the atrial device. And so I think this is some workflow that you can take reference to. It doesn't take a long time. And so for the device performance, this patient is actually on table. The device, all the parameters is very good. And so we also look at the eye to eye. Eye to eye means that two devices can communicate with each other. And so usually when we want to achieve a good eye to eye, the distance of the atrial device and the ventricle device is ideally less than 2 times of the ventricular device. And in Asian, actually this has some advantage because our heart is smaller than the Caucasian. So usually our eye to eye is not bad. And for the angle, you probably can't control it too much, but most of the patient is okay. And this is the eye to eye pair-up result of this patient. I think is a very good result, perfect result with 100% throughput. And so it can spare a lot of energy and have a good communication. And so this is another case I want to share with you is sick sinus and with frequent admission for junctional bradycardia. Patients have dementia and recurrent DVT on NOAC. And this is actually as people ages up, and I think we are seeing a lot of aging population, and some of the patients have dementia. So I think leadless device have advantage in managing of this patient because they probably is less easy to cause wound problems compared with the transvenous device because sometimes they may remove the dressing themselves and they may scratch the wound and probably cause delay healing and also infection, which can be problems to us in the past. And of course, the patient also have a Holter showing the sinus bradycardia and sinus pause. And so this patient, because the financial concern of the relative, we just implanted a fair AR device. You can just implant one part of it, and the cost of device is comparatively cheaper than 2 devices together. And initially, the threshold is pretty high because this is all uncommon. Because it's a bigger device, it causes a lot of injury. So the initial threshold can be higher. But the next pay, you can see, is actually falling down quite rapidly. It's 0.5 at 0.4. And you can test with even a lower pulse width, and you can see that with 0.1 millisecond is only 1. So this kind of device is quite interesting because in the past, if you do a transvenous, you probably you think it may not be very good to have such a high threshold. But you have a lot of tips and tricks during the implant. But during the procedures, actually, even the device threshold is higher. It will fall down in most of the patients, and it can be quite I can say is excellent in many patients because you can see that it can use even a lower pulse width and achieve better patient capture. So, and it's already functioned when the patient was transferred to the monitoring unit and is already a pace rhythm with a conducted beat. And for six-sinus syndrome, you may argue that whether we put in one device or two devices. And I must quote you, this is a very old study. I'm not in that age, but you know, it's 1999. When in the past, I think people only arguing whether you put in one lead AI for six-sinus or you, in the future, you upgrade to a two-lead system, but you have a problem with the upgrade because you already open up the ring, you need to add the lead in the transvenous system. One of the tricks we use is we pace it at 100 beats per minute. And actually, it's already showing by, in this study 20-something years ago, if the patient have no grade 2 or more AV block, a surface ECG PR interval is pretty normal in patient less than 70 years old or a little bit longer, even in more than 70 years old, without any bundle branch block. If you do a one-to-one AV conduction during atrial pacing at 100 beats per minute, the chance of this patient having a requirement for upgrade is less than 1%. So we are kind of, we usually test the device as well. So we are pacing it 100 beats per minute. We look for any one-to-one conduction. If it's remaining in one-to-one conduction, then there's no worry. The chance of this patient having the upgrade is very low. And also, if you talk about the upgrade, you can just put it another shift over the same ground, and then you just put in another device in the ventricle and connect it up through the eye-to-eye. So you don't have to open the pocket and pass the wire through the occluded ring, and then you have to do all this thing again. This is kind of difference compared with the transvenous system. So I think this is a very big breakthrough because now if you see a patient who only need one device, and in future if the patient need another one, there's a possibility there for you to upgrade the device and connect it with an eye-to-eye system. And this is something that have never been able to offer in the past. And so we all feel excited about this kind of new technology when it's available. And I have two more cases to show you. This is another one. It's a complete heart block, and it's a more complicated one, but it's more indicated for leadless. Actually, you see the patient is 7-8 years old, hypertension, hyperlipidemia, diabetes, and he had the end-stage renal failure, which I think in Hong Kong is quite strange that we only had offered the peritoneal dialysis first strategy. But good or bad, in many countries, using the hemodialysis more. So in this kind of patients, we tried our best to save the ring, because if you fail peritoneal dialysis or if you are using the hemodialysis, you have been occupying the ring. And you all know that those patients have a higher risk of the infective endocarditis. So we try not to put in the transvenous system. And so this is something that we have been doing. In Hong Kong, we have some reimbursement or social backup for those patients who have the this kind of problems. They can apply social worker to get some fund for the leadless system. And this is a very difficult patient. He also have some sinus node dysfunction. The sinus rate on average is 77, 40-something beats per minute only. Together with there's some type 1 and type 2 ranking back block, and also on the holter, actually, there's also some intermittent complete heart block. So there's a whole degeneration or in the conduction system, and he is admitted for the sinus bradycardia, heart failure, and reduced exercise tolerance. And So we implant the fair DVR system, and this is how we get to the ventricle first, and we implant the ventricle. There's a device already in, and we get into the atrial appendage or the base, and then we put in the system. And this is how it looks on the 3D eyes. This is intracardiac echo, and this part is hard to imagine because this is not the usual way you look at the heart. And on the echo, the foreign body look differently because you can't see the color. You can't take the color differently with the metal, but you can see that this is very stable positions and it moves with the heart. So you can see that with successful implant is actually the device is sitting quite stable on the atrium, and so this is how it looks. It looks more. It looks a lot of movement on the atrium, but actually it's stuck on the atrial wall, so it moves with the heart. So this is actually quite a stable device. And you can see that the device is actually not far away from the atrial, and it's less than 2 times of the ventricle device. Of course, you have to rotate the image intensifier because this have some parallels issue, and so this is how it looks on the ventricle and atrium. The device is sitting well, and you can see that this is a ventricular device. It's also sitting quite well, and it's attached to the septal side. And this is the atrial side, and you can see that it attached into one of the bigger band in the right atrial appendage. And so with this pair of device, you can have extended programming mode that can be offered with this leadless options. In the past, if you have the micro AV2, you can have VDD, VDI, VVI, or VO mode. But because you cannot pace the atrium. But now you can pace the atrium with DDD, DOO, VDI. And of course, there are some changes in the rate response. It's a temperature-based rate response, and you can do a mapping prior to the fixations. And EGM recording is also available, and you get a pair of the device. They can have limited EGM storage for that. And for the AV synchrony, this is another study that was published this year. In the real-world setting, they do a Holter analysis, and so the AV synchrony can be maintained in 96.7% of the beat. So in most of the situations, you can enjoy a very high percentage of the AV synchrony in different heart rate as well. And for this patient, initially we set a VVI because the threshold is higher, but the next day the threshold improved significantly. So we open up the DDD mode, and you can see that the eye-to-eye setting is also quite good. It's 100% throughput, and so this helps us to save a lot of battery, because when you open the eye-to-eye, it causes some of the battery drainage. But for this patient, this is what he needs. And I think it's also better to have a transvenous device because than having a transvenous device, because this is an end-stage renal failure patient. We don't want to have the transvenous gelling on the ring. And so also one of the things is that sometimes you may not have extremely good eye-to-eye communication at the beginning, but it will improve over the time. This is another study published last year, and you can see that the proportion of the patients with eye-to-eye success is much higher after 6 months. So it takes some time to improve as well. And the eye-to-eye remain very good. It's 99% for this patient. And For another case is a case 4. This is also another challenging patient. Is a paroxysmal patient, but the burden for atrial fibrillation is much higher in this patient. 77 years old, she has 75% of paroxysmal atrial fibrillation burden with a definite conversion pause and a recurrent syncope. So this is another case that we actually it's quite a struggle because initially we talk with the patient, we try our best to put in 2 devices. So initially she was in sinus rhythm, so we went in quite straightforward, put in a ventricular device, but afterwards you can see the heart movement becoming quite strange on the ice. This is the beginning. This is after we put in the device, she developed atrial fibrillation. And the ventricle device is very good, and you can see a good injury, good impedance-wise, and so we deploy the device. So the other questions you probably will ask whether we should put in an AR device, and I think this is raised a lot of questions about how we approach the patient with a paroxysmal atrial fibrillation with intermittent pause. I think with the advancement in the ablations with PFA and also the dual energy platform you see before, and also other PFA platforms, we have greater success in maintaining a patient in a sinus rhythm. And even if those patients who have recurrence, their burden is much lower, and they can be managed with antiarrhythmics. And so nowadays, I think we have more emphasis on the rhythm control because I think you all know that rhythm control now, the balance tilt off back to 10, 20 years ago, rhythm control or weight control probably similar because of the antiarrhythmic side effect, because of the all the risk of the procedures. But now I think we have improvement in the ablation technique, and also improvement in the different option of the introduction of the Yoshifumi, which have a less side effect compared with other antiarrhythmic, a better control of the risk factor. So I think rhythm control has been one of the things that we try to offer to most of our patients. So, but if you give the medication, most of the time this patient will have bradycardia, and so I think if we can put in an atrial device, is the best. So there's 2 options. We can cardio work the patient. We can off the table. We can talk with the patient, upgrade later on if the patient have some problem in maintaining the sinus rhythm, or we can do a catheter-based ablation. And of course, one of the things is we talk with the patient, and she probably want to have an atrial device first, and we tried the immortal one, but it didn't help because she is kind of a little bit older. So we see we can do it without cardio version. So this is how we do it on the fluoroscopy. We try to identify the atrial appendage, and this is how her atrial appendage looks. And actually, this is the pig heart, and you can see there's a thicker at the base, near the base of the right atrial appendage. This is our target. And CEGM is something that we try to look at it, but sometimes it can be quite hard in patients have atrial fibrillations. But for this kind of patient, he did have some atrial signal at the target site, and we look at the eyes, we already meet the target, and but it's quite slippy, so we try to reposition it. And this is how the signals look when in the second position, and you can see if we push a little bit further. In the atrial fibrillation, sometimes the impedance doesn't change a lot. This is one of the problems. But the signal also have the injury current now. So, and with the eyes as well, so we are pretty sure that this is going to be a quite adequate tenting, and also the we don't want to perforate. So we we try to position it and in this location, and we look at the impedance-wise as well. So we are very confident that this is a very good rise in the impedance. There's good changes in the CEGM in this case, and so we deployed here. And so the end threshold on the table is converted is much better, is 0.5, and the sensing is good. And so you can see the device is quite stable, and but you know it's initially still went easily went into AF, and so we look at it overnight, and it converted overnight, and then it changed to atrial pacing. So you can see there's no more long pause after the transition from the atrial fibrillation to the sinus. So you can know that this device already functioned. And this is very good for the patients because pacing atrium is more physiological than pacing the ventricle if you have a sinus bradycardia. And the next day is actually the device is also having a very good parameter in terms of the sensing impedance, and also the pacing threshold is 0.5 at 0.2 millisecond. It's extremely low. So and now you have the new AI with a VVI backup mode, and this is something that is very useful. I'll talk about it in another slide. This is 1 month follow-up, and you can see that the injury went down a lot, and so the sensing is becoming better, and also they have a good threshold, and the patient mainly is atrial pace is 5% atrial pace, and the ventricle one can use a longer time. And of course, this is 1 month only. We will usually step down the voltage more on the 3 month follow-up after the acute phase, and the battery will even longer. So, the availability of the AAI with VVI backup, actually they reduce the need for the eye-to-eye communication in this mode, and it will improve the battery longevity. And especially now you can enjoy a longer device longevity in the ventricular device. Of course, the atrial one is shorter, but I think this is a very good move, and it also depends on the pacing percentage. And I think for younger patients, another challenges to us is also to decide which is the first device for them. And for the Affair AR device, there's some data suggests of retrieval after 3 years after the implant. But of course, we keep an eye on this kind of the data. But for young patients, it will spare them to have the chronic lead in the venous system. I think this is something that can help in reducing the future risk of the infective endocarditis, because sometimes, you know, the blood flow in the venous system is quite slow. So whenever you get bacteremia, then you have problems in longer run. So we have to look at it. This is the first generation device. We will have the second generation device very soon in coming few years, and I'm sure that it will have a longer and longer battery. So, for the future perspective, I think people are talking about how to do a physiological pacing with a leadless device. And I think we all fancy about this different kind of technique about restoring the atrial and ventricular synchrony. So people have been trying to use it for doing a Bachmann bundle pacing. I personally I don't have experience about that, but it has been well reported and has been practiced in some centers. And of course, the other thing is the design of the device is not for this kind of purpose. So you can have a risk of dislodgement if you do it not properly and probably this is something that we look for the data about this kind of new technique. on doing abutment bundle placing with the leadless device. But this is something that is exciting, and I'm sure that it will be turning into an exciting era in the coming years. And the second thing is lap bundle airway pacing. So whenever we talk about the leadless pacing, people are concerned that it's essentially you are just putting in the old ways that you put in transverse device near the apical septum. So nowadays, when we do a transvenous device, we probably will consider using a lap bundle airway pacing. And the company is developing the leadless options for the lap bundle branch area pacing. And this is the first in human study. And of course, you can say that there's only 1 in 10 patient that can achieve the sort of lap bundle airway pacing. But I think this is only the initial move. And so future is changing, and with further redesign of the delivery system and also the design of the NISS module, it will also get into the more role in the future. And I think this is something that we all already look for. And in the future, definitely the dual chamber physiological pacing will become the truth, and it's never a dream. But I think in the first part of the moment, we have the first generation now, the AFEA, AR, and DR extend the indications that who can benefit from the leadless pacemaker technology. And the eye-to-eye communication allow a high percentage of AV synchrony, and the AI with VVI backup also improved the battery longevity with new options that can be offered in patients who had sinus node dysfunction and intermittent heart block. And even patients have sick sinus, and you can also consider upgrade the patient with a dual chamber device in the future if they have the problem of the heart block after the first leadless pacemaker. I think the second or third generation will further improve this kind of technology and will make it even more physiological than ever. And thank you. Any questions?
Thanks for Professor Zheng's excellent talk and case sharing. Due to time limit, we can open one short question for audience.
Thanks for Dr. Chen's great talks. I have one question that we are excited for the leadless pacemaker merge with the conduction system pacing system. And do you think the leadless pacemaker merge the conduction system pacing can compare with the transvenous lap bundle branch pacing at the same QRS shortening and the same outcome?
Yeah, I think the next generation of the leadless pacemaker will improve this kind of problems because now the current generation of the leadless pacemaker for ventricle is not intended to screw in close to the conduction system. So it's still, you can say that it will be more similar to the conventional transvenous pacemaker putting in near the apex. But the next generation will allow you to screw through the septum. But there's two considerations. One is the patient's risk for the pocket and also the any risk about the infective endocarditis in long term. For example, patient may need to take immunosuppressant. Then probably they are better to have the leadless pacemaker. And if the patient have impaired airway function and also have need for the CRT, then you probably won't consider the leadless option at this moment. Maybe in the future, yes. But at this moment, the leadless pacemakers is only for the better AV synchrony in terms of the this kind of physiology is also very important. But in future, yes, it will kind of offering the option for getting into lab bundle area, because you need a longer school to penetrate the septum. So I think you also need to care about the safety, and also the catheter need to be designed, redesigned for such purpose. Yeah.
I think this is a good for or another option for patient, especially valvular heart disease. So it's a good device. So maybe time limit, we need to close this section.
I want to invite our Chief Dr. Wu Nanjun to introduce the first speaker. 首先，我邀请吴南君主任来介绍第一位 speaker。
Hello everyone, I'm Dr. Wu from the Division of Cardiovascular Surgery of奇美 Hospital. It's my pleasure to introduce Dr. Song Si-Xian to all of you. Dr. Song, I think he is the cardiologist at Taipei Veterans General Hospital, and he is very specialized in treatment of structural heart disease. During our TAVI team progression, I think we accept lots of guidance from Dr. Song, and I'm so impressed by his expertise and his experience. So let us give a warm welcome to Dr. Song Si-Xian.
And thank you, Professor Wu, for the kind introduction and having me here in this 30th anniversary of奇美Hospital. So my topic today will be the current status of tricuspid valve intervention in Asia Pacific region. We know that the tricuspid valve nowadays is no longer the forgotten valve. Why this is tricuspid in disease is very important is because the prevalence in Asia Pacific, which is quite similar as the Western country. On the right hand side is the epidemiological field study of in the United States, the Olmsted County, showing that comparing to the left side, a valvular disease indicated by the red line, the right side, the tricuspid valve disease indicated by the green line, actually is almost 2%, especially in the elder patient. Comparing to the left side image showing the China DVD study, which recruit patient hospitalized recruit patient hospitalized the patient, which among these almost 9,000 patients, 60% of them had tricuspid valve regurgitation, which is the second common valvular disease among these patients. What we have been the standard treatment for the TAVI for the aortic stenosis, which is only 5%. So tricuspid regurgitation nowadays is really a very common disease in Asia Pacific. Comparing to the Western, even we probably have the similar epidemiology. However, the assessment of the device is much different. The majority of the device is not really available in some region in Asia Pacific. And also in the Asia Pacific, our patients usually presented their disease in the late stage. They initially they usually reluctant to have treatment, but at the late time they presented with very severe disease. And also the reimbursement policy, the healthcare policy and the system is quite different. Majority of the Asia Pacific country, there was really no fully reimbursement for this device therapy. And most important is that the guidelines also have new suggestion for tricuspid the treatment for tricuspid regurgitation. In the past days, we only have class 1 indication for surgery is that patient who has concomitant left side disease. Nowadays, the guideline has revised that not only the patient can have surgical option, but also they can have transcatheter option. They share the same recommendation, 2A for patient with isolated tricuspid regurgitation. So what transcatheter device now we have in Asia Pacific? We have TEER device, we have focal annular plastic device, We also have orthotopic valve replacement and also heterotopic valve replacement devices. The availability in each region would be very different. The tricuspid triclip nowadays is most available in majority of Asia Pacific, in Asia region, Asia Pacific region. And also the focal annuloplasty device, the K-clip, is only available in China and also in Hong Kong. And also the valve, the valve replacement, heterotropic valve, the trick valve, is also available in Hong Kong, and also Thailand and Singapore. And in Taiwan, nowadays we only have one commercial available TEER device, which is the TriClip. What is the initial experience of the TEER device in tricuspid, in treatment of tricuspid regurgitation? This is the recent published data from 4 centers in Asia, from Hong Kong, Taiwan, and also the Thailand. The study recruit 106 patients, age around 75 years old, and 80%, almost 80% of them have functional TR in etiology, and 20% of them actually receive MIS-key, mitral clip device to treat tricuspid regurgitation. On the bottom left side, the figure showing that after the TEER procedure, 75% of the TR can be downgraded to equal or less than 2+. And also on the right-hand side, showing you that majority of patients will get significant symptom improvement. Regarding the 30-day complication, there was no mortality and no re-intervention, and also however, the single leaflet detachment is around 5%, 4.7%, which is a bit less than the 7% in triluminous study. So this is a case, 62-year-old gentleman, atrial fibrillation, heart failure, and torrential TR. The patient have very dilated right side chamber, and also have significant coaptation gap. So after procedure and even after 4 months, the patient before the patient underwent catheter ablation, we still can see the durable durable effect on tricuspid TR reduction. So what about the comparison between the surgical intervention and also surgical managed treatment and also the TEER procedure? This is data from Medicare beneficiaries showing in that within the 2 years, the 30-day mortality is much less in patient underwent TEER device compared to the surgery. But during two-year follow-up duration, there was a 60% reduction in mortality, which is not significant. However, you may appreciate that patients who can underwent a surgery will probably have much less surgical risk. But the data in Asia Pacific is quite limited. This is the data from my hospital. From 2010 to 2023, and there are 92 patients underwent isolated tricuspid valve surgery. Actually, 42% of them, 42 patients actually have infected endocarditis or cardiomyopathy who didn't need to have surgery. The average age is 56 years. The 30-day mortality is 6.5%. Compared to the TEER in 2023, in the first year that the TEER TriClip was available in Taiwan, we treat 39 patients, mean age 75 years, and no 30-day mortality. However, maybe the TR reduction might not as promising as the surgical intervention, but the procedure, the data also showing that the TEER tricuspid is very safe procedure. But not every patient can get TEER procedure. It's due to the limitation of anatomy and also the image. This is a very published score, the GLIDE score, to assess the feasibility of TEER procedure to have significant TR reduction. We know that one very important point is that it's all about the image. So the eyes, 40 eyes is not also really available in Asia Pacific. We know that Hong Kong have ICE, and also the cost is quite, and also device is quite costly. This is the data from Mayo Clinical at their early experience to do the tricuspid TIA with the ICE devices. You may appreciate that on the middle figure showing that actually the whether with or without ICE, the TR reduction is quite comparable. But I think they are also biased because when you have very poor image quality with TEE, you probably would decline to do the procedure. So when you have ICE, you can expand your treatment population. But some patients still have very huge unsuitable anatomy. This is a 72-year-old patient, heart failure, and very severe RV failure. So the patient also have significant hyperbilirubinemia. You can appreciate the gap is very large, which is exceeds 2 centimeters. But the patient have progressive RV failure and even we have this shared decision making that this anatomy is not suitable for the TIA, but given the progressive symptom and disease, they would like to have tried. So we probably have downgraded a bit, but still remain torrential TIA. And the worst is that the patient during the follow-up we saw the septal lift tear, so that the TIA even can be worse than before. So that only when the log swab can be conventionally available, we proceed the tricuspid procedure to eliminate all the TR. However, the patient, because of severe RV failure, the patient she is still alive, but she still have some significant RV failure symptoms. So when we treat the patient too late with the valve replacement device, the patient will still encounter very long and also challenging recovery phase. The feature of the log swab is quite promising. That the device has to leave the grasper, which can anchor on the anterior also posterior vein, and also have the anchor plate, which by using a needle, you can also anchor the plate on the ventricular septum. And the device also have very large atrial disc. So on the atrial side, it can anchor on the atrial side. So the 2014, the 1 year outcome of the transjugular log swab plus system showing that in this travel to study, showing that on the right hand side, the 30-day outcome pacemaker rate is only 2%, and also major bleeding is 0 compared to what we have known from the TRISCEND, the EVOQUE study, which have almost 25% new pacemaker implantation in naive patient, and also 10% major bleeding, which is very different. It seems that the log swab provide a more safe profile compared to EVOQUE valve. On the bottom top figure showing you that after the valve replacement, majority of the patient, 98% of the patient can remain have equal or less than 2 pulse TR after the procedure, and the 1 year mortality is only 4.1%. So I think the device is quite promising. But however, if the patient have really a severe unsuitable RV function, which may also be a concern about the post-procedure management. So therefore, there are also focal annuloplasty device, the K-clip, which mimic the surgical K procedure to have annuloplasty. The device is comparing to the TIA is much simple. The image requirement is much less. So therefore, it's mainly focused on treating posterior, anterior, lateral, and also posterior septal annulus. It have the screw-in. The procedure is like a screw into the annulus, and you can pull up the annulus and also clip the annulus, so which can make a focal shortening of the annulus to have annuloplasty. So you can have 1 or even 2 devices And the only disadvantage is that because the posterior, the lateral tricuspid annulus is quite close to the right coronary artery. So during the procedure, you have to monitor the right coronary artery flow. So the pivotal study of the K-clip also showing us a very promising TR reduction and a durable TR reduction. And at 1 year, 80% of the patient really have 1 or 2 plus TR. So on the slide showing you that the majority, the annular positive effect would be at the posterior septal and also anterior posterior annulus, which showing immediately after procedure, the diameter septal posterior and also anterior posterior has been shortened. So combine this annuloplasty device, which can extend our treatment patient. If the patient have very unsuitable tricuspid anatomy and also very severe RV failure as what I present today the patient, probably we can combine the 2 devices. You can use this is the proposed from Professor YYM showing such probably we can combine the 2 devices. You can shorten the anterior posterior and also the anterior posterior annulus, and also for the anterior septal regurgitation, you can apply the TEER. So combine the 2 devices, which might be extend our treatment patient, the treatment anatomy to have more wider gap, and even when patients have very severe RV failure, not suitable for valve replacement. The last device, the tree valve, I think some of you, especially our Hong Kong colleague, have already plenty of experience. But we, in our hospital, we only have conventional experience with conventional use. The device is not really treated tricuspid valve, but it can minimize the impact of the regurgitation into the liver and into the superior vena cava. So the procedure is quite simple, can be fully monitored by the fluoroscopy. It deploys the right superior vena cava valve and also the inferior. The data from TRIC Euro has shown that after the device, after the heterotropic valve replacement, although the device did not really mitigate the tricuspid regurgitation, but the patients still can experience significant RV and RA remodeling. So in the future, I think when the device availability is, when devices are all available in the Asia Pacific, I think the most important is about how we can define what is the so-called GDMT for tricuspid regurgitation, given that there is only limited data. I think nowadays the diuretics is the only class 1 indicated medication. So we probably need to redefine the GDMT, including the medication and also even including the catheter ablation or even the pacemaker extraction, reimplantation. And also we have to encourage our patient to have disease treated earlier before the RV failure. So in summary, I think the EPIC now has moved from the prior isolated cases from the conventional use experience to now we can have a really available device to start our structural heart intervention early. And TEER nowadays is the present. So majority of the country already have TEER. However, the TTVR is now in the accelerating phase. I think we are all looking forward to the valve replacement device. The next growth bottleneck, I think, would be the system care. It's not only the procedure. We have to, have a new treatment algorithm, including the GTMT, catheter ablation, and followed by either the repair or replacement strategy. Thank you for listening. Thank you.
Because we're going to have a panel discussion at the end, so we're going to move to the next one. Thank you. Okay, so I would like to invite the Vice President, Dr. Ying-Wei Xian, to go to introduce the next speaker.
Okay, I'm Dr. Ying from Zhenxin General Hospital, Taipei. It is my great pleasure to introduce the second speaker, Dr. Simon Lam from Hong Kong. Dr. Simon Lam graduated from University of Hong Kong in 2003, and he becomes an interventional cardiologist. Now work at Division of Cardiology, Queen Mary Hospital. He received his congenital and structural training in Frankfurt under Professor Hausiver, who is the master in this field, and he already become a master now. He is currently the leader of heart team in Queen Mary Hospital, and also in recent year, he organized the Asia Pacific Electrosurgery Working Group, and I'm honored to be a member of the working group. So we work together. Hopefully we can have some concept and development in leaflet modification. So let's welcome Dr. Lam for his talk today entitled Leaflet Modification Current Concept.
Thank you. Thank you, Professor Yin. Actually, you're my mentor and also a great teacher. So this is, my talk is about TAVI and leaflet modification. So we know there's a need to modify the leaflet before putting in the valve. Especially nowadays, we are catching a wave, or the wave is coming after a bioprosthetic failure, no matter it's a surgical heart valve or a TAVI valve. And the trend, no matter in US or in Asia, is increasing. We understand that there are lots of things which is unique in the Asia-Pacific region. For example, we had smaller valves. So when you put in the first bioprosthesis, it's already very small. So if you want to put the second one in, the problem is you have the original heart valve, the original leaflet will lift up. We call a new skirt. And it will block the coronary arteries. So when we analyze the CT, we look at different parameters. Essentially, it's all about the space around the valve. And whether we put the second valve in, it will occlude the ostium of the coronary artery. So this is the concept of new skirt. The first valve is okay, but you put in the second valve, the old valve, the skirt will lift up and become a permanent wall that blocks coronary arteries. So this is the reason why we may need to do something to open up or clear it so that blood can flow to coronary arteries. So just a little bit touch on what happens to our Asian patients. And this is one of the cases that we typically see, very small aortic annulus. The sinus is very small, the STJ is very small, the coronary height is very low. So even for this native patient, native heart valves, we may need to cut the leaflets before we put in a second valve. Secondly, if you put a surgical valve in, the anatomy becomes even smaller. So this is a patient that has a mitral fold put in. You can see after the putting in the surgical heart valve, when you analyze the CT, essentially there's not much space around that area. And the valve leaflets are typically thickened, and the coronary could be occluded if the valve leaflets lift up by the second valve. And in Asia, we also encounter a lot of use for valves that have the leaflets mounted outside, including the trifecta valve and also the mitral flow. These are the two valves that we called because of early degeneration. So there are a lot of need for considering leaflet modification. And for TAVI valve as well, because TAVI valve is usually contains a lot more metal to anchor around that area. If that fails, if you want to put a second valve in, not just the leaflets will open up and block the coronary arteries. The metal frame will also push away and become a lot of metals around that small area. So let's go to basilica. You may have heard this name, which is a well-studied technique for cutting leaflets. So usually you need, during TAVI setting, you may need additional access because you need to form a loop that catch the leaflets and externalize. You can go from right side and exit from the left side, or you can use the single access on the right side or left side using a dry seal so that you put all the catheters in. So this is the concept. So first of all, you have to make a puncture at the base of the leaflet. So just like this is a core valve, and we have a catheter that touch the base of the leaflet. You can see the fire, the light. It is the energy that delivered to the tip of an starter wire. And with that, the wire could pass through at the base of the leaflets. So you can see once again, we have to make sure with the guiding is, the tip is focusing on the base of the leaflets. And then the position is good, then we press the button, and then the wire can go through. So this is the cutting. So once you pass through and you form a loop, that circle, that embrace the leaflets, and you can see we applied tension. We have good insulation on 2 arms, leaving behind a small metal part at the tip of. Okay, you can see this cut. So this is a cut. It's not using scissors. It's not mechanical force. It's applied energy, and it goes laterally. It burns and it just split over. So there are lots of the technical detail on how to make the best practice for the basilica procedure. This is called flying V. You may notice this in the literature. Flying V is where you concentrate your energy. So once this energy is concentrated, the cutting will be more effective. And the 2 arms, the V, the 2 sides, are insulated by plastic. We call microcavitors, guiding, usually typically fine cross, so that it protects the surrounding structures from energy that applies. So you only cut at the very tip of the flying V, which is where the leaflets are. There's some terms called balloon assist basilica. So to maximize this effect, you can, first of all, when you have a wire that goes through the hole, then make a puncture, you first dilate with a coronary balloon. And when you make the split, it will make an even wider split. So this is one technique that we may modify. So let's go for some cases. For this patient had a failed bioprosthesis, and we put in a eFluid in. So this is the typical view that we want to use. If you want to cut the left leaflets, you have to turn your CT so that you isolate it. So on the right, on this picture, on the right side is where the left leaflet is. So when you do your guiding catheter, usually it's the AL2, you have to go to that sinus because you want to cut the correct leaflet. And then at the LV OT, you already cross the valve from the true lumen, and then you open up a snare. So the snare position have to be very precise and not down to the LV, because ultimately you want to have a puncture of the wire through the AL2 and go through the loop and externalize. You don't want to catch anything in between. If you catch the mitral chordae, then you will treat the patient's severe aortic stenosis, but you create a mitral regurgitation. So you have to be very careful. And this is the typical setting with the wire that go through the leaflet, and automatically it will go to the loop. So the choice of the snare is the size based on the LVOT, so that when the wire goes through, it won't escape elsewhere. So it will just go through the hole. And then you will start to externalize. You will catch it, and you will form this loop. This loop is go from the base of the leaflet, going down the LVOT and going up through the true aortic orifice, and then externalize. Then you have already this loop. And this is what we call flying V. The flying V is something that you made outside the body. You bend it, and the inner part of the V, you use scalpel to scratch it so that the external coating was gone. And then this is the best way to deliver the energy. Also at the end, we usually use the stator wire. The end, we need an entry point and exit point. The exit point is where the flying V, the tip is, and the back end of the wire, we also denude the coating so that when apply the diaphragm, the pencil there, and then we apply energy, then we go in with this less resistant area and exit from the tip of the flying V. So we make this and we deliver it to exactly where the leaflet is, and then we'll make sure the position is good. So make sure the tension is good, because sometimes difference between the inner curve and outer curve, when you pull, they don't move together. So we usually had before applying the energy, we had a visual rehearsal with the whole team, because usually we'll involve a fluxing of dextrose if you need. We usually do that, but it's optional. But if you do that, you need a lot of pairs of hands to coordinate. And then you prepared your valve already, so that once it lacerates the leaflets, usually it's not a problem, because you create a split in the middle, and then the aortic regurgitation that results from this cut would not be that much. But you usually prepared for the valve already. Anesthetist will prepare for medication administration. Pacing could be implemented. So just in case something occurs, we can be well prepared. So this is the pull. So we coordinate with energy, and then we cut. You can see that the leaflet that you can move suddenly with give way. That is a time where the leaflet was necessary. And then you followed by implantation of valve. Where we want to implant, where it is, it depends on the coronary risk plane. And you check the coronary artery. If it is okay, then you post-dilate. If in doubt, you can check IFIS. So this is the first case. The second case is a patient in a native valve with basilica. You can go deeper in detail. So we also open a snare in the LVOT. So this is a typical setting where we want to puncture. So you can understand the critical moment or the critical part is where you traverse. If you traverse randomly, when you make the cut, it's just a random cut, or cut a little bit the tip, or cut a bit the side. You want to cut at the middle, midline, at the base, so that when you cut, it split open in the middle widely. And also, you want to go to the left cups. If you use a L2 guiding, it points outside. If you just apply energy past your wire, it will go outside the LVOT, maybe to the surrounding structures, typically to the atrium or the vascular structures. So when you go that, and one thing we learned from Professor Yin is we can use a pigtail catheter. So this is a longer version of pigtail. You cut the tip so that once it points outside, but it go backwards, make a U-turn. And then you can titrate where you want to make the puncture. For example, you do injection here. You can see it's in the right sinus at the base. You can always move a little bit more proximal if you don't want to go that base. And then with that, you have a very stable system that with the wire that goes through the leaflet. So this is one typical example that you use a L2 guiding and you use a cut pigtail, or you can use a navicross if the angle allows. But in some situation, you may need to titrate or tailor-made your curve. This would help a lot, especially in patients with very small anatomy. So in this puncture, and then the wire will just go through the loop, is where we capture it. You can see it's a pulling movement capture in the guiding would go through the aortic orifice. It goes in usually typical PA guiding. And then the wedge would be similar as what we had for just now. So this is the cut. So you can see there's already a pigtail inside the LV. So we're already prepared to put in the valve in after the laceration. And every case of us will be TE and GA guided, although in very experienced centers you can skip, but I will rely a lot on the imaging. For example, where we traverse, where we form the loop, is there any holding or catching the mitral apparatus? When we make the split, is the split correct or effective? We can see this is on the right upper corner with this short axis is the left leaflet. You can see the split afterwards. And also you want to detect complications in case it goes. Once the wire is put in, you want to check where the wire is. If you cannot see the wire in the LVOT or the LV, then you may need to have a high degree of suspicion it goes elsewhere. I think it's most about safety, accounts for 80%. 20% is effectiveness, but I think safe is important. So then you will carry on with your valve implantation. I think a lot of the time, if they're really low coronary height and high coronary obstruction risk, a shorter valve may help, because in case you want to reaccess the coronary for stenting or IFIS assessment, a shorter valve that may help more compared with a supraannular self-expandable valve. So this topic is about basilica, but a short touch on unicorn is about another concept for intraleaflet deployment of a sapien valve inside the target leaflets. You will also have a puncture at the basal. The initial step are same, but you use a balloon and with a it's not upfront lacerate the leaflets, but we want to have intraleaflet deployment. And so this technique will be simpler. You just need a E-sheath on one side without the snaring and externalization, and just show you the concept. So you had a guiding catheter with the wire, no matter it's a transversal wire, is a Estado or is a versicross, you just have a good contact. Usually if you've done a transeptal puncture, you know you need a good contact and tenting. We always want to achieve that before you puncture, because sometimes when the wire or the needle slipped, it may go to an undesirable point. So this is very quickly just what we meant by intraleaflet deployment of the valve. So on the right side, you can see the sapien was directly implanted inside the leaflets. And during the deployment, so the leaflet was all pushed to your side without catching on or road embolization. And important key facts is you need the precision on the leaflet transversal. If you just transverse at the edge, if you make the balloon, it will upfront lacerate. If you're not at the base, the leaflet, if it's not enough length, they cannot take up the balloon. So secondly is a careful manipulation of a coronary balloon and followed by the peripheral balloon, usually a 12 millimeter. And so there have been different steps. Why we mention unicorn? Because sometimes they go hand in hand, just like in this case. As a patient with a failed sapien, you can see that the initial reason for choosing a short valve is because the patient had already very small annulus, very low coronary height, high-risk coronary obstruction. You can see that, maybe you look at the right lower quadrant, you can see the metal already occupy all the space, and the upper edge of the metals are all above the level of the coronary arteries. It's also on the other side, on the left upper corner, upper picture, you can see this is where the opening of the left main is. When you open up the second valve, then there is risk of coronary obstruction. So we also look at the VTC, for example, the lower picture, you can see when you expand, then the high risk of pushing the leaflets towards, or the frame overexpand to cover the coronary ostium. So for this case, so we do angiogram. For us, angiogram is the best way to appreciate the picture, because CT scan, something look at it, but if you're interventionist, we always look at the angiogram to see the space around, how we will save the patient in case something occur, how we go for the leaflets. It gives you an overview, and this patient is a combined AS and AR as a degenerative mode. You can see the AR with the end injection. And so just go to different angles to plan our procedure. So this patient will be a basilica to the right, you can see. Right is more challenging than the left side, but with standard practice, you can go see it goes through the loop that we open in the LVOT nicely, and followed by externalization. You can see how the loop catch the wire. So it's not a running and catching, because if you move the loop around and find a wire, catch it, you will go to different directions, go to the mitral quality, go up and down. So you don't want to do that. You want to just open up there and the wire go in and catch. So this is the way to do it. And then next we will do the flying V, prepared before pulling, and then this is the unicorn to the left side. So this is we usually use versicross, but using a starter is also good. You just point to the base and go down. With coronary balloon and peripheral balloon. So this peripheral balloon you can see is on one side. It's not in the middle. So you somehow find the balloon move to the side, which means you accelerate the leaflet. So you have to carefully choose the correct balloon and puncture at the base, so that you maintain this intraleaflet deployment. So this is where the intraleaflet deployment is. And then upon deployment, suddenly you have a giveaway. So which means you leave it fully open at that side, but you simultaneously have the stent already covering it and catching all the leaflets without going overhang or going embolization. So finally, the result usually is good, but is perhaps will be limited at this time for balloon expandable valve. So this is the difference between Basilica. For clinical data, Basilica has more clinical data. The Basilica trial, which is experienced on US, European trial is also published with good results. Longer term result will be 1 year results from US trial. And there are also comparative results when you do, what about you do TRIMI standing? Would that be easier, better, or would it do worse, or you should do upfront laceration? At least at this time, both techniques will matter as upfront laceration or TRIMI standing or comparable. And unicorn is a more new technique, but there have a lot of been case reports for occasions. We also had our new inventions, new techniques on how to do it safely, maintaining near simultaneous deployment intraleafletly with self-expandable valve. And so we also published our initial registry in Hong Kong, which initial results was good. So the dedicated device will make life easier. For example, shortcut. So if you do bilateral leaflet modification, what if you have a mechanical scissors that cut the leaflets? You just have a catheter that go through the orifice, and then you make this configuration and cut and rotate and cut. So this is maybe a easier solution in the future. There are a lot of other devices like Telltale. It simplifies the preparation of the denutation of the wire, flying wheel management. So these are also promising device. and the more aggressive leaflet cutting devices. But the more aggressive it is, then you have to make sure you stabilize the patient during the AR, if the hemodynamic significant AR occurs. It's difficult to say which is the best algorithm to choose which strategy for which, but for us, I think planning and heart team discussion is important. For us, I think native, predominantly we do basilica, although it can be done with unicorn, but our preference is still basilica, because usually the leaflets align quite good with the coronary arteries. If isolated left and we do basilica, if VTC is towards 0, you really want a big clearance, then you would use unicorn. Right side usually is less user-friendly for basilica, and probably you can use unicorn first or basilica as a second choice. If it's misaligned, because for basilica, it cut in the middle. But if the coronary opens at the side, because especially for TAVI valve, initially they randomly rotate, not unlike surgical valve that where surgeons look at the valve and turn to correct alignment. So if it is malaligned, you may need a better clearance, then you may need preferred unicorn. If both are at risk, you can choose whatever you want, double basilica, unicorn plus stenting, unicorn plus basilica, depending what the team experience and what are in the toolbox. For us, we do exclusively current protection, IFAS assessment after all the cases. So in general, I think this is a new field, but I think it's something that we cannot shy away with because the real need for that. But always know about the limitation and know the device that you want to cut or the leaflet you cut, and have a full understanding instead of just focusing on how to implement the procedure. And the evolving technique would be how standardize the process and training, and also there had been collaborations around Asia Pacific region in the collaboration under the transcatheter electrosurgery work group. So I think this is my last slide, and if you have time, please join the Hong Kong WAF in October. We can learn together and share experience together. Thank you very much.
Thank you for Dr. Lan's inspiring talk. Because we have the panel discussion at the end, so I'm going to invite the next moderators, Dr. Li Qingwei from Taipei Rongzong.
Okay, so it's my great privilege to introduce the next speaker, Dr. Shi Zhiyuan. Dr. Shi Zhiyuan was graduated from the National Yangming Hospital, University, yeah. And he had complete training in the Kaohsiung Veteran General Hospital and the Chimay and the National Cheng Kung University Hospital. So I know him very well, and he is what we call very hard operator. We call it hybrid operator. He is performing very good imager and as well as the intervention. And he was very, very kind and generous. Most of all, and the important thing is he's very kind and generous. I have a privilege to join the operation in Chimay, and I saw him lead the team fantastically perfect. So it's my great. So let's give him a warm welcome for the topic about the transcatheter mitral valve intervention. Thank you.
Thank you, Dr. Lee, for your kind introduction. Good morning, everyone. I think allow me to speak Mandarin because I think today is a very good chance to communicate with all of us that were interested in heart care. 而且我注意到这个，对不起，我讲中文了我注意到这个翻译软体好像不如我们想的这个效果那当然最主要还是我的中文比英文好了所以我想我用中文跟大家做讲解那谢谢大家。那今天我的题目呢是二尖瓣膜的这个处置mitral valve 的 intervention。那其实，在听了刚刚的很多这个主动脉瓣膜还有这个三尖瓣膜的处置，其实大家知道说，我们这个心脏科在结构性的心脏病、瓣膜性的这个治疗呢，其实这近期的进展很多了那二尖瓣也是其中的一个进展很多的地方那这是我今天的 outline 我希望这个中翻英它会好一点这样那大家知道二尖瓣膜大家这个想象中就是两个门片我们有一个前叶有一个后叶那事实上这个事情不是那么简单。这一整个二尖瓣它其实是一整组的东西它有瓣叶，那它有 caudate， 它有 papillary muscle。 还有一个 annulus 哦，那甚至整个 LV 的这个 geometry 都会影响这个 mitral valve 的function。那甚至在我们做 intervention 的时候，它也要注意到，它事实上是一个非常3D 立体的结构，像一个马鞍形哦，所以事实上也不是一个圆圆的一个圈圈，然后上面2门片这么简单哦。那所以我们在做这个 mitral 的 intervention 的时候，我们有相当多的这个考量哦，针对不同的疾病，我们有不同的武器。那最简单的，我们一张slide就可以解决，就是 mitral stenosis。那这个最常见的呢，还是一个 rheumatic heart disease 造成的，就是风湿性心脏病哦。那它常见的呢，如果这个比较 typical 可以处理的，大部分是在 tip 的地方会有 fusion 哦。那所以在现在的概念，它还是一个 Class 1的 gold standard 的 treatment 哦。如果这个 anatomy 是合适的话呢，我们是以这个 balloon 的这个 commissurotomy 哦，就是我们叫 PMC 来做这个 valve 的 dilatation 哦。那另外要注意到是说，近期在我们以前当学生的时候 ，mitral valve area 是小于1平方公分，叫做 severe 哦。那其实近期我们都修正成1.5平方公分以下，就认为是 severe。一旦合并症状，事实上就要做处理哦。那另外说，我们在 AF 的治疗里面呢，我们近期都喜欢用 DOAC 哈，就是比较新型的口服抗凝药。不过呢，如果病人一旦有 rheumatic heart disease，mitral valve area 呢在2个平方公分以下，就是 moderate 以上的严重度哦，我们事实上是建议 warfarin 优先的哦。所以 DOAC 在这个情况就比较不合适。那我们接下来讲 mitral 的 regurgitation 哦，就是二尖瓣膜的逆流哦，闭锁不全。那讲到这个，刚刚有提到说二尖瓣膜的结构相当复杂哦，所以其实我们在治疗这样的疾病，我们会去跟它做分类哦，会分成所谓的 primary 的 MR 跟 secondary 的 MR。primary 就是说瓣膜本身有问题哦，比如说上面有穿孔哦，或者是有脱垂哦 prolapse， 或者是有 flare。那有这样的疾病呢，或者是有 rheumatic heart disease 影响到这个 mitral 的合闭，这个时候我们叫 primary 的 MR。那 secondary MR 是什么意思呢？是这个 leaflet valve 本身呢，它没有太大的问题，比较大的问题是可能有 annulus 的 dilatation， 或是 LV chamber 的 dilatation 呢，造成它的 coaptation， 它的闭合不好哦，这个叫 secondary MR。那either它是一个 ischemic heart disease， 或者是一个所谓的 DCM 这样子哦，这个会造成所谓的 secondary 的 MR 哦。那我们一个一个来讲哦 ，primary 的 MR 怎么治疗哦？其实外科医师永远是我们整个 heart team 里面的这个很重要的灵魂哦，很重要的好朋友。primary 的 MR leaflet 本身有问题，我们最建议的方式还是找外科医师做 surgical 的 repair。那近期我们有经导管的方式 transcaster， 就是刚刚在3尖瓣的地方，宋医师有做了很多介绍的所谓的 edge to edge repair 的 clip 哦，它可以把这个 prolapse 或是 flare 的地方呢做夹合。那当病人呢不适合去做手术，那他的这个手术风险很高的时候呢，事实上这样子的这个 edge to edge 就是 TEER 呢，它其实已经是现在是 Class 2A 的一个建议哈，它也有相当好的效果。那当然是比不上外科，所以它是 2A， 但是也能够让病人有一个相当好的选项这样子。那另外就是说，在 mitral regurgitation 二尖瓣逆流的治疗，现在也尽量把它往前推进。即使是没有症状的这个severe MR 的病人，在去年ESG 的概念也建议说，如果他有其他合并的一些表现，认为呢手术去治疗也是一个建议的方式 ，Class 1的 recommendation， 包括肺动脉高压，包括 AF 的产生，或者是说他已经有 LA 有 dilatation 或者是已经合并有中度以上的3尖瓣逆流这样子。那这个是一个87岁的男性哦，那他有 A1、A2 的这个 prolapse，A2 比较厉害，然后那大家可以看到 MR 相当厉害。那我们用了2个 clip 呢，能够让他的 MR 得到相当好的 reduction 哦。那87岁的男性这个外科医师也没有想开刀了，然后所以我们也没有就是跟外科医师这个抢饭碗的意思这样子哦。然后这个所谓的 secondary 的 MR 哈，现在也会做比较详细的分类了哈。这个我们会把它分成 ventricular 的这个 secondary MR， 这个导因于 LV 的 dilatation 造成我们的这个 leaflet 呢被往 ventricle 拉，有这个 tenting 的现象呢 coaptation 变差哈，这个叫 ventricular 的 secondary MR。那另外一种呢是 atrial 的 secondary MR 哈，通常是一个 preserve EF 的 heart failure 合并 AF 跟这个 LA dilatation。 最主要的 mechanism 呢是这个我们的 mitral 的 annulus delay 造成它的 LV 的闭合不全所以细分这2类，主要是说在治疗上的考量可能不同那我们以这个 ventricular 这个 secondary MR 来讲那因为这些病人很常合并心衰竭，然后这个左心室有扩大，所以我们的治疗呢，最重要的还是心衰竭的治疗所以在团队里，心衰竭的专家很重要所以我们给他所谓的 GDMT， 让他的这个心脏功能改善 ，MR 有机会改善，或者必要的话放 CRT 这个也需要 EP 的专家一起合并。那当然在这样的治疗之下，如果他的 MR 还是很厉害呢，我们这个 H-to-H repair 的这个 TEER 呢，其实也可以带来相当好的效果。大家可以看到，在之前的这些 trial 里面，所谓心衰竭合并 severe MR， 我们做的 meta analysis 可以看到 ，TEER 的这个治疗呢，比起 medical treatment alone 它可以降低病人的 all-cause mortality， 降低他的心衰住院率所以在目前来讲，这样子的这个病人呢，用 TEER 来治疗，它是一个 Class 1的 recommendation 那这个是一个 LVEF 只有30几的一个49岁女性那当时的 MR 相当厉害，那我们用了一支这个 clip 呢，让她的 MR 做很好的 reduction， 那这个病人之后就再没有因为心衰竭住院那我们讲到 Atrial 的这个 secondary MR 那其实这个是在去年的 ESC 概念比较明确把它提出来那它的 mechanism 刚提到，可能主要是因为这个 annulus dilatation， 常常是合并 AF 所以治疗的 strategy 可能会是以 reason control， 尽量以 control 它的 AF 为主。那如果说它的 MR 还是厉害呢，它的治疗可能就是以 surgery 优先建议。为什么呢？因为 surgery 可以做到比较好的所谓的 annulus reduction， 然后呢可以把它顺便做 AF ablation 跟 LA appendage 把它做切除，做 isolation 这样子那这个是目前 Class 2A 的建议是 surgical 的这个 treatment。那 TEER 呢，在这里事实上可能也有角色了，但是 evidence 不多，所以目前是摆在 Class 2B 的这个建议。那当然，待会 panel discussion 也请教各位做结构的专家在这方面的看法跟经验这样子。那所以如果我们用这个比较清楚的图表来看的话 ，ventricular 的 secondary MR、GDMT 我们心衰的治疗药物优先。如果还是有厉害的症状呢，我们是以 TEER 呢做优先建议。那如果是 Atrial 的 secondary MR 呢，目前以 reason control 这个控制它的这个 AF那当然如果还不行的话 ，mitral valve surgery 呢也是另外一个比 TEER 来的优先的建议这样子。那我们近期在所谓 valve involve， 就是说有些病人过去已经开过刀换过生物瓣膜，或者是说已经做过 repair， 那有个 ring。那可能他有 recurrent 的 MR 或者是 valve 已经 fail 这样子那在治疗上呢，当然我们可以在 redo surgery 那但是有很多病人的风险过高，所以事实上我们现在也有方式用导管的方式做 valve involve 的这个 treatment 特别是在高手术风险的病人那这个 transeptal 的 mitral 的 valve involve 的这个 TMVI 或 TMVR 它其实现在已经是一个 Class 2A 的 recommendation for high risk 的 surgery 的病人。那但是 valve in ring 这个就比较高的这个风险这个术后的 outcome 相对差，在一些没有选择的病人呢，它当然是一个可能可以做的一个处理了那但是这个预后呢，相对来比 valve in valve 来的差一些那这个是美国的 mitral valve in valve 的这个 real world 的 data， 可以看到说，其实在1年的追踪呢，绝大多数的病人，超过99% 的病人都可以维持在 mild 的这个 MR。pressure gradient 呢，事实上也都相当低不到5的毫米汞柱。那1年的 mortality 呢，根据不同的 STS 有不同的表现那这个是一个做过 double valve replacement 的一个63岁女性，那她的 STS 就是手术的风险相当高，有到20%。那所以呢，在当时她甚至合并severe的 TR， 然后已经这个 liver 跟 kidney 都有 acute 的这个 failure 了所以当时我们跟她选择做 transeptal 的 TMVR 那当时手术是相当成功，病人术后呢也恢复，不过 TR 还是厉害，所以后来我们还是多做了一个这个 Lux valve 的这个置放就是3年半也一并处理，那这个病人恢复得还不错这样子那考虑到说有 valve in ring 的需求，那事实上在 surgical 的 ring 的这个研发上，他们现在也开始做一些未来呢适合可以做 valve in ring， 可以把它撑得更远，减少旁边的这个 probable 的这个 立刻的机会了哈，让手术 outcome 更好。所以这个已经有所谓的 lifetime management， 就是去思考到病人未来的治疗选项这种思维在里面哦。那有一些病人他是二尖瓣逆流，但是他的 mitral 的 annulus 哦，就是他的瓣环有相当厉害的钙化。那这个时候呢，除了手术治疗以外，手术本身的风险事实上也是高了哈，所以其实这些病人很常是共病多。那所以呢，也可以用导管的方式做所谓的 valve in make。那但是大家知道说，这样子的一个 population 在过去用 off-label use， 我们用 balloon expandable 的这个 valve 去处理，事实上是可行的。不过它的这个 success rate 跟后面的 complication 呢，可能还是需要更多的 data 的追踪哦。那特别是刚刚提到的这个valve in run的这些 data 是相对是比较不是那么好。那另外就是说，因为这一群病人他的本身的瓣叶还在了，所以当我们放一个新的瓣膜的时候呢，要注意到的是 LVOT 这边会 obstruction 哦。那这个时候就可能会用到刚刚 Simon 介绍的这个所谓的这个用电烧的方式来处理瓣环哦。那我们近期比较有进展的是说，如果要置放一个瓣膜在一个native 的 mitral 的 disease 上呢，其实我们有一些现在比较transcatheter 的治疗哦，都已经陆续有 data 了哦。那这个是在去年的 TCT 发表所谓的 10-dyne valve 的一个置放，它是从 transapical 就是从 apex 置放，然后放一个新的人工瓣膜在这个二尖瓣的位置。那可以看到它的 primary endpoint 它的这个 all-cause mortality 跟这个 heart failure 的这个 admission 哦，它事实上是有达到它的这个 primary endpoint 的这个需求了哦。那而且在1年的时间可以看到97% 呢都可以维持在很好，没有mile以上的这个 MR 哦。那另外一个也是很有未来的，这个也是一样在去年的 TCT 发表的1年的 result。这个是 Sapien 的 M3 的 valve。那这个瓣膜跟刚刚 10-dyne valve 它的置放不一样哦，它是用 transeptal 的 puncture， 所以我们可以走 femoral 的这个 femoral vein， 然后一路上到 RA transeptal puncture 去处理我们的二尖瓣膜。那当然比起 transapical 来讲，它的这个侵入性就比较小。那大家可以看到1年的 all-cause mortality 大概只有13% 哦，然后这个 heart failure hospitalization 只有16%。那很重要的是说1个月的 mortality 哦，因为它的 STS 平均大概是6% 以上哦，所以看起来呢，它其实可以达到比其他预期的这个死亡率还要大概只有1/10的死亡率了。所以这个在合适的病人来讲，它其实也是一个效果相当好的选择。那1年的追踪呢，它的 MR reduction 可以到维持在96% 左右的这个在 mile 以下了哈。那这样子的这个 transcatheter 的这个 valve 的 implant 呢 ，mitral valve implant 事实上还有相当多的 device 在进展哦，所以我想未来是相当可以期待哦。那刚好提到说这样子的术式，我们要注意到的是这个 LVOT 的 obstruction 哦，因为我们正常的心脏收缩期的时候 mitral valve 事实上是关闭的 ，LVOT 是通畅的哦。那我们用一个 transcatheter 的方式放了一个新的瓣膜 ，Livlet 呢就会有可能会阻挡在我们的 LVOT。那不管是 valve in ring 还是 valve in make， 甚至我们 site 做的这个 valve in valve 的这个 procedure，Livlet 造成这个 LVOT obstruction 呢，都是相当要在术前评估的时候要去考量到的哦。所以刚刚 Simon 讲到的方式。那包括这个在二尖瓣这边类似 Basilica 的像 Lampoon 或者是 Cliff 的这个方式，也都是在整个 Heart Team 的考量治疗的时候都要去思考到跟具备的能力。那这个是宋思贤医师来指导我们在做所谓 valve in valve 的时候，有一个这个 LVOT obstruction 比较高风险的病人呢，那我们在这里做了一个所谓 tip to base 的 Lampoon， 就是用一条导线。那刚刚 Simon 也讲到的这个 Flying V 的一个通电的导线哦，那我们把它做一个撕裂开来，做一个让它有个撕裂的动作，减少 LVOT 的 obstruction 哦。那我们 transcatheter 二尖瓣的治疗也有很多可以处理的事情啊，那包括刚提到说有些术式可能会 parabolic leak， 或者是过去 surgery 过后呢，它现在在 valve 旁边呢有侧漏，这都容易造成溶血，造成心衰竭哦。那很长这些病人是高风险。那所以我们也可以用导管的方式呢，把这个侧漏呢做封堵了哈。那这个是近期这个做的 case 哦，74岁的男性之前 double valve replace 哦，那大家可以看到他这个机械瓣膜旁边呢有2个很厉害的 parabolic leak 哦，所以造成病人溶血，一直定期要输血哦。那我们也是很成功的跟他做 occluder 的置放，那病人目前就没有在住院哦。 那所以我想这些术式，不管是在任何一个瓣膜，所谓的结构性心脏病，现在非常重视的就是 Heart Team 的 approach 哦，所以包括内外科医师，那甚至刚刚提到的心衰竭 EP 的这个专家，或者是麻醉科，那还有影像医学科，我们在术前做很好的评估，包括 3D 的 T， 包括 CT 的评估呢，我想是一整个术式能够成功的一个很重要的关键哦。那所以最后的 summary 就是说，其实在现在的一个 transcancer 的年代，我们很多 valve 的 disease 都可以治疗。那我想前提是事前很好的评估，做针对病人做最好的这个建议哦。那 TEER 是一个现在非常成熟的一个技术哦，在不管是 primary 还是 secondary 的 MR， 我想很多 site 都有具备这样子的一个经验哦，特别是 high surgical risk 的一个病人。Atrial 的这个 secondary MR 是一个目前比较特别 data 比较多，大家有待多一些研究跟经验的一个领域哦。那所谓的 valve make 或者是 native valve 的一个 implant 哦，这个都是我想未来很值得期待的领域。那以上报告好，谢谢大家。
感谢施主任很精辟的说明跟演讲。那等一下，我们想要邀请所有的 moderator 跟 speaker 可以到台上来，我们大概有10分钟的 panel discussion. So we're going to invite all the speakers and moderators get on the stage. We're going to have about a 10 minutes discussion.
那谢谢大家参与哦。我想听完以上几个 session 的这个演讲，不晓得各位有没有问题要做讨论？如果没有，通常拿麦克风的都要问问题哦。那我先请教这个宋大夫哦，就是说，刚刚您秀的 case 相当精彩，3间半的治疗，我们现在选项相当多，所以我知道宋医师在 clip 上有相当好的这个技术跟经验哦。那但是我们也会看到说，因为3间半至少在我们 side 认为它的这个复杂度事实上是比2间半高哦，所以在做 clip 的技术跟影像的需求很高。那不晓得宋大夫在这个夹合的经验，像刚刚这一例说，我们还是有可能会失败的时候，那这个时候就是效果不好，我们需要用到类似 Lux valve 这样的一个治疗。那会不会遇到说，因为有了 clip 呢，我们后面在做 Lux valve 的置放呢，会增加困难，或者是说有什么我们要再处理的地方？
目前看起来应该就是如果真的放了，第一个还是要慎选病人啊，因为刚才那个病人其实是因为没有治疗，所以也其实是在门诊室 decline， 然后也又过了半年，因为越来越严重，想说让他 more than torrential 变成 torrential， 看会不会变好。那当然是看起来就是那个 tension 太大，因为它的 gap 真的太大，所以这个当然目前就是 aggressive 的这个 diuretics 就 pre-procedure 很那个积极的用一些利尿剂，看能不能下降。但是这个病人用了他就降嘛，因为他已经太 gap 太大，我想大概不是一个几乎是个 common chamber， 所以他的 RA 跟 RV 的压力是 equal 的，所以在之前术前评估就是这样，所以不是很适合。那这个去做 valve 也担心，就是后来才担心说这个 RV failure recover 比较难，所以我觉得第一个还是选适合的 case。那第二件事情是 image， 就是 image 应该是最重要，因为现在的 T image 可能大家有时候没有经验，等有经验打得好的时候，尤其是 transgastric 打得好，那 gap 是在 acceptable 范围。我觉得目前 gap 如果在1公分以内，大概要做到好会，如果那个 anatomy 不是很复杂的话，大概都不是太有问题。因为3间半很大，那你可以用多一点的 clip， 那这样原来可能超过1公分的 gap， 事实上就可以去 deal， 就没有那么的困难。那接下来就是 image， 因为如果在 Grasp view 传统的我们做2间半的 Grasp view， 你在3间半的位置看，都是完全就是 offline 的 off axis 的 image， 所以你那个 X plane 看到的 valve 跟看到 leaflet 跟看到的 clip， 它其实不在同一个平面上，所以你那个夹到夹不到是完全没办法看的，所以 eyes 可以解决这个问题。那否则就是 TEE 的 multi view， 如果 image 很清楚的话，multi view 也会解决这个问题。那当然，如果 image 有时候做到后面 image 都不够清楚，那你其实单一个 transgastric view 也可以解决这个问题。所以我们现在事实上做 procedure， 当然还是要注意啊，就是 procedure 几乎都是 rely on 一个 transgastric view 就可以去做 leaflet grasping， 可能不需要去真的上到。那除非 image 真的都不太好，那当然 transgastric view 打得好，它确实要有一定上的难度了，所以我觉得 TEER 因为现在 disease 很多病人都很晚才来治疗，所以 gap 都超大，所以很多你就会考虑要用到 replacement。但是其实 replacement 完之后，病人这个 recovery 我觉得也是还蛮辛苦的。所以 early 就是能够提早治疗，应该我觉得 TIA 本身应该看起来还蛮 promising 的。
我想要回应一下，这个就是那个施主任的演讲，就讲到 atrial 的 secondary MR。我不知道这个就是奇美的心脏外科团队非常非常强大了。那也想问问看外科医师的意见，因为 atrial secondary MR 有时候通常还是会合并，有时候病人会 severe MR 跟 severe TR。那重点是开进去，如果做两边的这个 annuloplasty 的话，如果我们真的算 STS score， 其实风险真的是比我们想象中来的低蛮多的。所以我不知道而且如果 surgery 的 intervention 还可以做 LA 的 volume reduction， 心脏会变小，这好像有很多的额外的 benefit。所以我不知道外科医师对于说这个 atrial secondary MR 的看法是怎么样，这样子。
要开的话欢迎啊，这样子。但外科就是我们大概外科的手术上，最近其实。当然，今天的研讨会的着墨点比较都是导管的治疗，但其实，在外科手术上面，我们的2尖瓣跟3尖瓣也有很多新的东西可以用的，包括3尖瓣最近我们也有很多新的这个 device 来治疗。那当然，对于大部分的人，其实我看到这个 MR、TR 的病人，我们大概还是会在我们医院基本上还是以2个瓣膜的修补为主。那对于3尖瓣的话，也会比较更多的使用就是 artificial coda， 好，再加上这个我们最近都是比较用这个 tricuspid physio 的 ring 来做3尖瓣的这个 repair。所以，基本上我觉得，除非是病人真的很高风险不适合手术啦，否则我觉得还是外科手术开进去看到的实际上的这个 structure 还是直接修补会比较好。其实3尖瓣这个大家可能觉得 moderate TR 在大家看起来好像小，实际上你在手术中看到的 moderate TR 其实相当大。就是假设病人 moderate TR， 你在手术中用 bulb syringe test 的话，你看它的漏出来的血量其实非常多。其实我觉得，如果可以尽量把这些regurgitation 把它修复好的话，我觉得对病人的 outcome 会好很多。
OK， 我想 Simon 应该听得懂中文。
可以。
But my question is that for those patients with severe RV dysfunction or pulmonary hypertension, the right heart intervention is really difficult. The patient has a slow or tough recovery period. So what's your tips and tricks in dealing with this kind of patient? I saw that in Hong Kong you use PA denervation to lower down the pulmonary artery pressure. Is that a good way to go?
是如果肺压太大，所以一般来说是 exclusion， 就是不做这个3尖瓣的手术。外国有的 case 上面说是可以先用那个药物或者是消融术那个 denervation 去看看可不可以把那个肺压力降低一点再做。不过这个没有一个很好的长期的复诊的临床数据，所以我想可能我们要再看看有没有临床的研究可以做多一点。不过有时候我们现在还是避开不做只是病人，因为还是那个 predictability 是一个很大的问题。不过我们也是研究是正在进行，是这个 denervation 的方法去把那个肺压降下来。有时候看看它是可能首先它会降下来，会不会在一段时间之后，他可能要上新，所以还是要比较长期的数据才可以做一个结论。
那我有个问题想要问 Dr. Simon， 就是说我们在做 Unicorn 的时候，有的时候我们 peripheral 12 ballooning 之后，如果我们是本来就很小的 bioprosthesis， 东西其实有时候很难，还是推不过去。那我不知道，就 Dr. Simon 做很多 Unicorn 有没有碰过类似这样的经验，然后有没有什么解决的方法？这样子，就是 device 没办法 uncross 这样子。
你是说他那个圈去不能圈过，还是那个？
就是我们做了12的 dilatation 之后，然后 THV 没办法，
不能通过，
穿不过的话，
对， 有这个，因为我们主张是 interleaflet deployment， 这个是我们不想用一个太大的球把它打破。不过你要选那个刚刚好，有时候你有时候因为板叶可能退化的程度啊，可能很硬啊，很钙化情况很严重，所以那个 tissue 可能过不去。我们尝试改那个 trajectory 啊 ，wire manipulation 去看看可不可以跑过去。有时候把那个球的前端那个球可能用 2cc 把它张开一点。不过最好的方法，我们也遇过这个情况，是一个 crossover technique。可能我们从前也有 publish 过，这个是从另外一方面，在一个刀线再穿过同一个洞，就像是我们做 septal puncture 的时候，有时候对最后不能把那个板膜顺进去，我们再从另外一边首先把它再扩张多一点再进去。这个是我们通常会在脑里面是想可能有那个方法。不过大部分只是用那个 trajectory 的方法调那个话呢，也可能把它通过。
我觉得你们后来的方法不错了，就用2条导丝了，有一条就是把那个 valve 在 ascending 那边weighting，然后直接用个大把弄把它打了以后直接放进去就好了，这样比较省事。
对，因为我们也发表那个用 e-fluid 的方法做，用 Unicorn 的方法做 e-fluid。因为我们知道它的 radial force 不够把那个 fenestration 打开，所以很多 case report 都是首先把它完成打开才放那个。所以我们的方法是2个刀线，一个是球，一个是 e-fluid。首先把 e-fluid 打开，之后在同一时间再用球把它张开之后再 deploy。所以我们的 bench testing 看到这个 leaflet， 跑 envelope 是飘来飘去的机会很低，它也可能找到比较完美的效果。不过这个需要一点临床数据才可以很确定是这个是最好的方法。不过这个 recrossing technique 也可以帮忙。这刚才是说球那个 tissue 不能通过的时候，你可以再多一个球在里面，可以把它再张开多一点。你不需要把它弄破，你可以用同一个球的 size， 因为现在有一个 wire 在里面。就像是那个 score flex 一样，一个 scoring balloon 一样，它可能把它这个 wire bus 也会改一点。有时候你可能不需要把它张开，那个 balloon interaction 就像是冠脉的 intervention 一样，它可能就可以通过。所以有时候还需要点 tips and tricks。
我想时间的关系，我还有很多问题呢，但是我想我必须把麦克风交出来了。那我们再次谢谢这些专家的参与。那也谢谢大家参与，那我把主持棒交给下个 session。
感谢专家们热烈的讨论。那等一下我要邀请那个亚东医院的吴彦文部长啊，介绍我自己。对啊，就下一个
section。Ladies and gentlemen, I'm Dr. Wu from Forest Memorial Hospital. It's my pleasure and honor to introduce the next speaker, Dr. Wei-Ting Zhang. He's everybody knows her because if you stay here, she's very young and excellent scientific. She graduated from National Chengkong University, and 10 years ago, she has been the research fellow in Brigham and Women's Hospital, Harvard. And I started her talk today because she stayed in the cardiac muscle research lab. And currently in Taiwan Society of Cardiology, we also developed a consensus about hypertrophic cardiomyopathy. And Dr. Zhang is a key person of the consensus. So today he will introduce the very important topic about hypertrophic cardiomyopathy. Where do we stand, please?
Thank you. Thank you for these kind introductions, and also I would like to think that opportunities that can share our opinions about hypertrophic cardiomyopathy today. 不过我觉得我今天还是用中文说好了，因为我想说在座有很多就是我想说可以像多一些了解像心血管相关的一些知识的部分，尤其今天讲这个题目是跟肥厚性心肌病有关系的，所以这个部分我想说如果可以的话用中文 deliver 可以讲得更清楚。那在这个部分事实上刚刚像是吴部长提到，就是我们最近在心脏学会事实上有写了好几个相关在心肌肥厚的各种不同类型的 consensus， 那个事实上网络上面也可以直接搜寻得到，可以直接 download， 所以如果有兴趣的话也非常欢迎大家可以去阅读。那最近有一个新版的是关于 obstructive cardiac hypertrophy 的部分，那大概近期也希望可以就是有机会跟大家分享。所以大概就是稍微快速介绍一下，我想说刚刚听了很多专家讲了有关就是电生理，还有有关相关心律不整，还有就是结构性心脏病变。那在这个部分其实我们主要讨论的是心衰竭的部分，所以心衰竭是 上在全世界和亚洲，事实上盛行率还是非常的高。但是我们可以知道说，我们现在大家知道的是，我们 D2B 哈，我们是要看快速的把心血管打通，也是因为这个 D2B 的关系，所以事实上我们可以看到，大部分我们以前讲的心脏收缩功能异常造成的心衰竭，事实上呢，这个比例相对起来是急速下降，但是心衰竭的病人并没有因此减少，所以到底是什么原因呢？所以我们可能要慢慢该 focus 到有另外一些类型的心脏衰竭。所以除了我们长期讲的 HIF-RAF 心脏收缩功能异常造成的心衰竭，其实还有很多是 preserved ejection fraction 造成的 heart failure， 就是心脏收缩功能是正常，但相对舒张功能异常之后造成的心衰竭。那这些类型的病人到底危不危险？其实我们可以透过之前在心脏学会做的一些分析，我们可以看到，像这边这一群的病人的话，是所谓的舒张功能异常的心衰竭，其实也可以看到它大致上造成的一些相关死亡率，其实也是非常的高。那也是因为这样子，事实上最近的话，不管说过去有一些相关的一些评分的方式，或是最近事实上心脏学会也公布了有关 preserved ejection fraction heart failure， 我们叫 HIF-PAF 这些相关的一些评分方法。其实可以透过很快速的超音波，还有心脏相关的一些指标，我们大概就可以知道这个病人是不是有舒张型，就是 preserved ejection fraction 的 heart failure。但是也是一个问题是，那到底为什么这些病人会有这相关就是舒张功能异常的心衰竭呢？当然很多事实上是跟年龄，还有一些慢性疾病、高血压、糖尿病有相关，但其实藏在中间的可能会有一些所谓的肥厚性心肌病变，而是并没有被早期诊断出来的。那到底为什么被早期诊断出来呢？其实我们可以看到，它的盛行比率其实一开始被我们低估了，所以其实到目前 global 大家知道说，大概200个人中间可能就有一位是有心脏相关肥厚心肌病变的可能性。那当然在过往我们大概对于这些相关的肥厚心肌病变，可能都觉得是高血压、慢性病造成的，但是有一些是特殊原因，像这边提到的一些所谓的心肌肥厚，可能是因为家族性基因造成的。那另外还有一些所谓的法布氏症，这个实际上一些代谢性疾病在亚洲，事实上尤其在台湾，盛行比例比全世界可能还要高。那另外的话，还有一些所谓的类淀粉沉积 amyloidosis 这会是另外一个在 aging population 或是一些家族性造成的，除了神经之外，心脏相关病变特别要去注意的。所以呢，在这几个疾病也是因为这几年开始有陆续相关的一些新的治疗发生，所以呢，我们才有机会知道说，在诊断上面我们要更着力，因为这些病人未来是有很好的一些照顾方法的。那当然，在最早1981年的时候，我们就知道心肌病变，其实当时已经可以做一些相关的区分。那当然，事实上刚刚的讲者也有提到，就有关就是左心室的出口阻滞，所谓 LVOT 的 obstruction 的相关一些问题。所以其实有一部分的话，可能是会造成这些相关的一些所谓的 HOCM。那其他的话，可能会有一些不同类型的心肌肥厚。那当然，随着时代的演进，我们不会从这种传统的方式，我们会有一些新的一些工具，就包含我们现在在做超音波的时候，我们可以透过 spectral tracking 所谓的就是亮点追踪超音波的方法，我们可以知道说心脏肥厚的地方可能有什么样特殊的分布。那这些病人是不是在我们的收缩功能异常之外，舒张功能还有就所谓的心肌本身的功能是不是已经出现了下降？这个目前都是因为现在有一些 AI， 还有一些 on-card， 我们在超音波机器上面，事实上很多都可以快速的去做一些分析，所以临床上面使用的比例事实上是越来越高。那再加上事实上现在以前都要做一些比较侵入的，像心肌切片这些相关的一些检测方法，但是现在有一些所谓的像 cardiac MRI 或像合一相关的 PYP scan， 事实上可以更进一步用一些非侵入性的方法，我们可以知道这个病人心脏发生了什么事情，心肌的肥厚是什么原因，那找到原因之后才能够及时做治疗。所以在最近这几年，在欧洲心脏学会的相关指引也有提到，对于所谓的肥厚性心肌病变，这些其实有可能不同相关的 etiology， 就包含刚刚提到的几个法布氏症 Fabry disease、amyloidosis 类淀粉沉积，或其他像是一些 sarcomere 我们所谓的肌节相关的一些基因变异而造成的一些问题。所以透过今天想说一些短的时间跟大家分享这几个部分有什么新的进展。那先举一个，就是我们这个病人55岁的男性他其实一开始只知道说自己有轻度高血压，也没有特别在药物控制，但主要他来事实上是因为其他的原因，他就打了疫苗之后胸口不太舒服。可是其实做一张心电图可以告诉我们很多事情。其实光是这一张的话，我们就可以看到很明显的，我们可以看到 voltage 它的就是心电图的电量增加了，而且出现了心肌肥大的一些相关的一些征兆。X 光片看起来的话，实际上也看到左心肥大这些情况。那超音波就可以更直接告诉我们，我们一般会去看心脏的前壁跟后壁的厚度已经到达了17 mm， 所以是个显著的心肌肥大。那心脏收缩功能是正常的，并不代表没事了，我们还会再去做分析，包含心脏的舒张功能。另外的话，其实我们可以透过一些 些做法让病人出气用力的方法，我们知道就是说心脏的出口是不是有造成阻滞。那另外我们 OnCar 可以直接做这个相关的我们叫牛眼图做一个 strain 的分析，所以可以初步稍微去区分这个病人可能是产生哪些相关的心肌病变。那当然透过这些方法有 strain， 我们就可以更好的去区分看起来可能超音波上面很类似的影像，但其实里面可能暗藏玄机。那所以呢，透过其他像是刚刚讲的合一的，或是像是CMR 所谓的 MRI 的方式的话，我们也可以进一步知道病人可能是有相关的哪些问题。所以我们大概在几年前，我们在奇美，我们就自己把它稍微定了一个简单的 flow chart， 就说如果说这个病人今天是来怀疑心肌肥大的话，那这个时候我们进一步要做什么呢？事实上可以透过一些抽血、问病史，还有相关一些简单的一些包含影像检测，做非侵入的方法，可以诊断病人会不会是刚刚提到的哪一类型的心肌病变。那后面有相关治疗会跟大家稍微去做介绍。那当然在这个部分的话，第一个我们稍微先谈一下刚刚讲的，就是心室出口阻滞就是 HOCM 这些造成的心肌肥厚，这很多事实上是跟一些 genetic 所谓的就是一些基因变异或家族性的是有关系的。我们可以看到我们心脏收缩的话，事实上就是我们的 actin myosin 这两者之间交错，让我们心肌可以得到很好的收缩。那如果这个功能差的话，就是收缩功能异常；功能过度的话，事实上可能就会造成我们讲的所谓的心脏过度收缩，造成心脏肥大。那这个事实上在亚洲事实上发生的机会是比我们预想中的还要更高，而且事实上有时候都会有一些家族性相关的，所以我们这有很多是母女档、父子档都是有相关的一些问题。但是其实我们可以看到，它有可能发生的有几种类型整体的心肌肥厚，或是有可能是在心脏出口造成的肥厚，或是有一些我们比较担心的产生一些像是心脏的一些瘤不是真的是长肿瘤，它是心脏一个 aneurysm 的产生，这些比较容易产生是致命性的心律不整。所以有的时候我们可以看到人家讲说，跑马拉松，突然有人就是年轻人本来没有什么慢性病，突然猝死这些其实蛮多是因为长期可能心肌病变并没有知道，没有被及时诊断出来的，所以要特别的去注意，因为很多是年轻族群。那当然如果说今天有心脏的肥厚的话，那当然除了传统的手术方式做心肌的一些切除，另外我们可以用导管的方式用酒精去做消融，所以这是另外一个事实上可以去做一些治疗介入的方法。但还是一样，这些东西的源头是因为心肌的过度收缩，所以如果有没有方式我们可以让这个心肌放松一点，我们叫 myosin inhibitor， 是可以减少这个心脏过度收缩，减少这个心脏肥厚的恶化。所以呢，事实上在过往的话，我们大概能够使用的武器就只有像是 beta block 乙型阻断剂，或是像是一些 non-GCB， 这些让心脏稍微收缩慢一点，减缓让它放松一点。但现在事实上有这个所谓的 specific 专一的 myosin inhibitor 的话，让心肌可以放松一点。事实上它的疗效是如何呢？所以我们可以看到，事实上已经从2017年到最近，已经在这10年的时间，实际上陆陆续续的几个 clinical trial 临床试验，其实已经有看到蛮好的相关的一些结果。所以呢，在目前的话，事实上大家已经有相关像是 Masicanten 和 Aficamten 相关的一些药物，在临床上面事实上已经可以开始使用。那大概今年的下半年有机会，事实上健保相关的给付可能也会在一些相关适应症的病人，在 HOCM 这个病人上面，事实上可以带来许多帮助。因为时间关系，我们就要快速现在拖到下一个，就是法布氏症法布氏症也是一个，其实现在目前新生儿筛检，我们都会去检测说，到底这个小朋友是不是有法布氏症？法布氏症的话，它本身就是因为心脏一些小的我们不想要的蛋白质，并没有办法被我们的溶酶体好好的分解掉，所以造成说我们心脏不想要的一些垃圾积在心肌里面，而造成心肌它过度的肥大。但这个肥大是大而无用的，它虽然心脏肥大，但是并没有收缩功能增加，所以相对起来的话，后面造成一些心衰竭之外，事实上心脏之外很多器官，包含皮肤、神经，还有就是包含的出汗、肾脏，有很多系统上面事实上会造成一些影响那当然，如果说法布氏症的话，什么样的情况要去特别去注意？当然，新生儿筛检目前有做，但是在我们这个年代的时候，大概出生的时候并没有做相关的筛检，所以要去注意的话，当然第一个是它是一个 S link 所以就是所谓的 X 相关的一个 chromosome 染色体造成的一个就是性联遗传，所以其实我们可以对于家族史去询问的话，可以知道可能相关的一些可能性。所以家族一旦是有人有发生这个法布氏症，实际上家族的成员是建议要去做相关的一些基因筛检。那当然另外的话，其实上它在心电图看起来就会明显的像我们一开始看那个病人 voltage 是很高的。那另外的话，其实会有一些像刚刚讲到皮肤出汗相关疼痛的一些症状，甚至造成肾功能不全。那这个也是在当时心脏学会的带领下，我们写了一个相关的 consensus。事实上里面也有提到，就是说如果今天有怀疑相关法布氏症的话，事实上它的检测相对起来也是很 friendly， 事实上可以透过肝血片、代谢酵素相关的活性，甚至后面进一步需要的话去做基因检测的话，事实上可以快速的知道这个病人是不是有法布氏症的可能性，或是它的带源。那当然进一步的话，临床上面我们可能就是每年要追踪超音波去做心脏相关的影像，那可以帮助我们去判断这个疾病
目前的情况。那当然，如果说今天是要去做治疗的话，目前的选择也蛮多。临床上面事实上这几年罕病基金会已经提供相关的 support， 所以病人事实上可以接受就是相对起来很昂贵，但是有 cover 的一个 Fabry disease 相关的一些 enzyme replacement 哦，所以相关的话事实上可以用一些替代疗法去做治疗。那再来也有可能可以目前有一些 chaperone 的方式，事实上可以减少这些相关法不适症不想要的一些沉积物。那再来最后的话一点时间，我们稍微讲一下类变美沉积哦。我们知道现在是高龄化社会，那在高龄化社会情况之下，很多也是一样，身体产生不想要的一些所谓的类淀粉酶，事实上可能会沉积在我们的身体很多器官，以神经跟心脏为主。那当然有一些可能也是因为家族性而造成这个沉积的，是因为家族的 familial type 哦。但是我们其实可以看到，这些的话相关起来类淀粉沉积可能会造成很多，包含什么？我们看肩颈肿大、舌头肿大，或者说其他相关的，包含皮肤上面的一些异常。那当然有一些是因为就是血液相关疾病的light chain 造成的，那有一些是我们讲的 ATTR-CM， 就这些可能肝脏造成的一些过度的废物沉积，这个可能是跟年龄或是家族性有相关性。所以在这个部分的话，其实这几年也是一样，心脏学会有提到很多很好的相关一些指引，这个网络上面也可以搜寻得到，那也欢迎大家可以来阅读。那当时有稍微有帮大家整理了一张图吼，就是可以看到，如果今天是一个就是原发性血液造成的 light chain 的 amyloidosis 的话，其实可以看到比较多的话是皮肤有淤青，或是可以看到大舌头，或是像 buffalo shoulder 或其他相关的一些临床上的症状。那如果今天是 ATTR-CM 的话，它比较常看到的是因为 aging 年纪大，或是相关的一些家族性的病变，其实造成的除了心脏肥大之外，可能会造成一些 spinal stenosis 或是 Barlow-Carpal syndrome 两侧的晚隧道症候群。或其他相关的一些神经病变，这些就是临床上面我们特别要去做注意的。那当然它的心电图跟超音波也会有一些特殊的一些表象，那这些大概就是临床医师我们要特别去关注。那当然在学会当时的那个指引上面有提到一个所谓 red flag sign， 就是哪些病人要特别去注意呢？其实有提到一些比较详细的资讯，不过我觉得目前我在临床上面使用的话，比较 friendly 的方式的话，还是大概就是后面像这个 hidden， 你可以快速的知道说病人是不是临床上有心衰竭，心电图实际上是 low voltage。心脏肥大、有晚隧道症候群或自主神经异常，像 syncope 昏厥相关的一些症状，这些可能就是要去做进一步 survey 的一个 hint 哦。那当然也是一样，过往事实上比较多对这部分有了解的，大概是神经内科，因为台湾的族群事实上就有蛮多是一些特殊基因病变造成家族性的一些神经病变。那当然其实后来陆续发觉，有一些会造成心脏相关的 environment 哦，所以心肌也开始出现肥大。所以呢，其实有一些病人是在神经科或者在心脏科长期追踪，然后早期做介入治疗的。所以呢，其实我们可以用刚刚讲那个亮点追踪超音波 strand 的方式，其实就可以看到说，如果说今天只是一个带原者，可能这个红彤彤代表说心脏本身相关的一些 strand 功能还正常。那如果说到后面开始出现了一些类淀粉沉积的话，其实就会看到从心脏的基部开始 base part 就看到相关的一些 strand 的一些减少，所以我们就有类似我们讲 cherry on top， 在上面心间放一颗樱桃的那种概念，可以看到说 strand 相关有一些变化。那再来的话，事实上可以透过核磁共振的方式，也可以去稍微区分，就不用侵入性的切片，但是可以稍微去区分，它可能比较像是法布氏症，还是说今天是可能是因为心脏相关的心肌一些病变，包含类淀粉酶沉积造成的，可以做一些初步的一些分解。当然最理想的话，事实上还是因为拜之前目前我们知道 PYP scan 所赐，这是核子医学检查，那这个是吴元部长的专长。那其实可以看到说，早期我们做这个可能只是想要看，就是到底有没有骨头相关的一些病变沉积，或者有出现一些 infarction 之后心肌梗塞造成的一些异常。但其实呢，也发觉这个相关的 isotope 实际上可以用在我们 detect 心肌有没有类淀粉的沉积。所以如果说用这样子相关的一个 isotope， 我们可以把它转化变成是去侦测有没有类淀粉沉积在心脏的一个变化。所以我们可以看到，照它一个就是详细的 protocol 之后，我们可以看到，如果说这个病人相对起来是 grade 2跟3以上的话，实际上就有很高的风险，这个病人其实有可能是类淀粉造成的心肌病变。那进一步如果需要，我们可以再去做切片，做进一步的 histology 的证实。那主要在治疗的部分的话，也是因为这几年事实上有相关的治疗的药物，所以呢，其实在这边的话，会造成我们临床上面会更关注这样相关的一个疾病。所以呢，肝脏造成这个我们不想要的这个蛋白不正常的折叠之后，会累积在很多地方，包含心脏跟神经。但是我们其实可以透过几个方法，那当然目前临床上面比较多在使用或给付的，加上 tafamidis 这样的药物，是一个 stabilizer， 就让这样相关不正常的淀粉酶事实上可以稳定下来，至少它不要到处乱跑，不要到处作怪。所以临床我们已经可以看到， 到在 survival 病人的一些临床的一些不管功能性，其实已经可以看到有一些证据上面的一个 improvement。那另外的话，其实还有一些相关的药物，包含这个是在去年的时候 FDA approved 的话，是用一个 gene silencing 的方式，用一个 siRNA。这个其实临床在之前已经有一些在神经相关类的成绩已经有相关的给付跟应用经验。不过也是在心脏的话，也是因为去年有相关 clinical trial 的证实，可以知道临床上面可以去做相关的一些使用。那当然还有一些事实上是在 ongoing 的 clinical trial， 那也期待未来有更多相关一些治疗。那目前的话，其实会觉得说，如果未来有机会，当然这些相关药物都很昂贵啊。不过就是说，如果可以的话 ，combination 使用，事实上可以从源头阻止 ATTR 淀粉酶的产生，然后让它 stabilize， 避免它产生后面相关的一些病变。那当然也有很多学者提出不同的想法。我们常常讲的 wild type 就是年纪大造成的，或是家族性，是不是它的本身造成异常不同，或是除了我们在讲到类淀粉之外，其实还有后续它造成的发炎跟纤维化，其实也是未来我们可能需要关注的。所以不单纯是治疗，后续其实还有很多心脏相关的一些照护，其实相关的一些药物介入，其实大概都会是未来我觉得在整合照护部分的话是一个很重要的一个 issue。所以我想说今天的话，我大概在比较短的一个时间，我们就用中文分享哦。那主要是要讨论到说，事实上在心脏除了早期讲的收缩心脏功能异常之外，心脏功能就算今天医师跟你说，心脏功能正常哦，不代表没有问题，实际上要注意是不是有心脏肥大。那心脏肥大呢，也是因为现在慢慢开始了解，所以呢，其实有一些特别的一些 etiology 一些原因藏在里面，包含今天分享的有个可能是 genetic 基因造成的心脏的肥大，主要最担心的是造成 obstruction Hocken。那另外还有一些是像类淀粉的沉积，这些可能还有神经相关的病变，所以看心脏之外，还要看 extracardiac 心脏之外的一些临床表现。那另外的话，还有像是法布氏症，这个很特别，是在亚洲，是在台湾表现率、盛行率是比全世界还要高的，但是也是很方便的，是因为现在可以减少去做 biopsy 侵入性的检查，可以透过像抽血的方式去做相关的一些核子扫描的检测，其实就可以比较快速知道病人他未来事实上有没有很多一些方法可以去做相关的一些治疗。那大概就是透过这些的方式的话，我觉得其实在 HCM 这个部分，那希望今天一些时间给大家一些新的 information， 那大家有机会的话，也期待等一下有机会可以讨论跟交流。那另外还要快速广告一下，5月的时候事实上在台北有亚太心脏学会，那今年是在台湾举办，那很欢迎各位专家或大家有兴趣的话可以共襄盛举。那以上是我的报告，谢谢大家。
我们可以提一个问题，可以哈。那不过我稍微补充一下，那个美亚康天在4月1号已经取得健保适宜证，然后是采事前审查，所以对于大家现在了解这些疾病，每一个都已经有药可以治了，而且都是健保给付的，是非常非常的重要。那不知道在座各位有没有什么问题想要请教张医师的？没有的话，我就私心问一个问题，因为我知道奇美有一个非常好的流程去筛检这样的病人，好，这个其实是很多医院都很想知道的典范，可以利用这个机会跟大家分享一下吗？
没问题，很感谢就是主任部长 Q 有这个问题，因为事实上本来今天要准备相关一些报告，不过我们目前还在整理当中。那事实上从大概刚开始有这个 flow chart 之后，事实上开始做 screen。不过当然比较weakness 的是，我们并没有办法每一个病人都做所有的 screen， 因为其实里面我们有些病人那时候去做 genetic test，genetic test 是我们自己掏腰包去做的检查。那其实会发觉，所谓的就是 HCM 是因为 genetic sarcometric 造成的，实际上比例比我们想象中的高。而且事实上蛮有趣的是，我们那时候找到几个 family， 事实上他是爸爸有 HCM， 儿子是 DCM， 但是同样的 gene mutation， 或是反过来，爸爸是 DCM， 儿子是 HCM， 同样的 gene mutation。所以其实我觉得后面可能在未来，因为法布氏症跟 ATTR， 其实我觉得目前都有很好的流程。那透过这样的机会，事实上我们中间有筛到几个病人，但是其实我觉得还有一些需要去关注的是这个有关，像马巴肯能现在治疗效果非常的理想。那当然，如果说这些病人是不是有家族性，是不是有一些可能他的表现临床上 phenotype 会跟 genetic 不相同的话，我觉得这个会是以后一个我觉得蛮有机会再去做进一步的 explore 的一个 issue。因为其实，在欧洲心脏学会目前除了 HCM 之外，它有 release 另外一个 non-dilated cardiomyopathy， 就是未来可能会发展成 DCM， 但是还没有到那个 stage。early stage 的 screening 跟后面的 management， 我觉得很重要。我目前大概收了大概200多个病人不过大概有些 data 还在分析当中，未来希望有机会跟大家分享。谢谢。
对，那我之前有听过几次，就是从病人的诊断到超音波室，到门诊，到整个流程能够串在一起。其实这些病人都没有像我们想象的少，他可能都在跑来跑去、跑错当中。所以透过一个这个 team base 的一个 approach， 一定可以让大家找到这些病人，而且他们都有相对应的药可以治疗。那我们很高兴，谢谢伟霆的分享。那你要下来回去继续来当主持人。
Thanks everyone's attention. So we're going to move to the next section. So next section, I'm going to invite our moderators, Dr. Huang Guanhua from our urology department.
Good day, my friend. Welcome to Tainan. It's my pleasure to be invited in this meeting. Thanks, Dean Chen, Professor Si, and Professor Chen, the kindly invitation. Today it's my honor to introduce the next speaker, Professor Ng Junda. He is a senior consultant cardiologist and also is the leader of the digital hub at the National Heart Center in Singapore. He is a famous scholar in the Singapore and worldwide. He had got many areas program training certificate, including Singapore, USA, and UK, and European. Today, he will give us a talk about the cardio-oncologists in Asia now and further the outbreak. Please give the Professor is a root of the plot. Thank you.
Thank you for the very kind introduction, and thank you for having me at this conference. I'm happy to see all of you, and I'm happy to witness the progress of Chimeyi Hospital in the past 30 years. Today, I'm going to touch upon cardio-oncology in Asia. I'm going to make my speech in English as 我的中文不大好吧，谢谢你们。So cardio-oncology is no longer a new field. It's something that is more important because of the disease that we have in Asia, where cancer as well as heart disease are growing in terms of numbers. By the end of the talk, I hope to do three things. One is to highlight the growing intersection between cancer as well as heart disease in Asia, and to discuss what are the challenges we face across Asia. And lastly, to share with you what the future of cardio-oncology will be like. Let me start with a patient that I see in my clinics. She's a 68-year-old Asian woman who had a HER2-positive breast cancer with diabetes and hypertension. This is not an unusual patient. It's a lot of patients, as what Wei Ting mentioned just now, has diabetes in our population. She received anthracyclines followed by trastuzumab, which is actually a HER2-targeted therapy. And she then presents to us or to cardiology with shortness of breath. And we repeated her echo. There was a drop in ejection fraction from a normal 62% to 47%. The key question is, how do we manage her risk? And that brings me to the field of cardio-oncology. At the heart of what we do, we prevent, monitor, and treat cardiovascular toxicities that's related to cancer treatment. But increasingly, it's becoming more than that. In the past, we used to treat complications. We now aim to enhance the health of cancer survivors, especially patients like childhood lymphoma patients who are in their early 20s and 30s. And in the future, we hope to be able to predict who will get cardiovascular side effects from cancer treatment and initiate treatment at an earlier phase. Asia accounts for 60% of the world's population. We see more than 50% of cancer patients. We see more than 50% cardiovascular disease in Asia. And in many parts of Asia, including where I come from in Singapore, cancer as well as heart disease are the top causes of mortality. They are ranked number 1 and 2, respectively. And it's not different in many parts of Asia. This is the reality that we face now. Cardiologists and oncologists, we now care for the same patients across a shared disease continuum, which means to say that we interact with all these patients at different time points in their journey as patients. If you can see this intersection between cancer and cardiovascular disease, we can appreciate why we see the same patients. In both our patients and the oncologist patients, we have common risk factors in our patient group, characterized by high prevalence of cardiometabolic syndrome, older age. There's also similar biology characterized by chronic inflammatory state, oxidative stress. And that brings me to this concept of reverse cardio-oncology or bidirectional relationship between cancer and cardiovascular disease. When cardio-oncology first started, it was a one direction, how cancer treatment can lead to heart disease, heart complications. But now, we realize that cardiovascular disease increases the risk of cancer as well. It also increases cancer mortality. In the same vein, cancer increases the risk of heart failure, venous thromboembolism, coronary artery disease, stroke, atrial arrhythmias like atrial fibrillation, and of course, also cardiovascular mortality. If you can look at this chart, when patients are newly diagnosed with cancer, they also have a very high chance of developing heart disease or being diagnosed with heart disease, be it stroke, acute myocardial infarction, heart failure, pulmonary embolism within the first year. A case in mind would be that of atrial fibrillation. If you look at time from diagnosis of cancer, at the start, within the first 180 days, they have up to 3.5 times risk of being diagnosed of having atrial fibrillation compared to a general population. This might be because of cancer being a oxidative milieu, or also because of the increase in contact with our healthcare system that they get picked up along the way. And this complicates management, as you could imagine, the anticoagulation part, the bleeding part, as well as treatment interruptions, not to mention that in cancer, they are in a pro-thrombotic phase, and they are at risk for thromboembolic complications of atrial fibrillation. We also know that there's also an increase in cancer prevalence incidence in heart patients. So there are a hazard ratio of 1.14 or 14 times higher chance of getting cancer as well. And cancer across the different subtypes, basically conditions like thromboembolism, heart failure, arrhythmias are increased with increased risk of cancer. This brings me to the concept of reverse cardio-oncology, where cardiovascular disease that we treat today may influence the development or progression of cancer. So this relationship is no longer a one-directional one, but it's a bidirectional relationship. It's a shared biology that we share. So the patient I spoke about just now actually had breast cancer that was detected during mammography screening. And mammography screening is recommended for women depending on their age group. When they do mammograms, you can look for tumors, but you can also look for breast arterial calcifications. And this potentially can predict the arteriosclerotic burden in our patients. And it shows promise as a tool for predicting heart disease and stroke in women. In Singapore, we do a chest CT for patients in a research setting to pick up lung cancer. But while doing that, we also screen for heart disease. And that's because when I do a CT of the chest, you could see some coronary calcifications with AI techniques or machine learning. You could derive, for instance, a machine learning derived calcium score. So the few bidirectional relationship between cancer as well as cardiovascular disease provides us with a whole host of opportunities. One, for combined primary screening, as I demonstrated, where we screen patients for breast cancer, for lung cancer. It also allows us to institute approaches to actually prevent or to reduce cancer or heart disease. For instance, the focus on cardiometabolic syndrome, as what Dr. Chen mentioned at the starting. This creates an opportunity for us to manage both groups of patients at the same time. When we see a cancer patient, they should also think of the cardiovascular risk. If you look through the case records of your patients that you have treated, a lot of them will have some form of cancer. This encapsulates the whole concept of reverse cardio-oncology, starting from a shared pathways between both conditions. We are exposed to the same environmental factors, smoking especially. They have the same risk factors like hypercholesterolemia, diabetes, hypertension. It's also characterized by hyperinflammatory state. There's also genomic instability and a chronic stress state. And all this can lead to both cancer and heart disease. The good news about this is that potentially with lifestyle intervention, exercise, smoking cessation, a dietary intervention, even with new therapeutics, for instance, like your anti-inflammatories for cholesterol, for blood pressure, the lipid reduction agents like statins or PCSK9, or even MRAs, we can potentially reduce both conditions at the same time. In Asia, our patients face different challenges compared to the West. We have a different epidemiology of cancer. For the West, for instance, they are characterized by melanoma, but we have a higher prevalence of nasopharyngeal carcinoma, gastric carcinoma, hepatocellular, as well as hematological disorders. Our patients tend to get cancer at an earlier stage. That also means they live a longer time after they survive cancer. There's a high cardiometabolic burden, whereby they have diabetes, obesity, as well as hypertension. And importantly, because of the fact that they are diagnosed younger, we have more of these patients, they survive longer because of better treatment. We get a whole host of patients who are cancer survivors. The field of cardio-oncology has grown. So in the 1970s, how cardio-oncology started was that in a major cancer center in the US, they discovered that a lot of patients who underwent treatment with doxorubicin or adriamycin at that point in time had heart failure. So what did the cancer center do, MD Anderson? They employed their first cardiologist, that's this guy over here, Dr. Michael Iwa, to start to treat these patients who had received cancer treatment. And at that point, no one knew why do all these patients have heart failure. And what he did was that he subjected almost 220 patients to a cardiac biopsy, and he established a proof of concept that cancer treatment affects the myocardium of patients. And move forward to today, we have targeted treatment like trastuzumab, but you also have other treatments like immunotherapy, we also have like cellular therapies as well. So the cancer treatment area has grown tremendously. It's one of the most rapidly growing areas across medical fields. They have the most number of clinical trials. They have the most number of precision-based medicine. And there's a lot we can learn from oncologists. How do we genotype patients? How do we treat them appropriately? How do we screen them for disease as well? But because of the number of treatments, we see a whole host of side effects. When cardio-oncology first started, everyone was just focused on about ejection fraction. But this is no longer the case. It covers the whole span of cardiology. From electrophysiology point, it increases QTc. It causes atrial fibrillation that is very hard to control, dose-dependent as well. It causes pulmonary hypertension, and radiation also increases the risk of valvular heart disease. It causes aortic stenosis to occur at a more rapid phase. And these patients actually do well with TAVI as opposed to open heart surgeries. And the reason is because with radiation, that affects the aorta as well. And that is where percutaneous intervention comes in. Unfortunately, we cannot have a single protocol to manage all oncology patients because there's no one size fits all. So imagine this patient that we mentioned just now, he should have a drop in ejection fraction from 62% to 47%. When they refer to me, the question they want me to answer is, can this patient continue treatment? How do we do that? How do we answer them as cardiologists? It brings me to this concept of permissive cardiotoxicity, whereby we assess the symptoms of this patient, what's the prognosis, how important is the treatment, cancer treatment to the patient. And we do not just stop therapy if we could manage. We do not let them continue with therapy without due diligence. But what we do is that we allow them to proceed with cancer treatment with caution. We monitor this group of patients such that they continue with cancer treatment so that their overall survival increases. In the minds of cancer patients, they have a lot going on in their minds. The common conception they have is that if they stop their treatment, they might succumb to cancer. So this patient was started on ACE inhibitors, beta blockers, SGLT2. Her symptoms resolved, so she did not have any more shortness of breath, her leg swelling resolved. She was actually resumed on trastuzumab, the same therapy that caused her heart function to drop. And the repeat echo performed 1 month later actually showed that the heart function returned back to normal. She started with 62%, fell to 47%, but managed to recover to 56%. This shows the importance of pharmacological measures. But in this day and age of cardiometabolic health, we are no longer talking just about medication. We are talking about non-pharmacological means. How do we have dietary and nutrition? How do we encourage patients to go for exercise? Digital health can be a means for us to accomplish all these non-pharmacological measures. The challenges of cardio-oncology in Asia. Across Asia, there's a range of discrepancies in terms of the availability of cardio-oncology services. We do not have specialized training for cardio-oncology, but this is going to change as we have more defined curriculum on what cardio-oncology curriculum should be like. There's also often a lack in physician awareness. Because of the number of agents that is used in the treatment of cancer patients, it's not quite possible to keep abreast of all the treatment modalities. But the only thing I ask of you is to understand that, for instance, certain chemo agents have certain side effects. Like doxorubicin is notorious for causing drop in ejection fraction. Other agents, for instance, like immune checkpoint inhibitors, are notorious for causing myocarditis. Things like maybe a TKI can cause hypertension and all this. But understanding the major classes of medications, hopefully we can manage our patients a bit better. There's also a lot of data gaps. A lot of these studies on prevention is done in the West, and we have a different phenotype, different epidemiology. So it's time for us to call our own Asian data. Not only that, one of the things that is going to happen in Singapore and across Asia is that of an aging population. Our population are growing older. We currently have 630 million patients or people who are above the age of 65. But by 2050, we have 1.3 billion of patients who are aging. And with aging, there are certain concerns that we have where we treat patients, even from a cardiovascular perspective. We are looking into things like frailty, how much functional reserve they are. Where prescribed medications, we think about polypharmacy, we think about the drug interaction they have. And in terms of goals of care, we also look into what the goals of care are for different patients. There are patients who want all out for, there are patients who say that they don't want an LVAD if they get a heart failure. So we need to understand their needs a bit better. And that's why we routinely introduce advanced care planning for our patients, to let them have their views on what they want if one day they do fall sick. The future of cardio-oncology is going through changes. So 3 main aspects. I mentioned about the toxicity aspect in the past. Now we focus on survivorship. But in future, it's about how do we predict the future? How do we predict who has this risk of having cardiac side effects due to cancer treatment? Before these patients started treatment, the oncologist will counsel them on the medications. There's a risk of cardiac side effects. And sometimes they ask, so what is my cardiovascular risk? How do we use risk to inform them? I think that's where the next frontier of medicine is. Precision-based risk stratification that incorporates our traditional risk markers, genetic testing, imaging biomarkers, with AI-driven in the loop. These are the traditional risk factors of patients who are at risk for cardiac effects of cancer treatment. Previous cancer treatment, our common risk factors that we see in cardiology, older age or very young age of less than 10. We also have previous cardiovascular disease. They obviously put patients at risk for worsening heart disease during cancer treatment. The lifestyle factors, for instance, smoking, obesity, sedentary lifestyle, cardiometabolic syndrome. But we also now know that there are certain genes associated with different treatment that potentially can predict worse outcomes. I think in the future, there will be having a polygenic risk scores for us to really appreciate the genetic predisposition of patients to cardiovascular risk. The biomarkers that we have is common to everyone, be it myocardial infarction, heart failure, cardiomyopathy. What we have is NT-proBNP and troponin. These are the two biomarkers that we have. I mean, there have been so many biomarkers that were studied, but unfortunately, none were useful. So we have to turn our eyes to other things. For instance, in our center, we do AI echo for patients undergoing treatment for cancer treatment. And what this does is that there's an AI-guided acquisitions whereby a non-sonographer, which means someone who is not trained in echo, can do an echo for this group of patients, because you can see that this echo guides the anatomy of patients. But more and beyond, in terms of what we can find from the echo, is that they can predict, for instance, they can tell you the ejection fraction, but often they can also predict the risk of having things like amyloidosis, hypertrophic cardiomyopathy, and amongst others. All cancer patients, or most of the cancer patients who have a staging CT done before they have treatment to assess the disease or cancer staging. And we are trying to use such scans that are non-gated, non-dedicated, to look at CT calcium score, to look at things like adipose tissues, to look at things like epicardial fat, to actually determine what their cardiovascular risks are. AI ECG, all the patients that come to our cardiology clinics at some point in time with at least one ECG done. And this ECG carries a lot more information than what we can see with our eyes. That's what Dr. Chen alluded to in his opening speech. For instance, you can tell what's the probability of this patient having a low ejection fraction, what's the probability of patients having hypertrophic cardiomyopathy, what's the probability of patients having silent atrial fibrillation, which means while they are still in sinus rhythm, what's their risk of developing atrial fibrillation in the near future, risk of aortic stenosis, amyloidosis. You can tell you the age and gender as well. Typically in the clinics, we auscultate patients, and by combining that with using an AI stethoscope, what this thing does is that it has a 3 ECG, it has an audio tracing, so what we call phonocardiogram, and it goes through an AI algorithm, and by listening to the patient, it actually sends information using the phone to the cloud, and you wait for a few seconds. This is real time, so in about 10 seconds, it tells you that low ejection fraction detected. And this is about 88% sensitive for low ejection fraction detection. But that's not about it. Can we use that, for instance, to detect atrial fibrillation, because you can see heart rhythm tracings? Can you use that to detect radiation-induced valvular heart disease, for instance, aortic stenosis, or even heart failure decompensation, because this can be used for lung auscultation as well. Face age is a study by the Harvard group, But what is interesting about this is that for all patients going through radiation therapy, they will have their facial image captured by the radiation oncologists. And this practice is similar across the world. So in the US, they capture, I checked my Singapore radiation oncologists, they do capture their faces. And this is supposed to be a patient identifier. But what the group has done is that by using a facial image, you can actually ascertain what is your biological age, which means what's the biology age as opposed to the chronological age. And for patients who are 5 years older than their biological age, which means if someone, this lady, let's say, was born and she's 55 years old this year, for whatever reason, this AI algorithm says that she's 61 years old, she was demonstrated in the study to have a worse outcomes, an increased risk of cancer-related mortality in 6 months. This is a pure cancer cohort. But can we do that for our cardiovascular patients, our cardiac patients? We know that from the AI ECG, an age of more than 77 years above their chronological age has a twice increased risk of MACE. So potentially you can use things like facial image to estimate biological age and predict cardiovascular and cancer outcomes. And this is an area that is currently lacking in Asia. As you can imagine, when they did this study in the West, in the US, it was mainly Caucasian patients. And in Asia, we have a huge range of ethnicities. We have different facial tones, facial features. We have different races. And this may affect the way the device or the algorithm interprets the age. While we see patients in our clinics, we have access to, for instance, an AI scribe, and basically what they do is that they take down the notes while we interact with patients. And the whole premise of that is to reduce the documentation effort and also to refocus on our patients when we talk to them. But voice has something more. Voice can potentially detect heart failure because the machine can recognize, for instance, the tone, the cadence, the speed, the speech as well. It can also detect, for instance, coronary artery disease. So a lot of places are doing this voice research. Potentially has multiple users because voice is accessible. When you call and see your doctor, you have to use your voice. When you do teleconsult with mood monitoring, you have to use your voice as well. So it potentially can provide us with more biomarkers. And if you can, the ideal situation is to integrate all these different resources that we mentioned about to come up with a risk score or risk prediction model in our EHR that can inform us on what sort of treatment that should we have for this patient, how frequently do we need to monitor the patients for cardiovascular side effects, and how we don't want to monitor all the patients for every 3 monthly echoes for sure, for instance. We want to be able to tailor their management depending on their risks. Next, I think we move from being a single disease whereby cardio-oncology is just managing effects of cancer treatment to understanding the bidirectional relationship of cancer. But the next phase is actually more integrated care. I mean, we talk about heart team and all these behavioral interventions, but this is also something that we advocate in cardio-oncology. The use of the communications between our oncologists, our pharmacists, our primary care providers are very important because for those patients who survive cancer, they are usually seen in the primary care. There's no way we could see all of them because of the burden of disease that we have. Exercise is important as well. So exercise is medicine in this era of cardiometabolic health. What this means is that you can prescribe exercise to your patients. And no longer are we talking about just aerobic exercises whereby people just ask them to walk, ask them to run, ask them to jog. We talk about things like resistant exercises because, for instance, it can lead to less fatigue, it can maintain muscle mass. That's especially important even in cardiovascular field as we approach the age of frailty. As our patients get older, we are concerned about concepts like sarcopenia and all this. So we try to intervene by asking them to do resistant exercises as well. The care model is also going to change. In the past, it was reactive. when they get a drop in ejection fraction, we see them. The move is towards screening them, and ultimately, how do we continuously monitor them? So I've come to one of my last slides. I wanted to just share with you what continuous monitoring means. It means using whatever we have and whatever matrix that is being collected to come up with data points that can inform us if they deteriorate or if there's a change in their conditions. For instance, a smartwatch, which a lot of people are using, can detect, for instance, your respiratory rate, your oxygen saturation, the temperature, and eventually blood pressure. And these are variable metrics that you can monitor to actually reach out to patients before they get a stroke or before they get heart failure and all this. In terms of physical activity, you can encourage them to exercise by providing that feedback loop. So a lot of the smartwatches will have option to assess your fitness, for instance, your VO2 max, your 6-minute walk test or 500-minute walk time. This will be able to inform patients of their progress as well. For instance, if you start a patient on, for instance, cardiomyopathy medicine is supposed to increase a 6-minute walk test, you can ask them to monitor and see how that affects them. It provides a data point for them to see that benefit. A lot of times where I do not see the benefit of treatment, for instance, I do not know, my patients will not be keen to continue. When we start cholesterol medicine, we monitor LDL. When we start, for instance, heart failure medications, we monitor things like biomarkers. But from the patient side, they can monitor something as well. For instance, if they exercise, it shows that that improves their VO2 max, they'll be more keen to continue. So this is a part of forming that feedback loop for patients. So in conclusion, cardio-oncology is no longer a niche area. It's central to modern care, and partly because we have an epidemic of cancer as well as cardiovascular disease. New care paradigms are actually changing the way we practice. Having permissive cardiotoxicity reverse cardio-oncology, and I think Asia really represents the next frontier. We have a high patient load, we have a unique patient subtype as well. And the future of cardio-oncology, as with other parts of medicine, will be precision-based risk stratifications. Right, with that, I thank you for your attention. Okay, thank you. Any questions?
Thanks, Professor Ng, the amazing talk. Any question or comments from audience? Okay, thanks, Professor Ng. Because he's a cardio-oncologist, is a good friend. They are helping us. Initially, I am a urologist oncologist, and help us to looking for the 3 points for the patients to get this between the oncology control and this body controls. So, will you suggest every patient before they receive treatment, include this hormone therapy or the chemotherapy, before that, this oncologist must consult the cardiologist to evaluate these patients' treatment plan and this body status? Would you suggest that?
Okay, thanks very much for the question. So I think that's something that's close to our heart. So in urology patients or prostate cancer patients going through treatment, they go through antigen deprivation therapy, and that is a hormonal treatment that affects, for instance, their cholesterol control, their waist circumference. Sorry, waist circumference. Let me drink some water. So it causes derangements in the metabolic component. But I think the question is what group of patients should be seen. We don't want to be seen as delaying treatment. So I think the group of patients that should be seen are patients with symptoms. For instance, those with chest discomfort, those with previous stenting done many years ago, they don't take their medications, they come back with a bit of chest discomfort, a bit of shortness of breath. These are patients that potentially we can see and treat them, because with this antigen deprivation therapy, that increases the risk of heart blockages as well. They get an increased risk of heart attack. So I think we have to be selective on what group of patients to see, as in cardiologists. We don't want to be seeing all the patients such that before they start treatment, they see a cardiologist, and that delays treatment. But we want to be able to intervene those that potentially can prevent an event. So it's the high-risk group of patients that potentially benefit. But what we have done back in Singapore is that we have tried to influence our primary care colleagues by providing recommendation, educational opportunities for them to realize that, for instance, they see the patient for diabetes, hypertension every few months. In the 6 months after initiation of ADT, sometimes they get worsening control. We either ask them to, before they start treatment, to increase the dosage of statins, or we ask them to monitor it during the treatment. And especially in patients receiving hormonal treatments, it's essential for them to exercise, because exercise helps to preserve bone mass, it helps with the hormones part, it helps with the preventing complications as well, especially in the prostate cancer group. So it's a very holistic management that involves everyone, a team-based approach, I guess.
Thank you. Thank you. 我还是要
Just wondering, then I follow the question. I'm just wondering that if the patient receive ADT and they truly have a myocardial infarction,
yes.
would you recommend that you just stop the ADT, or you just try to do the other resuscitation? Thank you.
So I think we have to realize, again, back to the concept of permissive cardiotoxicity, what's important for the patients. If they really need the ADT, the question is whether we switch to an agent that is less cardiotoxic. And secondly, if they have a myocardial infarction, is whether we should subject them to PCI as well. Because prognosis for prostate cancer is great, and we should do whatever we can to manage the cardiovascular risk. Okay, thank you.
In the urology oncologist's opinion, we will stop the ADT because you holding the ADT, the patient could be die of the prostate cancer after 5 years. But if you stop this MI treatment, maybe he will die in 3 days. So we will stop the ADT first.
Yeah, I agree. I stop while we PCI, wait for a while before we resume.
Okay, thank you. 在这边还是要谢谢那个张医师啦，因为台湾的那个心脏科医师都很忙，有时候我们那个转过去的病人，有时候都没办法挂入这个号码。那张医师他特别包容，就是我们泌尿科这个部分，如果说有一些就是需要 ADT case， 或比较年纪大的，或者一些 comorbidity， 我们大概转过去，他都就是会在心脏科里面的科里面，让大家都能够去帮我们需要这些病人的注射，真的非常感谢。I thanks Professor Chen and thanks Professor Thank you, thank you.
We are going to start our afternoon sections. So first of all, I would like to introduce the moderator, Dr. Xueshu Kai from Chang'an Memorial Hospital. 我们欢迎就是第一位 moderator 薛书凯医师。
Hello, every expert of interventional cardiology. It's my great honor to come here. And I'm Dr. Shu Kai Xue from Kaohsiung Chang'an Memorial Hospital. And our next speaker, Dr. Young Guk, is from Severance Hospital of Yonsei University. And he just performed excellent demonstration of debulking for bilateral leg calcified lesion with HOC1 yesterday. And today, because of nowadays heavy calcification of lower extremity has been a big problem issue to limit the outcome of bilateral leg. And so lesion modification is crucial, and debulking all these triple-C device have been well developed. But what are we trying to achieve with debulking device in peripheral intervention is a great issue. And Dr. Young Guk will introduce for us and give a great talk. Let's welcome Dr. Guk.
Good afternoon. I'd like to thank Dr. Chen and Dr. Hong and the organizing committee for inviting me to this meaningful meeting. And also I'd like to congratulate on the 30 years anniversary of Chi Medical Center. it's my great pleasure and honor to come to Tainan and to Chimei Medical Center. Yesterday I had a very nice beef soup dinner, and it was really my pleasure. So as the chairman introduced, I will talk about debulking device, atherectomy for peripheral artery disease. So these are actually the tools we have for the treatment of endovascular treatment of femoral popliteal artery. So plain balloons, drug-coated balloons, bare metal stents, and drug-eluting stents, and also we have plaque-modifying devices such as atherectomy, IVL, intravascular lithotripsy, and specialty balloons like cutting balloon or scoring balloons. But these days, the drug-eluting technology have a superior efficacy in the treatment of peripheral artery disease compared to conventional non-drug-eluting devices. So I think drug-coated balloon and drug-eluting stents are the main tools we have for the endovascular treatment of femoral popliteal artery disease. So the question is, which one is better? So DCB or DES? So in the intervention, in the treatment of coronary artery disease, I think drug-eluting stent is the preferred one. But in the peripheral artery disease, there is still limited data and dispute. And there have been several randomized controlled trials comparing DCB versus DES. And as you can see here, for the intimate lesion length, 150 millimeters, lesion, and these two trials showed similar outcomes of DES and DCB. And another small randomized trial compared DCB versus DES for mean lesion length of 180, a little bit longer. And again, DCB and DES were similar in the in terms of primary patency and also in freedom from clinically driven target lesion revascularization. So we can say in randomized trials, DCB and DES are similar, comparable. However, when we treat our patients in real practice, then we see more complex lesions than we have seen in the randomized trials. So often our patients have lesion lengths longer than 25 centimeters. So what about the real world data? And this is recently published data from Japan, and Dr. Nakama published this data from retrospective multicenter cohort. And the mean lesion length was about 170 millimeters. This study does not report beta stenting rate and also the frequency of atherectomy, but they found the DES performed better than the DCB in terms of primary patency. However, the freedom from clinically driven TLR was similar between two modalities. Dr. Nakama concluded that for the lesion lengths longer than 150 millimeters, DES is superior to DCB. So he thinks DES is better, superior in longer lesions, in complex lesions. We also looked at our data, our retrospective multicenter data, and we published this 3 years ago, and we compared the conventional modalities with drug-eluting technologies. And the right side is the statistically balanced cohort. And in this cohort, we found no significant difference between DCB versus DES. And definitely, these drug-eluting technologies have a better outcome compared to plain balloon or bare metal stents. And this year, we updated our data, and we found that, again, DCB and DES showed similar outcomes. Even though the graph shows better outcome of DCB, but there was no statistical difference between two groups. However, when we break down the lesions according to lesion length, when we have a shorter lengths like shorter than 150 millimeters, DS is significantly better than DCB in terms of freedom from CDTLR. However, in lesion lengths longer than 150, then DCB worked better than DS. It is a little bit surprising because in Japanese data, DS was better than DCB. But I think the difference between Japanese data and our data is we have more use of atherectomy, about 15%, and also we have a beta stenting rate about 15%. So I think this may have contributed to a better outcome of DCB, but since these are not randomized data, so there must be, I think we should consider the bias of this data. But it is interesting to know there is some difference among cohorts. And well, how can I explain this? I think we have to know this anatomy of the femoral popliteal artery. So actually the femoral popliteal artery is the longest artery in the body, and it is exposed to various forces caused by the leg movement, joint movement. So there is compression and extension, contraction, torsion, and flexion. And if you have stents cover the distal part of the SFA and popliteal artery, and I think these forces must have some impact on the outcomes of stents. And this is very interesting picture. So on the left side, this is the lesion picture taken in legs straightened in the knee joint. So there is only focal lesion with pressure gradient of 10 millimercury. However, when we knee joint flexed, then we have two lesions. Here, focal lesion here and here with a significant pressure gradient. And when we implant here stent, then in the straightened leg, there is no significant lesion anymore. However, again, when we have the leg flexed, then we have another lesion below the stent because of the kinking. And so this requires another stenting. So now there is no significant stenosis anymore. However, the question is how long can last these stents? So, this is the result of bare metal era. However, the longer the stents implanted, the higher is the restenosis rate. So, and also when we have stents in distal SFA and popliteal artery, then there is an increased risk of fracture. So, and fractured stent have, I think it is not does not have a good prognosis. We also look at the outcomes of subintimal approach with beta stenting, and we compared spot stenting versus long stenting after subintimal approach. And our finding was that spot stenting performed better than long stenting. And especially when we analyzed this, then we found that long stenting extended to distal popliteal artery, especially P2 or P3 segments. They have worst outcome and had a poor impact of the outcome of the procedure. So that's why I think, especially at least for the distal SFA or popliteal segment, it is better to avoid stents. So we can say the DCB, drug-coated balloon, advantage is the leave nothing behind strategy. So it is least susceptible to mechanical stress caused by the leg movement, and it can also preserve all future treatment options. When we cover the popliteal artery or femoral artery with stents, then that interferes with the future surgery, and also if you have restenosis after stenting, then sometimes it's very difficult to treat and recurrence is very high. So therefore, when we treat patients with DCB strategy, and when the patient develops restenosis, and when the patient comes back, then we can always treat the lesion as de novo lesion. So I think that is the definite advantage of DCB. However, DCB is also balloon, and balloons have limitations. Like when we dilate the lesion with balloon, then after several minutes or several hours, there's the recoil. So initially, the vessel, the segment is dilated, but after several minutes, it comes back, and still there is a significant narrowing. And also in the calcified lesions or fibrotic lesions, when we dilate with the lesion with balloon, then it causes dissection, and also it leaves residual stenosis, which may require stenting. So we actually wanted to avoid stenting. However, because of recoil and dissection residual stenosis, we may have to implant a stent. And also in calcified lesion, it is not very good responsive to balloon dilation, and sometimes it also result in dissections and residual stenosis. So I think the long lesions, calcified lesions, and instant stenosis lesions, these are challenging lesions to DCB. And also in the various clinical trials, as the lesion length gets longer, the rate of provisional stenting or bailout stenting goes up. So in the impact long lesion cohort, the provisional stenting rate was almost 40%. So about 40% of patients required stenting, even though we tried to not to implant the stent using DCB. So it is not the result that we wanted before the treatment, right? So, and also in calcified lesion, especially when the calcium is circumferential, then the response to DCB is poor. So therefore, in order to overcome these difficulties, I think we need something that can reduce these difficulties. And I think in this effect, I think the atherectomy has its role. And with the atherectomy, we try to reduce plaque burden, and we achieve more lumen gain, and we can reduce amount of calcium, and also using atherectomy, we can modify the plaques so that we can have less dissection and less barotrauma. And also, it's important to preserve side branch, such as deep femoral artery. And with the reduction of calcium and plaque, maybe we can achieve improved drug delivery. So these are all potential benefits. So, and we have different types of atherectomy devices. So directional atherectomy device, Silverhawk or Hawk 1, and this, I think it is, we had a live case yesterday, which was treated with Hawk 1 device, and also rotational atherectomy device, and laser can also serve as an atherectomy device. And there there have been not much data, not much evidence for supporting the effect of efficacy of atherectomy for peripheral artery disease. Definitive AR is just pilot, small-sized randomized trial, which compared the atherectomy plus drug-coated balloon versus drug-coated balloon alone. So about 50%, 50 patients in each group. So it is a little bit small scale randomized trial. And in this study, it is not statistically powered. However, anyway, the two groups showed similar outcomes. However, in longer lesions and heavily calcified lesions, at least numerically, the combination of atherectomy and drug-coated balloon showed better results compared to DCB alone. But as I said, it is not statistically supported. And this is meta-analysis data published last year. And when we look at freedom from TLR, and this meta-analysis included atherectomy and also IVF plus DCB compared with DCB alone. And when we look at the freedom from TLR, it shows no significant difference between the combination therapy versus drug-coated balloon alone. However, bailout stenting rate is lower in the combination group compared with DCB alone. So we can say the modification of the plaque using atherectomy or IVL can reduce the need for bailout stenting. And other endpoints like major amputation and all-cause mortality showed no significant difference between two groups. And our center also analyzed our data, and it was a small population, but there was no significant difference between atherectomy plus DCB group compared with DCB alone group. So we can say for the later outcome, there is no significant difference. However, for the immediate outcome, we can reduce the need for bailout stenting. So I think it is still it's an advantage and the benefit of atherectomy to avoid stenting. So this is a case. As you can see here, the patient has some calcified spots, and both legs show the decreased ABI. And this is the baseline angiography of the left side. And when we look at this lesion with the IVUS, then we see the calcified arteries. And when we treat this patient with this lesion with balloon angioplasty, like this, then what we get is like this. You see here dissections, and on IVUS we can clearly see the dissected intima. And when we have this kind of result, then we can help but implant stents covering the whole lesion. And this is what we did. So on angiography, it looks very good. However, after 6 months, this patient developed restenosis. Okay, so and ABI decreased to 0.4. So I mean, this is bare metal error, and maybe we can improve the outcome with drug-eluting stents. However, hemodynamically, long stenting is not a for me, I think it is not a good treatment option. And let's see, it's another patient with bilateral lesions. And here, similar lesion, diffuse stenosis and the subtotal lesion. And we passed the wire through the true lumen, and then we performed directional atherectomy. And in this case, we always place a filter to protect distal, from distal embolization. And this is what we get from the directional atherectomy. And also we capture debris with the filter. And after, this is the result after atherectomy. And then we treat this lesion with the drug-coated balloon. And this is the result. Maybe there is some linear dissection, but I think the flow is good, so we can leave that. And on the other side, we treated the lesion with subintimal angioplasty, and we inserted to bare metal stent. And this is what we found at 9-month follow-up. The left side was patent, and on the right side, the stents were occluded. And this patient was followed up to 4 years, and still the left side remained patent. And another case, this patient shows calcification of common femoral artery on the right side. The ABI was 0.35. And again, here we passed the wire through the true lumen, and then we treated this lesion with a directional atherectomy device. And then finally, we treated this lesion with the drug-coated balloon. And this was the result. Okay. And 30 months later, we followed this patient with CT scan, and the lesion remained patent, and ABI was also maintained. So at 20-month follow-up. So not all lesions treated with atherectomy shows such a beautiful result. However, I think it is important to know that we can also treat this lesion without putting stent. And another patient, this patient shows a severe, heavily calcified femoral artery. You can on fluoroscope you can see the calcified femoral artery, diffuse long lesion, and we used Astato 40 gram, very stiff wire to recanalize this lesion, and it took a long time, but we finally succeeded to pass the wires through the true lumen, and then we used the jet stream. It is rotational atherectomy device. And we did several runs. And we treated this lesion with DCB. And this was the final result. And we didn't implant stents. And this is the I was finding. So sufficient lumen diameter after treatment of treatment with drug-coated balloon. And this patient followed 1 year with Doppler ultrasound, and the lesion remained patent. So but on the other hand, what is the optimal atherectomy? Yesterday we had a case, and one of the doctors asked me, how much we should remove the plaque, and that is a good question, but I think nobody knows yet. So this is what we found in a patient treated with the directional atherectomy device. This was the IVUS image before the atherectomy. This is after first run, and this is after several runs. So we excised so much plaque, but still a lot of plaque remain. So we can say we can remove some part of the plaque, but we cannot remove everything. So we cannot control, and we can remove. We cannot control the directions perfectly, and we cannot remove everything. So what we do atherectomy is not removal of the majority of the plaque volume, but we modify the plaque, and this is the data from definitive AR that I showed previously, and it shows if we have less than 30% radial stenosis after atherectomy, then this is associated with a good outcome. But this is small data. I think we don't have the good evidence yet. So, however, when we do too aggressively atherectomy, then we might get this kind of result. So we analyzed the debris, what we've had microscopically, and we found some part of the media, and also we had adventitia. And when we cut too much, then they can make injury to the vessel, and they can induce kind of aneurysmal change. So I think too aggressive atherectomy is also not so good. And distal embolization is a big issue. When you perform atherectomy, then we always protect the distal vessel from distal embolization. And there are several types of atherectomy devices. As I said, Jetstream is a rotational atherectomy device, and Hook1 is directional atherectomy device, and this is laser. And all devices have advantages and limitations. But for limited length of lesion with eccentric plaque, I think the directional atherectomy device performs better. However, when we have long lesions with heavily calcified lesion, maybe rotational atherectomy device can work better. So intravascular lithotripsy is a new phase on the market. Already frequently used for the coronary intervention, but for the peripheral intervention, I have no experience. But it can be a game changer, but we don't have much data. So this is, again, meta-analysis. It showed that IVL can widen the lumen diameter, and the complication rate is below 5%, so which is tolerable, and the bailout stenting rate is about less than 20%. So similar to atherectomy device, but this device does not cause much distal embolization. And this is a paper compared atherectomy, the DCB versus atherectomy plus DCB versus atherectomy plus DCB versus IVL plus DCB, and the lesions were common femoral artery, and the case numbers are only 30 patients in each group, so really very small data, and they found no significant difference between two groups. So I think it is too early to say IVL is better than atherectomy or not. But anyway, so we'll experience more data, we'll have more data of IVL in the future. So anyway, the current consensus says in moderate or severe calcified lesion, we can use atherectomy or IVL to modify the plaque, and then we can treat these lesions DS or DCB or BMS. So for the severe, moderate or severe calcified lesion, I think we need to have the plaque modifying device such as atherectomy or IVL. And again, the problem with the atherectomy is the distal embolization, and the problem with the intravascular lithotripsy is it has a larger crossing profile, so there are the limitations. And we also reported our IVOS DCB trial, which concluded that the intervention, the DCB angioplasty using IVOS performed better than angiography guided DCB angioplasty. So we didn't have sufficient data, the number of the patients treated with atherectomy in this population, but we can say that maybe IVOS can help to improve the outcomes of atherectomy, followed by DCB in patients with femoral pulpit artery disease. So what is better? So if we perform atherectomy, then we will have excellent immediate outcome, and we leave nothing behind. But on the other side, the downside of atherectomy is the higher cost. We need atherectomy device, DCB plus filter. And also it takes longer time and much more effort. And therefore, we also get more radiation, and the patient need more contrast dye. So it is early to say this, but I think we need to find the answer to that. So what are we trying to achieve with atherectomy? I think we reduce the plaque burden and increase lumen, and we improve the vessel compliance and balloon expansion in heavily calcified lesion. And also we try to minimize vessel injury by high pressure balloon inflation. And finally, this will optimize the drug delivery of drug-coated balloon, and also this showed that it can reduce the need for bailout stenting. Thank you for your attention.
Thank you for a great talk from Dr. Guo. And I think there's much more cases of debulking with like HOK1 or in Korea, then in Japan and Taiwan. And Dr. Guo showed a very good result with for long lesion treated with atherectomy and plus DCB. And is there any question from the audience? I have two short questions. First one, if like a long, the case you just show the long CTO of femoral pulmonary artery, after you passing the wire, will you routine check IVOS before the atherectomy?
Unfortunately, IVOS is not reimbursed in Korea. So maybe in Japan, Japanese doctors use almost routinely IVOS. So I think it is very important to check whether wire is interluminal or not when you want to use atherectomy. And if the wire was passed to subintimal channel, then there is an increased risk of perforation when you use atherectomy. So it is crucial to have the wire intraluminal. Even though you don't have the IVOS, still in a heavily calcified lesion, you can assume that the wire is just in the middle of the vessel. Then I think we can say the wire is intraluminal, and we can perform the atherectomy. And also, if we have a short length of subintimal space channel, then we think we can do still atherectomy. But if you have a long dissection, then I think it is a little bit dangerous.
The second question, because atherectomy device is still expensive in Taiwan, and it's not covered by health insurance. And will you try to use scoring balloon or cutting balloon before using this atherectomy device? Because it sometimes may cause dissection and maybe not feasible for further atherectomy.
Fortunately, the devices, the atherectomy and the filter, these are reimbursed in Korea. It's a very strange situation. Usually, such devices are not reimbursed, but these are reimbursed. So we often use atherectomy device in our procedure. As you said, we can also consider to use plaque modifying balloons, specialty balloons like a cutting balloon or scoring balloon. But I think we can use them only for very focal lesions. If you have long lesions, I think the efficacy of these specialty balloons are not as good as atherectomy or IVL.
Yeah, I also think so, but sometimes we have no choice. We still will try to use a scoring balloon for long lesion, but maybe the result not so good as yours. And I have an additional question. What kind of situation you will consider IVL after atherectomy?
I just asked Dr. Kashima. Actually, I have no idea of the IVL. So if the cost is okay, then why not? But it is always a question of cost, and hopefully the devices get cheaper with time, and so.
More chance for patient to use it. Yeah. Okay, and thank you again for Dr. Gao's very excellent talk. Thank you.
Yeah, thank you very much.
So we're going to move to the next section. So the next section, I want to invite our next moderators, Dr. Dian Ping Cao from Zhenxing Hospital. 曹定门主任。
Okay, dear Dr. Chen and colleagues. I'm Cao Dianping from Zhenxing General Hospital. It's my great pleasure to introduce Dr. Yoshifumi Kashima Sensei. And he's from Japan. Dr. Kashima is a good friend of ours. His present positions are Executive Vice Chair and Chief Director of Interventional Cardiology, Oita Cardiovascular Hospital, Oita, Japan. And currently course Director of CCT, and the course director and the board member of CTO Club, and the board member of Team CTO. And Dr. Kashima is a worldwide recognized expert in the treatment of heavily calcified coronary lesions, and a master of masters in rotational atherectomy. And he is the key contributor to the CVIT expert consensus on rotational atherectomy. His work has significantly advanced the contemporary strategy for atherectomy-assisted PCI. So today, the title of Kashima Sensei's lecture is How to Achieve Adequate Calcium Modification, the Role of Atherectomy Device in PCI. And let's give a warm welcome to Dr. Kashima. Thank you.
So I have never presented this concept in the abroad meeting, so this is the first time. Okay, so cracking technique, cracking effect is, and so, Okay, so these four mechanisms. So one is, and so prevent overstretching like this. If you can get in the cracking, then so you don't need an overstretching to get in the so good acute gain. However, no cracking, you need overstretch. It's a so very issue, a very severe issue, because the overstretch sometimes makes in the perforation and dissection, and so acute and chronic recoil. So cracking is very important. So also increasing vessel compliance. So you can see that, so 32 degree to the 140. But in the non-cracking cases, 37 to 80, compliance much different. And the intercalcification fracture is sometimes happen. What this? So you can see that. So you can see that so high density area and the low density area, calcium thickness is so thick. However, so after cracking on the compression, so a little bit compressed, even the so calcified part. So also in the so cracking, after cracking, so balloon compressed and the plug behind the calcification. So this is in the so cracking effect. However, cracking effect is not always enough. So you can see that. So this is my experiment. So this is a no rotabulation models. This is a 0.5 bar arterial ratio rotabulation cases, and this is 0.64 with the BA ratio. So for example, so target vessel is 3.0, so bar size 1.5. It means so 0.5 BA ratio. So and I explained so this model. This calcification is so much hard. So 20 atmosphere non-compliant balloon cannot make any calcium fracture. So result is much so easy and can be easy understanding. So if you cannot make any volume reduction, of course 24 atmosphere cutting balloon makes huge cracking. However, after that, so even the 60 atmosphere DES implantation get the acute recoil. However, very small volume reduction, 0.5 BA ratio. Even that and so volume reduction makes easy cracking, only 8 atmosphere cutting balloon, and so only the 14 atmosphere DES implantation, then good result. Getting larger volume reduction, of course, getting better outcome. Like this, 4 atmosphere cutting balloon, only 4 atmosphere mix and so, cannot work with pointer. Very good, so cracking here. And after that, only 6 atmosphere DES opening. So very nice result. So I can show you that. So non-volume reduction, then cracking, much dangerous. So good. Now cutting balloon makes and so dilated, and 10, 12, 14, 16, 18, 20, 24, bam. Explosion like so expansion. So of course, we can see the so good cracking after I removed the balloon. However, sometimes at that time, patient became the shock vital because coronary perforation happened, coronary dissection happened. So it is not so good effect. So almost always we need a volume reduction for this experiment. So this isn't so my question. Anyone can show me can answer to me what is a so good success case? What is a risky case? I cannot say anymore because I cannot any answer. Because even imaging device cannot show us risk aware the so calcified modification before the procedure. So this case, even short calcified regions. However, after cutting balloon, much smaller one, but makes coronary perforation. Case 2, also in the very short regions. However, makes the aortic dissection. Case 3, also very short region. This case, result is so-so. But nobody knows these result outcome before the procedure. So always we have to make the volume reduction before the cracking for any cases to keep and safe for the patient. So this is in a simulation of the AI. So of course, high Gemini, high and choppy, high shitty, but and they are not so good until now. However, so I make a lot and so to order the prompt, so they can answer the same result. If and so material and the same thickness and the same structure, of course component is important. You know, coronary calcification have and so a variety of so components. So if and so hard calcification 100%, of course, very hard. 70% calcification, 30% collagen, so. And 50% calcification, 50% collagen. Of course, we can make and cracking even with the same thickness and the same structure. Some component, same components and the same structure. Of course, thickness equal hardness, because component and structure are same. So hard thickness are so very thick and the components, of course, so much hard. Very thin thickness, of course, very easy to make cracking. However, you know, our so coronary calcification, much variety of the so component and thickness and the structure. So only thickness doesn't mean the so hardness. So nobody knows coronary calcium hardness even after the evaluating and so imaging device. So this is the next experiment, my experiment. So this model is not so hard calcification. So 20 atmosphere non-compliant valve makes easy calcium fracture. So everybody is considered, so no need volume reduction. Answer is no. So green square shows us and so volume reduction and cracking, then DES implantation. Yellow square shows us and so show you the so no volume reduction, not volume reduction, only cracking and DES implantation. Of course, acute gain are almost same, almost good. However, symmetrically index, only volume reduction and cracking and DES family are so good. But in the so cracking alone technique cannot make sure us and a good result about in the symmetrically index, not symmetrically. You can understand easily, maybe in chronic phase, these patients get chronic recoil. Only one case, IBL, shock wave, and so high radial force DES can get good lumen gain and good symmetrically index. But model perforation happen. So without volume reduction, always risky, always no good chronic result from my experiment. So this case is in the, so when IBL is not available in Japan, so I want to so ask and so Dr. Hawk, he's in the so he stay in Hong Kong. Please give me the so some case. So he gave me that case. Of course, he said to me, rotator is so maybe risky because and so this angle. So he chosen the 3.5 IBL, 4.0 IBL. However, 2 IBL cannot work well, these huge calcification. Final result, even high radial force DES makes and like this lumen, but symmetrically index still 0.5. So his comment is and so very nice. I should make volume reduction fast. Maybe this patient get chronic recoil. I agree with him. So, symmetrically index is important for such a DES error. Of course, we have a lot of data in the bare metal error about symmetrically index. However, DES is available. After that, we don't need not so good symmetrically index in almost case. That means that's a non-calcification case. But in calcified region, nobody knows symmetrically index is important or not in the DS error. So if you make a good region preparation, of course, you can put on the stent. 1 year TL, 1 year MACE is only 4.7%. But before the DES implantation, region preparation is bad. 1 year MACE is more than 20%, much miserable. So for using DCB, region preparation, lumen index, lumen symmetrically index, 0.7 more, 0.7 less, both are same result. 1 year MACE 11%. So from this data, we can consider the DES implantation after the good region preparation. But if you cannot get good region preparation, you should consider the DCB strategy. Okay, this is the mechanism of each device on calcified region. What is good region preparation? So, yes, non-calcification case. Balloon can work effect based on the 4 mechanisms: plaque compression, plaque redistribution, vessel stage dissection. However, in calcified region, of course, any balloon cannot compress. And so these hard calcification cannot be redistribution, of course. So always balloon required stretch, overstretch, and dissection. Sometimes perforation happen. On the other hand, cutting balloon and IBL makes cracking. After cracking, of course, compliance is relatively improved, and compress the plaque behind the calcification. So, however, these mechanisms only improved degraded basic performance. So we cannot achieve good result like non-calcified cases in the calcified regions. So we need unique mechanisms. It's volume reduction with low ablation. So this is AA simulation too. But a lot of physicians ask me, Sensei, cracking alone can work well for our cases. I want to say this answer. Of course, looks not so bad. This is 3 vessel and 5 micron calcification. Now, of course, this is in the concentric cases. If you get the good result with good condition for the cracking, best multi-cracking like this, intracalcium fracture 50%, maximum non-calc plaque compression 50%, and best plaque redistribution like this. Plaque into the between the soul calcification. DES implantation in vessel stretch by 10%. 10% more, of course, perforation possibility is very higher. So 10% is maximum vessel stretch over this proven that. So 3.3. Then we can get only 67% of reference diameter. So not so good. So always we need volume reduction before the cracking. Of course, cracking is so necessary mechanisms to conquer the calcified regions. So this is a reduction in the cracking technique concept. Always we need volume reduction from inside to the outside. So cracking, we can affect to the outside behind of the calcification. So React overcomes the disadvantage of volume reduction and cracking with their respective advantages. So we need combination of the both actions. So this data shows us, my data. So more than 700 calcification cases, bar arterial ratio 0.6, very nice. After that, cracking and DS implantation, then 1 year TR was only 2.9%. You know, a lot of paper shows us, and so in the calcified region, chronic outcome almost always in the around 10% to the 50% of the 1 year TLR. So much good. So if we make larger volume reduction before the cracking, before the DS implantation, we can get good outcome. So recently, my current optimal approach to calcified region is like this. Find the severe calcification, always root ablation. And if possible, enhance volume reduction effect. So not conventional rotor, only so I make the carbon rotor, max rotor. Max rotor is very difficult technique because so we need intentional control and wire bias. However, carbon rotor, of course, I show you soon. Carbon rotor is very easy. After volume reduction, so we have to make the good cracking, mulch cracking with so cutting balloon and so IBL. Of course, IBL is so good device to make the mulch cracking. But the cutting balloon is much cheaper than the so IBL. But the limitation, the cutting balloon has a limitation. It's always we need so more than 20 atmosphere, 40 atmosphere. It means so off-label use. So, however, volume reduction and cracking makes good result. So finally, I show you what is carbon root ablation. So this case is only short nodular calcification between this branch and this branch. So this is a proctorship case. So this Hirano sensei, he worked in the Toho University. He makes 2.15 rotor. Oh, very nice, I said to him. So after passing the rotor, he said to me, Sensei, I finished volume reduction. Then I want to move the cracking. I said to him, please wait, please root ablation more. I only comment something. Of course, same size, same wire, same rotational speed, same operator, but result is much different. Why? This is carbon root ablation. So after learning carbon root ablation, you can get the same result. This is on the right side, left side, and the 2.15 circle. This is around 3 circle by 2.15 root ablation. Okay, this is carbon rotor. So sometimes, you can see the nodular, especially the nodular calcification like this. So a lot of physicians said to that, this wire bias is not so good because it's near the vessel. But it is not true. This wire compressed to the vessel side by this nodular calcification, eccentric calcification. Wire bias means the wire wants to tend to the into the center, to the center. So this is the wire shift by calcification. So after passing the rotor once, then this wire to the center like this. So we can make rotor ablate more. So number 3 on these figures. However, everyone stopped the rotor ablation after passing rotor once. But my rotor ablation, carbon rotor, is just to start after passing rotor once. So that is the only different point. However, if push strongly, like this, so this power is same as the first rotor ablation manipulation, rotor ablator manipulation. Of course, this bar slip into this lumen because already you can make the rotablated ones. So you need to control the low, gentle bar manipulation and careful manipulation, extremely slow manipulation of the bar compared with so fast rotablation. Only that. Then so you can make so rotablated this surface to this number 3 part. Then you can get like this. So it's easy. During the curving rotation, always you can have that, say 1,000 rotational speed down, 2,000, 1,000, 2,000, already 1,000, 2,000. You cannot hear the more than 3,000. Because so if you make so strong rotablator manipulation with 3,000 more down, so it means the slip into here, this lumen. So not so good. So always extremely slow and careful manipulation compared with fast passing. This is a carving rotor. This is a champion cases. So you can see that if you can see this eyebars are very risky, wire bias not good. But I already passed the 1.5 rotor like this, so I can check the eyebars. After that, 1.5 rotor with carving rotor, I do that. Very good. This is a 1.5 rotor result, much different. At that time, this is so fast carving rotor, so I stopped here. But you can see that wire bias is still good. So if I continued and so this situation, I can get a much more volume reduction effect. So this is carving rotor. Okay, finally, I show you the experiment 3. If you cannot, this is nodular calcification model. Of course, I know a lot of physicians said nodular calcification doesn't have any good solution. I don't think so. Of course, conventional cracking and volume reduction and the conventional cutting balloon angioplasty, we cannot get a good result like this. Lumen gain and 4.4 and symmetrical index less than 0.6. However, you make carving rotor, then cracking, you can get good result like this. So I don't think so. I don't think the nodular calcification doesn't have any complete solution. I always conquer the nodular calcification. Okay, so this is a summary slide. What should you do? Always you consider that. You can say that, cracking, volume reduction. But it is not important. The important point is why should do. So cracking and the volume reduction lead to the easy cracking, easy implanted stent. So next step, how should do? So I always recommend you, please make volume reduction before the cracking for easy stenting. Thank you so much.
Thank you, Dr. Kashima. We are so lucky we can hear the most updated information from Dr. Kashima. Any question from our colleagues? Dr. Zhang?
Thank you, Dr. Kashima, for your nice talk. I always enjoy your talk and learn new information every time. So my question is, to be honest, my way to practice rota is quite similar as you suggest. I try to apply as slow as possible and without any resistance before I finish the rota ablation. But sometimes for longer calcification, if we try to do a very aggressive rota ablation, we're going to have a higher chance of slow flow. So at that moment, do you suggest to combine rota less aggressively and then maybe IVL or? Thank you.
Yes, thank you so much. So very nice question. So of course, we always consider that when do we finish volume reduction to prevent the slow flow? It's an important point. So yesterday, I have a live demonstration case here. That is so diffuse calcification case. So I don't use the carving rotor because I don't have any solution. So no nitroprusside, no nicorangel. Of course, at that time, my end point of rotablation is only one pass to get the good lumen to pass through the other subsequent devices. However, if lesion can allow that's much more rotablation time, then you can make the carving rotor or max rotor. It's okay. You can get a good result with that and any slow flow and no reflow. So always we consider timing and duration of the rotablation. You are saturate any regions. So of course, always trade off in the complication and good effect.
So when I do the case with case-file lesion and balloon can dilate the lesion and then put a stent, I always regret because the stent cannot expand nicely. So you emphasize the volume reduction before cracking. I think it's a very good option. And in your opinion, should combination strategy or hybrid strategy like rotatripsy or the rotor cutting or orbital tripsy of the cutting become the standard therapy in a very heavy case-file lesion?
Okay, thank you so much. That is a hot topic in calcified field. So I don't love OAS. Yes, I clearly say that. Because OAS for the beginners operator, because the OAS makes an orbital movement, it means that nobody control. So if you make orbital atherectomy, I make complication rate same. No need learning curve. It means the user friendly, but risk management is very difficult. Rotablator depend on the learning curve. So you make if getting 2%, 3%, 4% complication rate. My rotablation complication rate and less than 0.1%, including the very small complication. So much different. So always I make the volume reduction with rotablator. And so for the cracking, of course IBL suitable. If you can allow, and if government insurance allow the expensive and the value. Because IBL always can make multi-cracking. Very easy. But cutting is cheaper than the IBL. However, almost always one or two crack. So this is much different. And cutting balloon is needed, required, and off-label use. Rated pressure is 12. But sometimes we need 20, 24. So much different point. So currently I recommend it, and rotablator and IBL is best solution for the calcified regions. But IBL cannot compress. So after IBL, I always use cutting balloon for compress the calcification and behind the plug behind the calcification.
So the carving rotor is quite new to us. So my idea is after your presentation, the carving rotor is the same wire and the same per size and even the same rotation speed, but more time of more runs and more time. But avoid the speed drop more than 1,000 or even 2,000. Is that correct?
Of course. In any situation, so fast rotabulation is much more risky for any cases. Looks even easy. However, one pass, then almost physician finished. But my rotabulation, after passing once, then my rotabulation is just starting. Because so much safer, wire bias always to the center. So rotablator cannot touch the vessel wall. So everybody can try. Of course, and sometimes, and so you push strongly, then slip into the lumen. After that, you cannot get good, so additional acute gain. However, you can master the curving rotor. It means that only the just gentle touch and slow manipulation, you can get an additional rotablation effect without any risk. So please try it.
How about reduce the rotor speed? Because the previous concept with reduced speed may also get the additional.
Yeah, of course, and the low speed rotablation is so my original technique 14 years ago. It's the one with my max rota technique. Looks easy. Of course, please set and so 160, 140. It looks easy, but risk is a little bit higher because and so low speed rotablation makes orbital movement. So you can get in the good acute gain more. However, this bar, risk of the touch to the vessel wall. So little bit risky. But then the curving rotor is almost always safety. Much different point.
Thank you. Very good information. Yeah, thank you. Any question? We can have only one question. If no, thank you. Thank you, Dr. Kashima, for your excellent talk.
Thank you so much.
Yeah, thank you. We move to the next presentation.
So, okay, next sections we're going to invite Dr. Zhang Qirens from Chang'an Hospital and to introduce the next speaker.
So, good afternoon, everyone. I'm Zhang Qirens from Chang'an Memorial Hospital. It's indeed my great pleasure to introduce the distinguished speaker, Dr. Shoichi Kuramitsu from Sapporo Cardiovascular Clinic. He's currently the director of cardiovascular medicine of Sapporo Cardiovascular Clinic. And I think everyone know him very well about his expertise in physiology, imaging guide intervention, and also in managing complex and calcified lesion. So today he's going to share with us the other topic, how he applied DCB in the current PCI. I have the privilege to listen to his talk 2 days ago, and I found this really insightful. So the topic would be my concept of DCB angioplasty, when and how to utilize coronary physiology and imaging. Let's welcome Dr.
So thank you very much, Dr. Jan. So hello everyone, I'm Shoichi Kuramitsu from Sapporo Cardiovascular Clinic, Japan. So first of all, I really appreciate all of you for having me to this great opportunity. And also, but personally, I'm so happy to talk after Dr. Kashima, my mentor and my boss. And actually, this is the first time to visit Tainan. So once again, hello everyone. And so today's my topic, my concept of the DCB angioplasty, the when and how to utilize coronary physiology and imaging. So here today's agendas. So first topic is what is known about DCB angioplasty. So the current DS generation, they get mature. However, the late DS failures occurs rarely. And currently, DS represent novel therapeutic strategy. So this technology facilitate the leaving nothing behind strategy in clinical practice. Why the clinical evidence of DCB angioplasty? So everyone say, okay, instant restenosis is a good indication for the DCB angioplasty. So therefore, latest ESC or other country guideline carry one class 1 indication for DCB angioplasty. So, and several clinical trials demonstrate the de novo small vessel disease is also good indication for DCB angioplasty. So however, the limited data is available regarding the de novo region regardless of the vessel size. I mean the large vessel size. So the recently, the recurrent cage-free 1 trial, attempted to show the non-inferiority of DCB to DS implantation in non-complex region. So this is the key point. And here doesn't work. And here the successful predilatation criteria, no major dissection, so good TIMI flow, and the less residual stenosis. As a result, these trials failed to show the non-inferiority of DCB to the DS. However, looking at the subgroup analysis, please take a look at the left side figures. There was no significant difference between the DES and DCB. So supporting the current result, showing by the previous studies. And this year's 3-year outcome of the recurrent cage-free trial was presented, has been published in JACC. So once again, this trial failed to the non-inferiority of DCB to the DS. However, in contrast, last TCT, de novo solution trial was presented. Actually this is a RCT, comparing the solution DCB and the DS. Unlike the cage-free trial, these studies include the complex region. However, please look at the key exclusion criteria. In these studies, STEMI and the unstable non-STEMI were excluded. This is different from the cage-free 1 trial. And here the study flowchart, and this is the primary endpoint. Actually, here's DS, in this study, DS 4.4% and solution DCB 5.3%. Actually, non-inferiority was met. That's why the investigator concluded, at 1 year, a strategy of PCR-wise solution DCB and provisional DS was non-inferiority inferior to the systematic use of DES. This table summarizes the baseline demographic between 2 RCTs. Of course, there are several differences between the 2 RCTs. First difference is a clinical presentation. In solution de novo trial, ACS 33%, however, cage-free 1 trial 55%. Okay, so this is quite different. And also, as the cage-free trial focusing on the non-complex PCI, that's why calcified lesion were excluded. In contrast, solution de novo included the moderate severe calcification to 24%. However, please look at the use of atherectomy devices or IVL, just 3.6%. Okay, it means, this is just my interpretation, but it means these calcification is really not tough cases. Okay, and also intravascular imaging around 10% in both RCTs. This is my first comment. For now, whether DCB is non-inferior to, DS in de novo region, remain inconclusive. In addition, the impact of the different drugs on outcome has not been assessed directly. That's why further study are needed to address these issues. All right, let's move on to the second topic. When and how should we use DCB based on imaging and physiology? As already mentioned, ISO and de novo region are good indication for DCB angioplasty. In my clinical practice, we sometimes use the DCB angioplasty in complex region, including a Kashima region, and we sometimes use the DCB for the young patient and high breathing risk patient. And so this is a consensus document, so proposed by the Japanese Cardiovascular Intervention Society, CBIT. And please take a look at the step 3. So this is a very important point, so to decide whether or not DCB. So these criteria, so for example, good chemistry and less residual stenosis and absence of the major dissection and FFR over 0.80, if these criteria are met, so you can use the DCB only approach. So let me show you one case. Actually, the case is not complex, non-complex lesion. And the patient is 51 patient, very young patient, and present with chest pain during exercise. CAG showed the already tandem region. These are cranial view, so we can see the proximal and the little bit difficult to control. Anyway, we can see the proximal and the mid LAD. So, however, these region so are not so tight, just intermediate. So that's why we add the coronary physiological assessment. As shown here, the RFR 0.91, however, FFR 0.93. Actually, this is a discordant case between FFR and the RFR. And looking at the FFR probable recording, so we can see the 2 step up at mid and proximal, and the larger step up is observed at proximal region. So considering the result, of course, we should consider how we should treat PCI or OMT. And of course, the patient felt the chest pain and FFR positive. So I think you should consider the PCI. And last years, so we presented primary result of J-Pride registry. So this registry focusing on the prevalence and clinical outcome of discordance between FFR and RFR. As shown here, so FFR positive, NHPR negative region benefit from the revascularization. So however, the FFR negative, NHPR positive region did not. So of course, although these studies include a limited number of revascularized the FFR negative, NHPR positive region, so these findings highlight the clinical advantage of FFR guided decision making for revascularization in discordant region. Of course, we did the IBUS. This is the mid part. Of course, this region shows the intermediate region. So here are summaries. Looking at the mid LAD, MAA 2.6 square millimeters. However, this is the proximal. Proximal part, MAA 5.0 square millimeter, not significant. Considering these findings, this is my initial strategy. The patient is very young, so that's why, if possible, we want to finish the procedure with DCB alone. Anyway, back alone. So we tried the IBUS and FFR guided DCB angioplasty. We used the pressure wires as workhorse wires. So when you use the pressure wire as a workhorse wires, you can measure FFR anytime during the procedure. So this is the advantage of this style. For now, so there is no clear criteria for optimizing the DCB angioplasty. However, this is just my endpoint procedure endpoint, FFR over 0.0, IBUS MA over 4.0 square millimeters. In this case, we use a cutting balloon and the infrared gradually from the 6, 8, 10, 12, and this is the angiogram. So angiogram looks nice. So some doctor, okay, we put a stent or we use the DCB. And this is the IBUS. So IBUS, so as already mentioned, my procedure endpoint IBUS MAA 4.0. Actually, we can see the sum dissection. MAA 3.8, little bit below 4.0. And check the FFR 0.97, slightly below 0.0. Okay, so of course it's okay if you put a stent at this timing, but I wait for 10 minutes. So this is because we can see the sum dissection and the MAA little below 4.0 and FFR also below the 0.80. Looking at the angiogram, so little bit recoil, and the IBUS also, MA is getting little bit smaller, and the dissection little getting larger, bigger. And this is a summaries. So immediately after cutting balloon and 10 minutes later, as shown here, MA getting smaller, and also FFR decrease from the 0.97 to the 0.95. This is very interesting case from Japan. So this study include 5 de novo regions, and the physiological assessment, the FFR and the IFR and the OCT were evaluated immediately after DCB. Of the 50 regions, only 3 regions needed bailout stenting. So in the bailout stenting, FFR and IFR 15 minutes later was significantly lower. And also this study assessed the prevalence of red lumen enlargement. And in this study, 61.7% showed the red lumen enlargement at 9 months follow-up. And interestingly, post-DCB, FFR and IFR 15 minutes later was significantly higher in the red lumen enlargement group. So these findings suggest the clinical benefit of the post-DCB angioplasty assessment in de novo region. Of course, this, honestly speaking, I don't apply this style to all cases. Okay, so however, if necessary, I use this style. According to these results, I changed my mind. I put a stent, and this is the IBUS. Anyway, so MSA 5.2 square millimeters, and this is a FFR pullback recording. So after the post-dilation, so for FFR 0.83, and there was no pressure gradient, so within the stent segment. And so that's why we finished the procedure. So this is the final angiogram. So what is known about FFR and the imaging guided DCB angioplasty? So far, the evidence is not so many, so showing the clinical benefit of the FFR guided DCB angioplasty. However, this is one paper from Korea, Dr. Singh. So she loves the DCB angioplasty. She is my friend. And this studies, so FFR 0.85 was used as a cutoff point for deciding DCB angioplasty. So looking at these tables, so after the procedure, of course, minimal lumen areas was smaller in DCB group than DS group. However, looking at the 9 months follow-up, so red lumen loss, the DCB had a lower red lumen loss, so compared to the ES group. So this is the red lumen enlargement phenomenon. The stent and expansion is established as major predictor of stent failures. So far, there are several criteria regarding stent optimization. And also previous studies demonstrate the stent optimization link favorable outcome. So however, as already mentioned, what is the critical or what is the cutoff point of MA assessed by IVAS or OCT before DCB angioplasty? So far, once again, there is no clear criteria. So this one paper from Japan, also Japan, and this paper focusing on the plaque areas. So unfortunately, this paper did not focus on the minimal lumen areas. I don't know the reason. However, plaque areas, so less than 58.4%, so was available for the DCB angioplasty. As already mentioned, so we should avoid the major dissection. So if you want to finish the procedure DCB, but some paper reported so medial dissection led to the red lumen enlargement. But so far, I don't have enough data. So how much the dissection is acceptable? How much dissection is risky? So this is our clinical question. Okay, so this is my comment. So regarding the FFO and the imaging guided the DCB angioplasty. So this approach has a potential to enhance the safety and efficacy of DCB for de novo lesion. However, further study are required to establish the optimal approach using imaging and physiology. So let's move on to the last topic, potential of DCB for calcified lesion. So the patient with severe calcified lesion has the lower procedural success rate, higher peri-procedural complication rate, and poor clinical outcome. So that's why I would say the calcified lesion is a worst enemy for us. And recently approved analysis of AT-LCT demonstrated the calcified lesion result in worse outcome even with the second generation DS compared to the non-calcified lesion. Recently, we published the data regarding the risk factor of second generation stent thrombosis. Of course, the incidence of the stent thrombosis after second generation DS implantation was so rare. However, please look at the RE and the red stent thrombosis. So severe calcified lesion is one with the risk factor for RE and red stent thrombosis. So how about DCB angioplasty following the Debulking Devices? So there's some paper from Japan regarding this topic. So I show here, this paper suggested the clinical benefit of the DCB for the severe calcified lesion. However, the major limitation of the studies, the population number, all data less than 100 patients. So that's why, using our data set, we assess the outcome of the DCB versus DS in calcified lesion. And let me show you our data. So in these studies, 471 patients underwent PCI, using either DCB or DS size of less than 3 millimeters following rotablatus. At this timing, we could use the DCB for the small vessel disease. So nowadays, we can use the DCB for all de novo lesion, regardless of the vessel size. But at this timing, so just user for the small vessel disease. So that's why we focus on the small vessel disease in these studies. Here are the primary, the key slide, key figures. So the primary endpoint, the TVF, so DCB 50.1%, and the DCB 9.9%. So numerically higher in DCB than DS. However, there was no significant difference. So after adjustment in the baseline difference, so however, looking at the TVL and TL, so DS had a lower incidence than DCB. Interestingly, looking at the subgroup analysis, so the looking at the vessel, device size. So when the device size less than 2.5, I mean the 225 or 2.5, so DS was preferable. In contrast, when the device size 2.75 or 3.0, DCB is likely to show their benefit. So why? This is a very interesting point, but of course I don't have enough answer. So however, I will show you the one possibility. So this table summarizes angiographic and procedure result. As Kashima sensei already mentioned, so BAR to A ratio, so our target BAR to A ratio at least 0.6. Actually, in this study, we achieve BAR to A ratio around 0.6, so regardless of treatment strategy. However, looking at acute gain, in DES group, so there was no significant difference, so between regardless of the device size. In contrast, in DCB group, the acute gain was smaller in the small device size. So these findings suggested, so Kashima region is likely to be recoil. So of course this is our speculation, but actually this result, is opposite result of the previous studies. As already mentioned, the small vessel disease is a good indication for DCB. Actually, several studies supported the concept. However, once again, so this study shows the opposite result. So that's why we should consider, we maybe change our mind, our thought. And also, residual percent DS, is often used as one of the criteria for DCB angioplasty. However, in these studies, there was no significant difference between over or less 30%. However, looking at the percent to DS less than 20%, of course, there was no significant difference due to the small numbers. However, there was no event at 1 year. It means, as Kashima sensei already mentioned, if we can optimize the lesion preparation using low tabulator or IBA or cutting, and the actually residual percent DS less than 20%, it's like a stent. If so, we may get the optimal result of DCB angioplasty for the calcified lesion. So this year, I will present the another data at EuroPCL. Actually, not yet published, not yet presented. So that's why this is confidential. Please don't upload this slide. So just keep in your mind, okay? And actually, I'm focusing on the impact of stent and expansion on long-term outcome, okay? And the definition of stent and expansion, minimum stent area less than 5.0 square millimeter on IBERS or 4.5 on OCT. And actually, I use almost same database. And in this study, 418 patients were included. Of 324 patients with DCB and expansion occurred around 30%. And looking at the long-term outcome, so I show here, so optimum stent group so had a significantly lower incidence of TLF, 3-year TLF than DCB. In contrast, there was no significant difference between suboptimal DES and DCB. So this finding suggested once again, so we should try to optimize lesion preparation in Kashua region. Actually, this is a key point. So for the better outcome in severe Kashua region. Ouch. Okay, so this is my comment. So I would say, so DS implantation so remain the preferable treatment strategy for Kashua region. So however, DCB angioplasty may serve as an acceptable alternative to DS implantation. So in certain cases, as well as the complex region when stent and expansion is likely to occur. So finally, I would like to talk about the Kashua noodle quickly. So you know the Kashua noodle is a real worst enemy. Recently, Dr. Akiko Maehara's, so she's one of my mentors, so reported the elective Kashua noodle so resulted in worse outcome compared to the non-elective so Kashua noodle. However, personally, we should consider, regardless of the type, Kashua noodle so what was worst enemy. So recently, so we assessed the outcome of rotablators for the Kashua noodle region. So when I worked at the Kokura Merma Hospital, and in these studies, so we got the larger stent areas in the Kashua nodal group with the aggressive rotablators. However, outcome actually here's Kashua nodal region, so resulting in worse outcome even after rotablators. So this is a representative case. So the region is suboptimal or subtotal region, and we got the excellent result with stenting and the rotablators. However, the patient was back to our hospital only 2 months later. And this is the IBERS after recrossing guide wires, and we can see the instant Kashua nodal. So, you know, the DCB is a first line for the instant restenosis. However, in these studies, so this is our data, so DCB had little effect on instant Kashua nodal. Okay, so this is so that's why Kashua nodal is unsolved issue. This is my last slide. So outcome of actually our data, and this is unpublished data. So using our center data, so Kashua nodal, focusing on the Kashua nodal. So DCB angioplasty, so of course the incidence of the TLR was numerically higher. However, after the adjustment in baseline difference, there was no significant difference. So because Kashua nodal group include more complex patient and the region characteristics. Okay, so here are my take-home message. So DCB represents a novel therapeutic PCR strategy. So whether DCB is non-inferior to DS in de novo region remain inconclusive. So imaging and physiology guided PCR may enhance the safety and efficacy of DCB for de novo region. However, since the evidence is very limited, so large-scale RCT or registries are warranted to establish the optimal approach based on imaging and physiology. So DCB has a potential to emerge as an alternative treatment for a certain calcified lesion. However, further study are required to clarify its clinical implication. Thank you for your attention.
Thank you, Dr. Kuramitsu, for the excellent, insightful presentation. So I think we have maybe 3 or 2 minutes for discussion. Any question?
Thank you for Kuramitsu-sensei's excellent speech. You know I am a physiology guy, so I have a physiology question for you. We know that after we do the balloon dilatation, the balloon hyperemia or dissection or acute recoil may have influence on the result of a physiology result. So according to the Yamamoto-sensei's study, we need to wait 15 minutes to check FFR. But by the BK Cook recent study, he said maybe we check FFR by 5 minutes, 10 minutes, and by 15 minutes, the result will change. So, but in the daily practice, I think it's difficult for us to practice. So what's your opinion on this strategy?
Thank you very much. So I know you're a physiology guy, so that's why you can wait 15 minutes. However, most physicians, okay, so cannot wait, maybe. So my answer is, as already mentioned, for me, I don't apply this style to all region. So actually, in this case, we really want DCB, we really want to finish the procedure with DCB alone. So because the patient is very young, the lesion is very focal. So however, we change my mind. So that's why my answer is it depends on the situation. It depends on the reason. So if possible, you should wait at least 5 minutes, at least 5 minutes. But maybe you don't have to wait 10 or 15 minutes. It depends on your catheter situation. Okay, your boss say you hurry up. If so, you should wait 5 minutes. Okay?
We're a bit behind, but I think we can take the last question.
Kuramitsu Sensei, well, thank you for your nice presentation. I enjoy it. I have a question for you because the DCB use in PCI daily practice is getting more popular now. Even in Taiwan, I think that maybe a DCB mania. So I want to ask a question is, because there is no clear criteria or something like image or physiology criteria for DCB DCB alone strategy. We just based on the angiographic guidance, maybe less than 30% recoil and flow was okay, no limited dissection. So I want to ask a question that any suggestion that by the physiology or image not to apply DCB in de novo lesion?
Okay, so actually your question is so nice question. So yes, actually we don't have enough answer. Okay, so as already mentioned, there is no clear evidence, no clear criteria for the DCB angioplasty. So that's why this is my practical comment. Okay, so I know some doctor love the DCB angioplasty. So regardless of the situation, he just adhere to the DCB angioplasty. However, my style is a little bit different from them. So my style is if I have some concern about the complication. I mean the little bit risky of acute closure or something, I don't hesitate to put a stent. So actually, looking at the evidence, for example, leg-free trial, there was these trials fell to inferiority of DCB. Of course, the solution DCB showed a different data. However, for now, we have just 2 RCT. And also there are several differences. So that's why, once again, there is remain inconclusive. So the key point is the safety and the efficacy of our procedure, so for the patient. So that's why it's, of course, this is maybe not perfect answer for your question, but you should decide the procedure based on your thought, your policy. So far, it's good enough. This is my just comment.
Okay, thank you. So I think time is up. So I would like to thank Dr. Kuramitsu again for the nice talk. And I think we have to move to the, thank you.
So we're going to move to the last section about this part. So I'm going to invite Dr. Shi Zhiyuan from our hospital to introduce the next speaker.
Good afternoon, everyone. I'm Dr. Shi from奇美Medical Center. I'm here again, and I'm happy that everyone is awake. And the next speaker is Dr. Hong Jun-sen. He graduated from National Defense Medical University, and he finished his training of internal medicine and cardiology in our hospital. And he's now the director of our cath lab. And Dr. Zheng, I think Dr. Hong will give you 15 minutes to wait for the FFR study. And next I will speak in Mandarin. 洪医师现在是我们的这个心导管室主任啊，那他在这个心导管方面的造诣呢、技巧，还有这个知识都相当丰富哦。那我想他是一个这个很受医师病人喜爱的医师哦。那他这个不只人长得帅啊，歌也唱得好，还很会打鼓哦，这样子。那今天要给我们的题目哦。Today, Dr. Hong's speech will be entitled "The Update of Current Guideline and Evidence for Coronary Artery Disease and Peripheral Artery Disease." Let's give Dr. Hong a big welcome.
Thank you, my boss, Dr. Shi. And first of all, I want to thank Dr. Ku and Dr. Kashima and Kobayashi sensei. It's very excellent talk, and I learned a lot, and I am very impressive. And of course, I want to have my speech in Mandarin because I think that I don't want you to miss my information. 首先，我要谢谢上面的3位老师们啊，这国外的讲者都讲得非常好，我是学识非常多。那也感谢有这个机会在这边有一个小小的跟大家分享一下。那其实呢 ，I am a image guy。好，我是一个做 PCI 用影像学帮助我的 PCI 的这个进步的哈。那接下来时间呢，因为刚刚前面的讲者讲了非常多的一些所谓的technical 的一些问题，包括 PCI 包括我们做周边的一些血管要处理的非常多的一些问题，这些钙化怎么处理，这 technical 你看到有很多数字要怎么去运算都很复杂。接下来的时间我要跟大家 update 的，大家都绝对都应该都比较清晰，就是我要 update 一些最近的2、3年的一些 guideline， 告诉我们说，我们做完那么辛苦的 procedure， 我们这些病人到底要怎么照顾？特别呢，我会 focus 多一点在这些药物的治疗上面，希望给大家一些资讯这样子。 那这个是我的 outline 哦，就是我想要表达的是，其实 CAD 跟 PAD 刚刚前面的有3个 session， 横跨了非常复杂这些病灶，其实都是我们每天都可能会遇到的。我们做完处理以后呢，那我们现在这个治疗指引啊，或者是有没有新的一些证据告诉我们要怎么做？还有呢，有什么我们是这个错过了没有注意到的事情？第一个就是我们刚刚看到有什么心脏血管周边血管还有其实我认为脑血管其实都是所谓的 ASCA 就是 atherosclerosis 跟 cardiovascular disease。是血管动脉硬化相关的这个疾病这样子，那这些疾病它是全身性的，所以它的重叠性很高。所以如果有这个 concept 的话，那我们的照顾病人就比较简单，因为这3类型的病人，你其中看到1类，大概另外2类大概处理就雷同了虽然现在还是有一些有一些争论的一个地方，包括以前有提到过脑中风能不能心导管，现在可以了以前不行，我在住院医师的时候还不行现在可以。那主要有一些 concept 呢，给大家看一下这个3个疾病，它不管是这个主要的 concept， 3高控制应该都一样有时候以前的数字很多，让大家都搞混了。现在呢，慢慢的越来越多证据证明说，其实这个治疗上3个是趋向一样的包括之前的一些血压的控制包括血脂的这个控制的数值呢，应该是趋向大家都一样。那戒烟、复健、饮食、运动，这个没有问题嘛？因为这些病人呢，他患病了以后呢，其实呢，可能都会面临到一些功能性的一些问题。那再来呢，在药物治疗上面呢，那既然有3高，那就很好去思考了，就是你的血糖的控制血脂的控制血压的控制包括呢这些病人是心血管疾病嘛，所以呢他的血管呢多多少少可能会有一些所谓的血栓斑块的一些形成，所以抗血栓治疗也在里面。那为什么不讲抗血小板治疗呢？我待会提到因为抗血小板治疗是其中一种而已。然后血管重建刚刚有看到有很多专家们都有提出，那复健其实很重要不过复健我们今天没有时间再覆盖到了所以平常我们照顾到病人，然后中风的病人CAD 的病人AMI 的病人，我们都要出来会诊我们的复健科同事们请这个复健老师帮他们做一些复健这样子。戒烟当然很重要了那在最近有个很大的艺术减重嘛那个瘦笔或者瘦针这样子那都是可以非常突破的。那以下呢是比较 update 国外的，包括 ESHA 的这些2024年到现在的一些概念，还有一些台湾的那第一个 concept 呢就是抗血栓治疗。那抗血栓治疗为什么在这个心血管疾病那么重要呢？那常常就是只要诊断这个所谓的 CAD 或者是脑中风，其实都需要了那因为呢就是刚刚科苏玛先生里面呢的 slide 呢也有提到说这个血管里面有一些东西那可能要切开，有一些钙化。那事实上呢这些东西就叫斑块，黄色的地方。这些斑块呢是现在我们知道呢，可能就是氧化的一些血脂沉积在是我们的血管的一个内皮的下方，堆积多了以后呢，这个所谓的内皮破裂了以后呢，就会跟我们的血管接触，之后产生这个所谓的血小板凝集，产生这个血栓的一个形成，就把呢后面的血流阻断，会受到影响。这个影响竟然会影响到病人的临床症状。那当然在脑部就是可能会急性脑中风，在心脏可能是心肌梗塞。这个图是该在上面的图我们知道心肌梗塞有分2种，一种是 STEMI， 一种是 non-STEMI。当然我们照顾上就不太一样因为 STEMI 要非常快呢，要进去导管室，要做 primary PCI， 把这个血管打通的同时，你还要给抗血小板跟抗凝血的治疗。non-STEMI 的病人呢，可能呢就没那么急。当然有些病人其实呢，他在某些程度上呢也是很急，比如说他已经不稳定，他 VT 啦，或者是 cardiogenic shock 等等呢，可能要2个小时呢把这个血管打通这样子。那当然抗这个血栓的一些治疗等等呢，我们或者是我们要做怎么去取决这个病人到底要不要去做介入治疗，其实我们有算一些这些 scope 的 system 去分类 有些病人是稳定，有些病人不稳定了，所以不厌其烦，就是有时候接到病人的时候，还会问很多事情你要问这个病人 vital sign、年龄等等，他现在 presentation 怎么样？就是我们是希望透过这些 scoring system 把风险高的这个抓出来，我们赶快呢可能要做一些介入的处理那当然，抗血小板治疗通常在急诊室可能都会用到了包括传统的 aspirin 跟后面的所谓的新的发现的一些所谓的 P2Y12 的一些 inhibitor， 传统的有 clopidogrel 就是 Paris 那后面呢我们医院也有了这个 prasugrel 跟 ticagrel， 现在我们医院都有了。不过要注意看看，我们拿到的 prasugrel 呢，其实这个剂量呢跟国外的剂量不太一样，台湾跟日本的剂量是所谓的低剂量是标准剂量的大概是1/3。不管 loading dose 跟 maintain dose 那都有4个大型的研究去佐证它那因为亚洲的剂型呢只有日本跟台湾有嘛，所以它的 number 数会低一点，所以呢它就做了一个这样所谓的 Pacific， 没有比传统来的差它就上市了。但是其他呢，包括 Paris 啦，或者是 prasugrel 然后 ticagrel 都有大型的研究佐证，给我们的这些药物去做使用。那当然这些药物呢，其实建议在所谓的 acute myocardial infarction 或 ACS 的病人呢，希望呢你就是会用上 DAPT， 所以比较没有问题就是如果今天接到病人理论上 ACS 呢，应该就用上 DAPT 了在急性期的一个地方。那当然，如果说今天已经进入相对病人已经慢性期了那过完1年以后，我们定义1年以后病人呢比较没有所谓的心肌梗塞发作，不需要再做介入的病人，超过1年，我们定义他已经进入 chronic phase。那 chronic phase 的病人，到底这个所谓的 DAPT 2种抗血小板的药物需不需要呢？那这些所谓1、2、3、4、5、6个研究就告诉我们了前面的5个是抗血小板，最后一个浅绿色的是 aspirin 再加上 viloxibam。极低剂型2.5的 BID， 那发现说前面呢那5个呢看起来好像有一些或者是单用一些 Paris 好像有一些帮忙，但是没有很显著，所以现在呢在大部分的guideline建议我们1年过后呢，其实你可以考虑 tap 到所谓的1种抗血小板的药物，那这一种呢又以所谓的 Paris alone 就是所谓的 clopidogrel alone 比起 aspirin 来的好但是呢Compass trial 比较特别它就是把高风险的 CAD 的病人跟 PAD 的病人抓出来，发现说它居然可以减少 mortality 那这个 trial 其实已经经历很多年了10年这个时间那时候出来是非常轰动因为大概也只有它横跨出2个事情，第一个就是他第一次尝试在慢性期的时候用1个抗血小板的药物加上1个抗凝血。还有极低剂型呢，去证实说在高风险的病人，他的所谓的抗血栓治疗还是对于这些高风险的病人，包括 PAD 的病人是有所谓的风险的下降，特别是所谓的心血管的一个死亡的一个下降这样子。那当然，他多吃1种药的话，那我们知道他出血风险是比较高，所以在慢性期高风险的病人，你就评估一下这些病人呢，到底他需不需要用这些药物？那他的出血风险高不高？梗塞风险高不高？就是我们需要帮病人的因为随着时间，病人呢这个时间过去的话呢他的所谓的 bleeding risk 跟 ischemic risk 都会变化我们希望中间取得一个所谓的折中的方式这样子。那到底该来怎么告诉我们呢？就是2025年 HA 跟ACC 的该来，他跟我们说，如果你真的担心这个在急性期的时候呢出现这个所谓的bleeding 的问题 DAPT 的话，可以考虑这个1到3个月以后呢可以转换成 ticagrel monotherapy 可以减少出血的风险。那它的 reference 呢就洋洋洒洒的就写在下面那所以呢，在 ACS 的病人的话呢，我们到底要不要用 DAPT？ 答案是在急性期1年内是要的那但是他要用多久，要看病人的 bleeding risk 而定。bleeding risk 越高的话，它的所谓的 DAPT 使用的时间可能就越短了那以现在研究的话，大概可以做到1到3个月左右。那当然还有另外一种，我不要 DAPT， 我还是要维持 DAPT， 但是 DAPT 的所谓的 P2Y12 这个药物的话呢，它的强度下降 所以有2种方式作为考量，一种就是 short depth， 我就是2种药物减成1种药物，另外一种呢就是 depth de-escalation， 就是把所谓的 potent 的 P2Y12 potent 就所指的就是 ticagrelor 跟 prasugrel， 那当然这种都是所谓的欧洲的文章，所以在这个 prasugrel 的剂型就是传统剂型，我们现在台湾暂时没有这个药。好那这个讲了就头很昏，所以帮大家整理一个表，我们现在台湾能拿到的抗血小板的治疗的药物，在 ACS、CAD 的可以用到的，就是这1、2、3、4、4种这样子。然后刚刚提到那个所谓的标准剂型的Prasugrel 的10 ml QD 的这个呢，没有在我们这次在我们台湾可以使用了哈。那当然也有一些研究再去，刚刚有提到说1到3个月的 ticagrelor 其实是这篇文章去佐证的，然后就是所谓的 TRIAL 这个trial 去讨论说7000多个高风险 CAD 的病人那他的这个DAPT 能不能提早在3个月以后呢就把 aspirin 拿掉，只留下 ticagrelor？ 他的答案是肯定的他的 bleeding 风险增加，但是呢他的 ischemic risk 在右图是2者呢是没有差异。那当然，在另外韩国呢也有做了另外一个研究是雷同，也是3个月以后呢把这个所谓的 DAPT 把 aspirin 拿掉同样得到同样的结果。后来呢又有新的一些 trial 去挑战说，那我能不能呢把这个也是把 DAPT 呢这个停掉呢？然后看起来呢比较特别，就是这类型的研究后续呢就是把说，因为当然你增加 DAPT 它 ischemic risk 下降，但是增加 DAPT 的长度的话 bleeding risk 上升所以后来的研究呢 primary endpoint 呢就会化成说它的 CV 的传统的 mass 再加上 bleeding 的 risk， 他认为这样才是总括来看到底病人的所谓的 net clinical benefit 到底有没有用那当然 stop step 2的稍微成功了以后呢，就进展到所谓的 stop step 3这个研究里面它更积极就是一开始呢就是把这个所谓的 DAPT 想要拿起来这样子，直接进入这个 P2Y12 的一个 monotherapy。那知道这个研究其实是在日本做的，所有都是日本人，所以他们拿到这个所谓的 Prasugrel 的药物，其实是跟我们台湾的剂型是一样的那看一下他的结论他的结论就是我们一开始就 PCI 了以后呢，就把这个 depth 呢直接停掉，剩下1种药物这样子。那它剩下1种药物呢，它有不同的转换的方式，这边不跟大家细数了它的结论就是说，在1个月的时候呢，这个把它直接呢，在一开始就把它转成所谓的 P2Y12 alone 的话呢，它的这个出血风险呢是没有下降，但是 ischemic risk 有一点点上升，所以这个要注意。所以其实呢，所谓的 stop step 3这个 trial 呢，原则上呢它是尝试失败了好，那当然后续呢，在NAGM 大家应该有注意到，最近呢去年年底呢有连续 publish 2篇文章，也是尝试说，我是不是早点把这个 depth 这个停掉有没有这个好处这样子那当然早点把 depth 的话呢，其实呢可能会增加 mass 的一个风险，这个是要注意。所以有时候这住院中有时候会诊说，那洪医生我能不能把这个所谓的depth 停掉，那你就要很注意这个病人到底他现在的 bleeding risk 高不高。但是如果说没有什么理由他 bleeding risk 不高，贸然把这个depth 停掉的话，其实病人的 mass 的风险是会增加的那看一下我们为什么讲这个议题呢？我们统计了有一阵子统计了我们医院的500多个 STEMI 的病人我们排除了所有的死亡以后呢，发现一个事情很特别。既然呢这个出院呢，因为任何原因没有给 depth 的比例其实不低大概也有差不多9%，所以10个病人其实有1个，所以我们要知道说这1/10的病人为什么会把这个 depth 停掉的主要的原因。 那这样才可能会减少。那当然这个是我们 real world 的研究嘛，所以我们的临床的医师应该就 adjust 过它的一些风险。所以可以看到红色的stent thrombosis 最怕就是你刚刚做完处理，这个 stent 支架又塞掉了哈。那我们这个统计起来，我们 stent thrombosis 比例是0这样子哈。所以跟大家做一个小总结，在这个所谓的抗血小板治疗在所谓的 CAD 这些病人上面的话，现在呢，在一般的建议是建议你还是1年呢要吃满这个 depth 但是某一些出血风险高的病人的话，也许可以考虑1到3个月之后呢，转成所谓的P2Y12 的 monotherapy。那刚刚还记得就是这个 monotherapy 呢，其实以所谓的 ticagrelor 的 monotherapy 为优先考虑这样子。当然还有另外橘色盒子的这种区块，就是把所谓的 potent 的 depth 转成比较低强度的一个 depth 这样子，但是它的建议强度就没那么高了哈。好，这个是小小的做这个血小板在 ACS 上面的一个结论了，在目前的guideline还是建议12个月了哈，出血风险高的可以考虑缩短啊。最近有更多的证据指出，可能是不是可以减少缩短 short depth 的一个可能性呢？那最后的guideline其实是建议说，你还是要个人化治疗了哈，你要看一下这个病人他是什么样的病人，他的梗塞跟出血风险高不高而定，来取决你的药物治疗这样子。好，那我下一个第2个阶段，我进入所谓的 CCS 就是 Chronic Coronary Syndrome 就是这些病人呢，在 ACS 急性过后呢，他进入比较慢性、相对稳定的时候了哈。那是不是这个稳定是不是呢？我以前都觉得说 stable CAD 应该就稳定，稳定应该不会发病嘛，其实不是。所以第一个呢，我们对于这个事情会 miss 掉一个事情那在 CCS miss 掉什么呢？其实这是所谓的1年过后的，我们觉得是 stable CAD 的 CCS 的病人，其实它不是稳定的。还是有呢，大概2成的病人呢，在未来的这个发病后这个 DAPT 过后的1到3年，还是会持续产生这个 ACS 的事件这样子。那当然，每次产生 ACS 的事件的话，它可能呢这些心脏功能呢就会变差了所以这些所谓的 chronic 的病人其实并不是 stable 的所以 chronic 不等于 stable。那哪些病人才不 stable 呢？那在 ESC 的一个guideline上面呢，也给了我们一些指示包括这些病人 CAD 呢，它是比较复杂的多条血管，它这个 CAD 是有 DM 的病人，他以前有 AMI 过，还有这些 CAD 的病人，如果他有 PAD， 他也是风险高。所以有 CAD 的病人，最开始第1张 slide 要记得，就是现在呢，你只要接触到 CAD 的病人，其实他潜在风险可能是一个潜在的没有症状的 PAD， 可能潜在的他可能是一个中风的一个潜在风险的病人，所以要特别注意，这些病人都有可能会再次发病那发病呢，有这些林种种的 risk factor 发病的这个几率多高呢？其实呢，可以增加了差不多85%的一个几率这样子。那另外刚刚我们提到过 COMPASS trial 呢，不是说我们就是探讨说1年过后严重的 CAD 的病人加上 PA 的病人他的这个风险能不能下降？有了，刚刚有提到过。其实呢，这个 COMPASS trial 呢已经证实说，在这些高风险的病人，如果他只吃 aspirin如果是 add on 这个所谓 Viloxazine 2.5 ml BID 的话，它可以降低未来大概1/4的一个 mass 的发生率，大概降低了25% 的一个相对风险这样子。还有这个 trial 里面呢，很特别就是它大概呢就是超过90%了，大概90%的病人的 CAD 的病人，所以我那时候认为解读这个 trial 应该是一个 CAD 这个 trial。那当然它后续因为 PAD 了。结果实在太好了，所以呢，在 PAD 另外，他又开启一个所谓的 Voyager trial 里面呢，那我没有附上来因为这个不然这个slide 实在太多了。那可以注意到，刚刚说它其实是一个很独特的一个 clinical trial， 因为它佐证在所谓的以前觉得 chronic stable 的病人，但是 high risk 的，其实它并没有那么 stable。 当然我们刚刚说要减低死亡率，它到底减低了什么死亡率？这个是它里面的死亡的分析，发现说它减低的死亡率呢，主要来自于所谓的 ischemic heart disease， 所以确定是如果你 add on 一个更好的一点点的一些所谓的抗血栓的一些治疗的话，对于这个高风险的病人呢是有帮助。那这个 table 刚刚已经有跟他 run 过一次，我这边不细数。那同样的，在2024年 AHA、ACC、PAD 的guideline上面呢，它的抗血小板的建议呢，其实也是雷同了哈。在红色盒子有跟大家画出来了，它是认为在 stable PAD 的病人如果他可以的话，可以加上aspirin 加上 viloxazine 2.5这种 DPI 的组合。然后另外一个就是他刚刚做完这个通血管呢，刚刚做完这个钙化，像 Dr. Cole 说这个钙化的处理，他用了那么辛苦的一个术式把它打通了以后，其实也可以直接转成所谓的 DPI 的治疗，对于这些病人都有帮忙所以不管是所谓的在 PAD 病人是急性期，或者是他在慢性期，其实这个 regimen 都是可以用了哈。那这个是 AI 帮大家整理的一个 table 了哈。那就在 standardize 的时候呢，在 CCS 跟 PAD 的病人是可以考虑所谓的SAPT， 就是单一的单抗的血小板了哈。那 aspirin 跟 clopidogrel 呢，看起来呢在 clopidogrel 呢又好像优于 aspirin 了哈。那当然要碍于这个健保给付的一些规范呐。那当然，对于所谓的刚刚有提到过 high risk CAD 跟 PAD 的病人呢，其实呢，他可以考虑说，可以考虑这个 DPI 的治疗哈。好，那我们进入到这个第3个 session 对于 lipid 呢，哇 lipid 这个章节是非常大的一个章节哈，我尝试尽量summarize 一些重要的资讯跟大家看。先看一下现在最近的一个建议，最近的建议其实呢就已经越来越 aggressive， 越来越积极了哈。那数值上呢，你会看到说在数值上呢就好像是越画越低这样子。那以前170，那现在可能有听到50、55等等这些数字，或者是40这样子哈。那看到2023年 TSOC 就是台湾的心脏学会的 CCS guideline， 对于所谓的极高风险 extremely 这个 risk 的病人呢，它的定义是以前有 ACS multiple 的 MI， 还有呢 complex 的 multivessel disease， 它 ACS 有 DM 有 PAD PVD 其实是多血管血床的疾病了哈，就是它可能合并其他血管有阻塞。比如说他以前有脑中风 cardiac stenosis 等等，这些都高风险。它高风险呢，它是建议你说你要压到非常低的这个2023年是50这个数字可以看到吗？那当然它是引用了一些文章的一个数据。那在ESC 它甚至呢认为 extremely risk 就是刚刚有提到过 ACS multivessel disease 等等复杂的，希望你可以呢 LDL 下降到40那台湾也有很多2022年、2025年的一些guideline可以看到这些数字。那原则上刚刚有提到过了，其实它的数值上都是越要求越低了哈。那为什么越要求越低呢？就是因为太多证据越来越出来说，你可能进一步把这个LDL 血清里面的 LDL 压到越低的话，它存在的残余的风险会进一步下降，看起来是一个直线的关系那当然，我们的药物是有限的。我们过去传统的药物就是 statin， 它能够下降的幅度是很有限的。所以呢，我们现在呢，就是除了 statin 以外呢，所谓的 non-statin 的 lipid lower therapy， 然后有很多其他的药物可以辅助非 statin 类的在2025年台湾的这个所谓的血脂这个guideline上面呢，他说极高风险，希望你降到55那55它有什么策略呢？你不是说你就嘴巴讲讲，然后建议他饮食运动好好睡觉就可以了这个是没办法嘛因为有些时候我们饮食运动是能下降的有限，所以他给你采取一些策略。我们先看一下刚刚那个策略的那个字很小，先看一下为什么会这样建议，就是因为如果以我们现在的 performance， 我们的表现 全台湾的表现其实不好我们希望这个数值要达到70好了哈，这个其实比例也都不高，更不要说55了，55连2成都不到所以这个代表说我们整体的这些台湾的病人的话，他的 LDL 的控制呢是没办法并不是很好的。那如果是这样的话，以我们现在除了 statin 以外呢，还有什么策略可以使用呢？就是除了 statin 以外的，包括我们可以有的说是这个所谓的 ezetimibe 或 PCSK9、sRNA 或者是其他一些药物等等，待会再细数。那这个是它的一些 table。那为什么会建议你合并其他药物呢？就是因为合并其他药物的时候呢，它的 LDL 下降的幅度会更好。可以看到右边呢越往右边，它就是 combined therapy， 你会看到它下降可以达到60%、70%，甚至有一些合并呢可以降到80% 以上的 LDL 一个下降。所以一开始呢，你就要取决说我这个病人的目标多少，来取决说他到底可以用什么药物来使用，来达到我可能一个 target 这样子。那这个是一个 ESC 的 concept 原则上他就说，statin 你就尽量用中高强度嘛，他病人可接受就是在 tolerance 它的最高的 statin 的一个强度不行的话再加上 ezetimibe， 不行呢就加上现在呢台湾其实有的这个 benzidolic acid 这样子就可以减低这些病人的血清的 LDL 这样子。那它就是有一些策略了那红色的笔呢就有跟大家说了，但是它主要的策略还是以 statin 为首或者是为主的一些治疗策略这样子，所以 statin 还是最主要的一个治疗。那又以高强度的所谓的 rosuvastatin 跟 atorvastatin 这个10 ml 跟40 ml 这些剂型以上的为主这样。那我们看一下，除了 statin 以外呢 ezetimibe 的表现那看到 ezetimibe 呢是其中一个很重要的 trial 叫 IMPROVE-IT trial， 是蓝色这个 trial 可以看一下蓝色跟绿色那个区间其中有一个叫 IMPROVE-IT trial， 是第一个非 statin 证明说持续降低 LDL， 它对于这些所谓的 ACS 的病人呢，它的未来的风险可以下降的一个很重要的一个 trial。 那后续呢就是还有其他的一些 trial 也佐证类似的一些所谓的 non-statin 持续减低 LDL 的可以改善病人的这些假说。那现在呢已经越来越多证据去指向这个了那刚刚有提到过 ezetimibe 其实也有它的一些证据，包括早年的 IMPROVE-IT，后来呢，有一些所谓的 IVUS 血管内超音波，这 precise IVUS 的一个证据那当然它使用的是 atorva 加上 ezetimibe。那另外 racing trial 是韩国的就是 rosuvastatin 再加上 ezetimibe。可以看到这些这个都是你进一步下降血中的 LDL 呢，可以有效下降病人未来的 MAS 的风险这样子。benzidolic acid 的话是最近呢，我们台湾是有的这个药物这样子那它的代谢的路径呢，跟传统呢有一点点不一样，从传统的 statin， 但是是同一个 pathway。但是呢，可以看到传统的 statin 呢，它会影响到一些 muscle 的一些代谢 metabolism， 所以呢，有一些病人呢，他有时候就吃不住，他会肌肉会酸痛这样子。那这个benzidolic acid 呢就比较不会影响到肌肉这个代谢的路径，所以 benzidolic acid 呢对于所谓的 statin， 因为这样子 intolerance 的病人的话呢，其实就是非常好的一个武器，可以有效下降这个 LDL。当然，它有一些前驱的一个实验证实它是有效的下降，大概下降呢就是20% 左右了这个血中的 LDL 下降。那它有没有什么 outcome trial？ 有，它也证实说这些所谓的 statin intolerance 病人呢有吃 placebo 吃这个 bempedoic 比起 placebo 的话呢，它在所谓的 MAS 的风险下降呢是有13% 啊，还有呢刚刚有提到过 LDL 的下降，这个 study 呢大概就20% 这样子。比较特别的这个研究也是说可以看到，居然病人呢所谓的 high sensitivity 的 CRP 啊，它的 reduction 也有20几个%，啊，这个是比较有趣的哈。那另外呢，可以看到说，其实除了口服药物呢，我们也有针剂的一些药物去发展这样哈。2025年呢 ACC AHA 的 ACS guideline 上面呢有提到说，你可以考虑呢，就是 early the better， 早一点使用这类型的药物的话呢，可能对于病人的预后是有影响的哈。那当然就是针对 ACS 的病人啊。那为什么这样说呢？原来呢，他早年呢，大概已经快10年了哈。这个有2个研究哈，一个是2万多人这个 4-year trial， 2个都是 PCSK9， 一个是 Yoshifumi 那另外一个叫 Audit Outcome Trial，快2万个人了哈，18000多个人是 Yoshifumi 哈。那 Yoshifumi 呢是一个 ACS 的研究他发现什么事情？那2个居然在传统的 statin based 的研究里面呢，他用这个 PCSK9 呢进一步下降这个血中的 LDL 呢，获得在追踪上面获得同样都一个数字，都是15% 的一个风险下降所以后来呢就大家就可以使用这些药物了那健保也是有条件可以给付的特别是对于那些ACS 的病人他的 LDL 下降的幅度不高，或者是呢他有家族遗传性的高血脂症那另外呢，在 Yoshifumi 里面呢，也有对于所谓的 primary prevention 的病人，还没有发病、没有 MI、没有 stroke 的病人，他这样下降有没有帮忙？有，下降幅度更多，减低25% 的一个风险的下降这样子那平均呢，这个 LDL 呢已经降到多少？40了所以呢。那么多 trial 也不断的跟大家报告说，其实呢，血中的 LDL 呢是正比于我们未来的心血管的风险。如果我们想尽办法只要有有效的方法可以下降血中的 LDL 呢，就可以有效减低未来的风险。那是不是故事到这里就结束呢？那显然就不是了还有更厉害的看到这个 inclisiran 这个药物针对 PCSK9 所谓的 LDL receptor 它可以呢减少这些所谓的 PCSK9 的这些 protein 的蛋白质的生成，和减少 LDL 的 receptor 的降解，从而呢可以减低血中的 LDL 的一个浓度这样子。那当然这种呢是这个受惠于现在科技的发展因为它类似一种所谓的 mRNA 层面的一个所谓的基因治疗。那它有没有study 也有了Victorian trial 里面呢，其实看到有非常高 CV risk 风险，有病人有高血脂症的话呢，实际上呢，它的 LDL 呢可以下降到60%左右这样子。然后它的所谓的 LDL 下降到55的达成率，比起 placebo 比起来是天差地远就是蓝色左边那个图，可以接近超过80%的病人可以达标这样子。然后呢，他的肌肉酸痛发生的比例，那可想而知嘛，因为他打这个针应该不太会影响到他肌肉的一个代谢，所以他的肌肉酸痛的一个比例呢是没有传统的来的那么多这样子那刚刚那3种药物，包括传统的 PCSK9 每2个礼拜打1次，包括这个 inclisiran 它打针的这个频率会拉高。可能是半年1年打2次，那当然事实上呢，这个药费都是蛮贵的1年大概药费大概是10几万了也供大家参考。最近很热门的最后花一点点时间看一下最近很热门的这些所谓的 lipoprotein 小 a 这个事情。lipoprotein 小 a 为什么会被放大呢？就是因为说，为什么有些病人他 LDL 下降了以后，他还是会发病呢？发现说有一些病人居然 lipoprotein 这个 lipoprotein 小 a 的话它是高的，还有呢，这个他没办法用传统的这些 statin 的药物有效的下降。大部分这些病人呢，这个90%呢都是遗传性的，就是 genetic 影响的，所以这些病人就无解了嘛所以这个时候呢，我们就看一下我们可不可以有别的一些治疗的一个药物可以治疗 到这些风险这样子。那左边呢这个图呢，左边这边呢是传统的 LDL 的一个 pathway， 右边呢是 lipoprotein 小 a 的一个 pathway。那所有的盒子呢都是现在 ongoing 或者是已经上市了，或者是有一些 ongoing 在 clinical trial 的一个药物所以未来呢，对于这类型的一些病人呢，他就有更好的一些药物可以使用来进一步减低病人的心血管的风险的一个下降这样子。那这样好像对我们距离很遥远的话，那事实上我们现在有一些药物其实也有一点帮忙啦，包括我们的这个打针的 PCSK9 或者是 inclisiran， 其实都有不同程度的下降这个 lipoprotein 小 a。所以在一些更有效可以下降更多的药物还没有发展以前的话，这些药物都可以考虑让病人可以就使用。那传统的药物有没有？我们刚刚说 statin 传统的没有什么下降那个幅度嘛，但是呢可以看到所谓的这个 niacin。它其实呢，好像呢还可以下降的不错了，但是对于 clinical 这个 benefit 来讲的话，是暂时没有很多的实证医学去证明它到底有没有减少这个心血管那个风险了那这个是一个keynote 给大家参考一下这个我就不赘述了那看一下最后面一点点，就是PAD 到底有没有呢 ？PAD 感觉很可怜的那好像很多 trial 都抛弃它，事实上没有。最近 PAD 也是很热门，很多 clinical 都找上它了包括这个很多这种所谓的 PAD 的一些病人他可能肥胖走不太动啦他 claudication， 那他就研究这个 semaglutide 对于一些病人到底有没有帮忙这样子了那当我们叫 semaglutide， 它对于 Type 2 DM 的病人，他的 CV 的 outcome 好像是有一些帮忙了特别是高风险的病人这样子，他就做了这样的 clinical trial， 他发现说有打针跟没打针他发现一个事情，他走得比较远呐还有呢他的体重也不晓得是走得比较远体重下降，还是体重下降才走得比较远这样子，也给大家稍微思考一下了不过昨天跟 Dr. Cole 呢，他在聊天的时候他说他其实跑马拉松他跑了一次之后，他就说他的膝盖就压起来了膝盖就痛，所以他说要跑步瘦身的话，应该要先瘦身再跑步这样。我觉得也蛮有趣的，可以打个针再来跑步这样那当然还有一些所谓的糖尿病啦跟血压的一些帮忙这样这个是它的一个 clinical trial 一些数字那还有呢这个 trial 里面也有发现说其实它对于一些 mass weight 呢也有一些下降的一些帮忙这样子好，那我最后讲一个 case 好了就是这个是60岁的病人presentation 是一个 AMI 的一个病人，其实很早了已经蛮多年了，是一个 Williams syndrome。然后很显然他就不是很复杂嘛，我们就做了这个放了这个支架然后就帮他处理。那就问一下，这个病人的 risk 高不高？应该高了他是这个 AMI 的病人，有一条血管这样子那可以看一下我的治疗是怎么样。我的治疗就是说，他那时候应该是 LDL 的目标是要70嘛，所以他的原本是160、150这样子，所以这样还不错啦，就吃一个 Atova 40呢，应该就快到70了嘛那时候就差不多就70了就犯了鲁迅先生他就差不多先生这个问题，所以我就差不多了很多年。发现说，后来他就产生这个 DM 这样子，那肾功能也开始往下，因为他后来也诊断一个肾脏的一个 cancer， 然后后来呢，就发现说这样好像不太行，这样子，某一天我就觉得应该要把他的 LDL 再下降多一些那这个时候呢，再加上这个ezetimibe 那看起来还不错这个 LDL 就下降到这个 around 50左右。结果他又胸闷了过了好几年，2018年到2025年，发现说这个支架有没有问题？支架没有问题但是呢，他的 RCA 的恶化，所以他呢就放了第2支支架。在血管内的超音波也证实说它是斑块累积，还有一点点钙化所以还好不需要再磨它了那这个时候呢，就发现说它的风险呢就已经增加了，随着这个年龄 ，AMI、DM、CKD、PAD、polyvascular disease 那应该呢数值以现在要求可能要55级以下这样，所以那时候就建议说，那不然你来打 PCSK9 好了，然后他也说，很好啊，这样应该要再下降多一些哈。所以这个病人呢给我一个 lesson 呢，就是说，他呢我们这些病人在照顾上面的话呢，应该他的动脉风险的会变化的啊，我们应该要依病人的不同的变化来调整我们的一个药物的治疗这样子。我来快速到最后一章哈。好，最后就是这张了哈。这张就是2024年的 guideline 其实告诉我们，其实我们这些病人要做非常多的事情了哈，然后有一些很多的内容没有时间跟大家这边报告，希望之后还有时间跟大家好好的去探讨这样子。那以上是我的报告，谢谢。
谢谢洪主任把这个 SCVD 我们怎么照顾我们的血管从 ACS、CCS 到这些 prevention， 不管 primary 还是 secondary prevention 都整理得很好
About this one, actually, let me kind of introduce, invite my moderators and to introduce the last speaker. Yeah.
Hi, everyone. Good afternoon. I'm Jade Liao, and today it's my pleasure to introduce our speaker, Dr. Hattori. Dr. Hattori is an assistant professor in Department of Cardiovascular Medicine at Cardiology Center, Tokyo Women's Medical University Hospital. He received his medical degree from Tokyo Medical University and earned his Doctor of Medicine from Tokyo Women's Hospital University with broad clinical training spanning from the Okinawa Shubu Hospital, to the University of Utah. And Dr. Hattori brings both domestic and international perspective back into Japan. And now, just please join me in welcoming Dr. Hattori.
So thank you for introduction. Thank you for inviting me to Shimei Medical Center Symposium today. So I will be speaking about today current pathway to advanced heart failure and cardiogenic shock therapies. So first, let me introduce my hospital. So our hospital is located in the center of Tokyo. Our hospital has CICU, PCI capability, temporary and durable mechanical security options, as well as heart transplantation. So between 2019 to 2025, 550 patients were supported with temporary MCS, including balloon pump, impeller, and ECMO. So the lower left figure shows the temporary MCS modalities. So the majority of patients received balloon pump alone at the initial device, followed by ECMO alone, a combination of temporary MCS and the impeller and ECMO. So the lower right figure shows the temporary MCS modalities. The lower right figure shows in hospital mortality by sky shock stage among temporary MCS patients from 2019 to 2022. The in-hospital mortality rate increased incrementally with advancing shock stage, rising from 1% in sky shock stage A to 49% in shock stage E. So these figures illustrate the hub and spoke model. Borrowed from the image of a bicycle wheel, the term refers to the hub, central part of the wheel and spokes that radiate outwards to the rim. The concept was first applied in the airline industry. local airport offers a flight to the central airport, which provides access to long-distance connections. The hub thus serves as a key point of coordination and distribution. Since the introduction in the 1980s, the hub-and-spoke model has been adopted across various industries, including product logistics and healthcare systems. So this figure illustrates a dramatic improvement in survival following LVAD implantation over time. In the landmark rematch trial, first 1 year survival with first generation LVAD was 52%, compared with 25% in patients receiving medical therapy alone. More recently, the Momentum 3 trial demonstrated the survival with the HeartMate 3. LVAD improved 80% at 2 years. But we should remember that these improved outcomes are not only due to advances in LVAD, but also appropriate patient selection. The key is to ensure that patients who need advanced therapies most can benefit from them. These are several red flags that should prompt evaluation for LVAD or heart transplantation, such as inotropes or recurrent defibrillator shocks. However, many patients are still referred too late, limiting their therapeutic options. So therefore, we encourage early referral. There is no need to hesitate. Referral is rarely too early, but often too late. So this is a representative case of referral to advanced heart failure center. 55-year-old woman, she presented at age 23 with reduced LVEF. Although her LVEF improved with medical therapy, it remained impaired. At age 54, she was admitted with worsening heart failure and reduced EF of 28. She developed BT after initiation of inotropes, prompting a transfer to our center for consideration of advanced therapy, including heart transplantation and LVAD. This patient had dilated cardiomyopathy with ventricular arrhythmias and wide QRS. After CRTD implantation, we were able to successfully wean inotropes. Before discharge, discussed LVAD heart transplantation with the patient and the family. We also maintained close collaboration with referring hospital. At age 55, she was admitted with ICD shocks and worsening heart failure. Despite prior optimization, her condition progressed. By age 56, she required resting for heart transplantation and underwent LVAD. So this highlights the progressive nature of advanced heart failure and the importance of shared care. So let's move on to the next theme of this presentation. So cardiogenic shock is a complex heterogeneous state of end organ hyperperfusion resulting from low cardiac output, frequently leading to organ injuries and death. As a field of temporary MCS, such as ECMO, Impera, and the valve pump, has developed, the use of temporary MCS to manage shock patients has increased in the last decade. So despite improved therapies for shock, mortality in shock patients remains high. In the shock trial, which was published in 1999, 30-day mortality in revascularization group was 47%. So in the landmarked danger stroke trial, which was published in 2024, the 30-day mortality remained still high at around 50. To improve outcome, several approaches have been proposed. So one approach is to define severity of shock for the purpose of risk stratification and decision-making in medical treatment and appropriate temporary MCS utilization. In 2019, Sky proposed a novel shock stage classification from A, which represent at risk, to E, which represent extremis. Since the release of classification, this scheme has been widely used in the variety of clinical settings. Another approach is to rationalize care delivery. Shock patients are candidates for advanced therapies such as LVAD or heart transplantation and requires comprehensive management from a multidisciplinary team. The members of this team include heart failure cardiologist, interventional cardiologist, surgeon, intensivist, VAD coordinator, and physical therapist. So multidisciplinary approach enables critical decision making in a timely manner. The third approach is to focus on healthcare system. As a result of increasing complex management of shock patients, the extensive resources are required to maintain shock care. To facilitate regional care coordination and resources, a new approach of treatment for shock patients focused on healthcare system beyond the medical therapies. So this figure illustrates the progression of care setting from ER to community hospital, specialized ICU, facilitated with PCI capability, and finally, advanced center offering LVAD and heart transplantation. Hub centers are equipped with advanced temporary MCS, surgery, LVAD program, and a well-established multidisciplinary team culture. Spoke center typically have PCI capability. The balloon pump is the most commonly available temporary MCS modality, although some centers may also have access to impaired devices. So now we present the first case of shock patient. 48-year-old man was admitted for STEMI at the hospital with PCI and temporary MCS availability, but no LVAD. He was performed PCI 2 years before admission. Echo performed before admission showed a normal AVEF. This hospital 200 kilometers away from our center. At the ER, blood pressure was 82, he was intubated, ECG showed ST elevation, and he was transferred to cath lab. The angiograph revealed total occlusion of area D and LCX. After initiation of Impera, PCI with placement was performed. He was admitted to ICU. And we got a consultation as he was pretty sick and had eligibility for advanced therapies. At that time, because he had chance of recovery, he was continued therapies for winning temporary MCS at site. After removal of Impera, he was gradually deteriorated with requirement of CRRT. So we discussed again about eligibility for advanced therapies and decided to initiate Impera 5.5. Taking into account the geographical consideration and resource availability at local hospital, Impera 5.5 was placed at site. After that, his renal function improved and talked with patient and his family about the possibility of LVAD and heart transplantation. through with video conference and the decision made to transfer. So this figure shows clinical course of this patient. After arrival at our center, the patient suffered pneumonia with the requirement of re-intubation, but eventually listed for heart transplantation and received LVAD day 99. The patient continued to do well 3 years after LVAD operation. As shown in this case, there are several key frameworks to improve outcome in hub and spoke model. First, pathway for referring a shock patient should be created. Because shock patients require urgent decision-making, telephone is preferable. In addition, rapid response from hub hospital is essential. Second, hub and spoke hospital have to agree shock management and share decisions. Especially it is important when there is a large geographical distance between hub and spoke hospitals. Also, shared care improve communication between hub and spoke hospital. We could improve management of shock advanced heart failure, such as appropriate utilization of temporary MCS, patient selection, and timing of transfer. So this figure summarizes the role of hospital. In 2019, our center established a multidisciplinary team, which named BIND team, to provide shared care and address the needs of heart failure patients managed with advanced therapies. Since then, we focus on collaboration with other hospitals, such as referral pathways, case conference, education. We believe this process improved heart failure patient quality of life and longevity, as well as enhanced teamwork. But there are still unresolved issues. We present second case. 59-year-old man with hypertension was admitted at a local hospital for heart failure. This hospital is a 30-minute drive from our center. ECG showed atrial fibrillation, and the echo showed LVEF 25%. During the night, BT developed and the patient received a single shock. Blood pressure was 60 and transferred catheter. And angiography revealed no coronary artery stenosis, and balloon pump was initiated. Despite balloon pump placement with high dose pressures, the patient has deteriorated, and we got a consultation and made the decision to transfer. Because of risk of BT and VF, intubation was done before departure. During transfer, 5 minutes before arrival, PEA developed and CPR was performed. So on arrival, we put ECMO and Impera, and then ECMO and Impera removed day 4 and day 11 respectively, but CAT scan showed mass cerebral infarction and hypoxic brain injury. Consultation with the patient family, active therapy was withdrawn, and the comfort measurement was instituted. Shortly thereafter, the patient died. Safe inter-hospital transfer of temporary MCS patients can be challenging, given the highly specialized nature of this patient and the characteristics of the out-of-hospital environment. Poor communication during inter-hospital transfer is common and is a significant contributor to adverse outcome among this patient population, including missing clinical information leading to diagnostic errors or redundant testing, absent or misleading test result or clinical condition leading to mistriage, Utilization of standard checklist is one of the effective tools to improve communication. Decision-making of transfer is difficult. Proper patient selection may be important, but further studies are required. Ideally, specialized transport team equipment such as ambulance are desirable, but these extensive resources need institutional support and sufficient funding. So this slide shows how LVAD patients were referred and transferred to our center. Among 50 LVAD patients, 42% were transferred and underwent LVAD implantation during the same hospitalization. So 66% of these patients were transferred with temporary MCS. So in our region, the distance between referring hospitals and our center is relatively short. However, this depends on the regional healthcare system, so it's essential to establish an efficient transfer system tailored to each regional healthcare network. So another unresolved issues is training in advanced heart failure. In hub-spoke model, sufficient staff in hub hospital is essential. In Japan, there is currently no formal certification in advanced heart failure within the National Specialty Board system. Typically, it takes 5 to 7 years to obtain internal medicine certification, followed by an additional 3 years for general cardiology certification. Only after completing general cardiology training, physicians choose to specialize in advanced heart failure. At that point, they are often in their mid-30s to 40, making this career path less attractive given their uncertainty. So I believe this field is highly attractive as it offers knowledge and experience that cannot be gained in general cardiology and allows us to care for patients from a longitudinal perspective. However, significant barriers remain to be overcome. This is also true in the field of critical care cardiology. The management of complex patients require specialized training to staff contemporary CICU, like ventilator management, treatment of multi-organ system failure, and airway management are essential skills in the care of a CICU patient. These skills may not be sufficiently emphasized in general cardiology, although cardiology training would provide management of MCS, skills of echo and hemodynamic assessment. Currently, no consensus exists regarding the optimal pathway for critical care cardiology training. Designing critical care fellowships for cardiologists is limited, but will require collaboration between cardiologists and intensivists. So this slide summarizes several core frameworks to build hub and spoke model. The creation pathway for referring patients with safe transfer, shared patient management, and sufficient resources are key for success of this model. So after implementing of this approach, the number of LVAD patients has increased from 10 to 24 in 24 and 23 in 2025. The outcomes have also been favorable, with 1 year survival of 96% and 3 year survival of 89%. So this is last slide, our colleagues, and so close cooperation and two-way communication between health and spoke hospitals are key for success. So thank you for attention.
Thank you for our doctor introduce the practice in Japan, and we learn a lot from their experience and Japan suggestion. So we will enter to the next section.
等一下，我们会要麻烦就是成大医院副院长许志新医师来介绍最后一位 speaker。
大家午安，我是成大医院许志新。那很荣幸介绍下一位讲者廖家德廖部长。那我想大家对廖部长都非常非常熟悉啊。那介绍廖部长最困难的就是他永远 CV 永远比上次多一点这样子。那如果要介绍完，时间就用完了。所以我们还是简单介绍一下。那廖部长从北医毕业之后呢，其实他在伦敦呢，我记得是卫生跟热带学院还有政经学院拿到双硕士。那还有成大的公卫呢，还有比利时的鲁文大学拿到生物医学的双博士。那他目前也在台大攻读 MEA， 那可以看到他对医疗政策还有健康政策的一个热情。那他主要研究领域呢，在心脏衰竭还有心血管的医疗政策，还有在我们医疗经济学以及人工智慧。那所以在奇美医学中心呢，担任很多重要的职务，包括心衰竭团队的负责人，包括实证医学以及医疗政策中心的主任，还有医学教育部的部长。那今天呢，他这些丰富的研究以及临床的经验，相信会带给我们很好的分享。那今天主题是 Advancing Innovation in Heart Failure Management。那我们欢迎廖部长。
After consideration a lot, and at the final moment, I decided to speak Mandarin because our audience is from Taiwan. So I just pardon me, and I speak Mandarin for you. 今天我要跟大家好好聊一下这件事情，就是 innovation 在 heart failure 的这个治疗上面。那其实我一直在犹豫，到底我要讲的主题是偏向哪一边 ？AI 多一点 ，innovation 多一点，还是在未来的整个治疗的 framework 可以多一点，更完整一点点？那于是后来我把它定调从 guideline 到这个 systems of care 的这一块，我们怎么样透过 innovation 的这个部分，可以让我们的照顾的模式可以来得更好一点。那我本身心脏科医师，那等一下的这个 disclosure conflict of interest 的部分，第一个大概就是会讲到一些 AI。那我本身有一个 AI 的 startup， 那再来就是我是这个 co-first author， 然后再等一下会讲到这一篇的 study， 会讲到蛮多在 JAHA 目前刚刊登的这一篇。那以下大概跟药商没有什么特别的利益冲突关系。那再就是这些 research， 主要是 TSOC 的 heart failure 的 registry， 还有就是HA 的这个 program 里面做一些 support， 好，所以大概是这样子。今天想要跟大家聊聊这件事情 ，innovation 到底在 heart failure 治疗上面帮忙是在哪里？帮忙走到哪里？然后还有我们的心衰竭管理 management 到现在有没有哪一些比较新的一些更新？那再来是结构化怎么这样调整我们的整个 quality improvement？ 然后再就是讲到 innovation 的真正的这一块。在 drug, device, AI, molecular 跟 transplant 的这一块，然后再讲到一个 future outlook and take home message. We don't lack evidence, we lack execution at scale. 其实老实说，其实我们并没有很缺太多的实证，但我们其实缺的是更多的怎么样把我们执行力变成是一个可以规模化的这件事情，然后让它可以用在我们大量的这个病人身上。那创新一直在往前走，可是我们的照护品质真的有变得比较好吗？我们来看一下，全球目前还是一样，这么多人的这个心脏衰竭的病人，有6400多万的人处于心脏衰竭。那在美国，在预估到2050年还会有将近40% 左右的成长，然后也会花非常非常多的钱。那甚至预估这个死亡率还是接近在50% 左右。即使我们很努力了，我们很创新了，我们也放了好多的东西进去，但是好像并没有降得非常漂亮，如我们当初预期的这样子这么漂亮。那我们来看看我们的亚洲，甚至我们的台湾，我们 NIA 的这个使用率，我们的 target 如果跟西方相比，其实我们使用的是比较差的 beta block 或者是 RAS inhibitor。那特别值得注意的是，我们的男性的这个发生率比较高，平均年龄比较低。这代表什么意思？代表我们有工作力、有劳动生产力的人反而是比较多的。那这些人 正在经历的心脏衰竭，我们正在失去着我们的整个生产力，所以对我们而言，这是一个很大的警讯。怎么样，我们可以让我们的心脏衰竭的发生率可以降得更低，而男性的这个时间可以把它推得更后面，这在 innovation 里面就变成是一个开始的一个 point。在这个 Institute of Medicine 美国里面说，当我有一个 evidence 出现之后，到我真正可以 sustain 我的整个这个 adherence， 总共这一条路总共要走17年。原因是因为 guideline writing 写下来了，但我的 awareness 不等于是我 action。那 clinician aware 他了解了，但是 clinical inertia 其实并没有真正的接受这件事情。然后，即使我知道了，我也认真开这个药，可是当我的药物在调整的过程里面出现了 titration 的 fail， 然后或者是说我的 target dose 即使达到了，但病人都是 follow up， 所以每一个照护的过程里面都出现了照护漏斗，而我们有没有一个很好的一个 monitor 的一个 flow， 可以去 monitor 这每一个环节？我们设计的各式各样的照护的方式有没有可以去抓住每个环节，然后去进行更好的一个调整？这个在创新里面，等一下也许会秀给大家看，我们奇美医院是怎么做这件事情。那整个 guideline 的这个 landscape， 这样从2022年比较完整的整个 guideline， 不管 ESC 或者是 AHA 这样子 ACC、AHA 这边的公布，到现在2026年，我们走到哪里去了？我们回头看一下，2022年出来了 ACC/AHA 的这整个 heart failure guideline， 相对的是比较完整一点点。那走到了这个2023年 ESC Focus 的 update 出来了。加入了acute heart failure 的治疗，然后放进去了这个铁，然后在这个共病的治疗里面相对很重要。然后在2024年，我们可以看到，就是在整个 hospitalized 的 heart failure pass away， 它把它放得更重要，特别是在几个 quality 的 measures， 还有 program 里面的这个要执行的 measures。那在2025年，就是去年，其实百花齐放，包含了台湾，我们都有调整了很多我们自己的guideline的这个治疗。那到今年，我们会直接整合更多的治疗的 evidence 进来，然后同时间在 ESC 跟 HA 今年会有一个大幅度的一个调整。所以一路这样从22年走到26年，我们做了哪些事情？第一，也许大家已经不觉得这是 innovation， 但我还是要再讲，从头强调这一次，在4个 pillar 里面，不管是在 ARNI、ACI、ARB 的这个部分，其实我们已经用了。那在 pillar 2 evidence-based 的 beta blocker， 我们Carvedilol 或者 Bisoprolol 或者是 Metoprolol 这边我们也开始用进去，或者是 Naviprolol 我们也用了 MRA、Spironolactone 或者 Epinephrine 或者是新的 non-steroid MRA 等等之类的，然后包含了像 Pillar 4， 然后我们的 SGLT2 inhibitor DAPA 或 MPA 这样子来做使用。其实我们想要知道的是，现在的 ACC 2024年告诉我们，可以的话尽量在3个月内全部开到底、开到满，尽量在这3个月内做到。它可以的话，因为这会影响到他们之后的这个存活率，所以在整个 core principle 里面，住院这件事情它并不是 rest stop， 它其实是在创造一个可以让我们把这些药物给开上去的一个 window。所以在很多的 innovation， 它会从这个地方当成是我们的起点 ，startup 的地方开始往前走。我们怎么样可以让病人在这一段时间可以尽量接受到最满的这个 4 pillars 的这个药物？于是我们开始会在出院的时候做很多的 checklist， 我们会 check 它的 LV 的function有没有彻底的被评估，有没有尽快被评估，那这4大 pillar 的药物有没有被用上去，然后再来接下去的回诊，它什么时间该回诊，该什么时候在哪里被回诊，以及他住在哪里，他的经济的这个生活的这个整个 lifestyle 的 area 到底长什么样子 ，pattern 长什么样子，还有病人的卫教、家属的卫教是否有完成了。而这完成能不能透过 innovation 的 device 或者是一些 program 来完成，然后一些共病的评估以及治疗。所以对我们而言，在过去，其实我觉得这从2020年、2022年到现在26年，我觉得最开心的应该是说，我们过去从 HAPF 无药可用，或者是我们认为它可能在临床上面很常听到老师说 HAPF 就治疗共病啊，太胖的就稍微减肥，然后如果 AF 的话，可能 AF 要control，然后可能就是糖尿病的糖尿病要控制好，或者是怎么样等点。所以nihilism 就是虚无主义，在我们的这个临床上面不断的会出现，就是好像可以治疗，又好像我们没有什么武器可以治疗。但是到现在2025年，我们开始从 classical based 的 treatment， 我们开始走向 phenotype driven 的 treatment。我们 SGLT2 inhibitor 可以用在全部治疗这样子的一个heart failure 的病人上面，然后在 mid range 的 ejection fraction 的 heart failure 或者 preserved 的ejection fraction 的 heart failure 的病人，再加上 CKD， 我们可以用 finerenone 的这个 MRA 可以来做治疗，而在 mid range 或者是 selective 的这个 mid range， 我们也可以继续开始使用了。那具有了 P1RA， 我们可以用在肥胖的 HPF 的病人，我们可以使用。然后重点是 Class 1的建议，运动对于 HPF 的病人、mid range 的病人，其实是可以早一点介入，开始做运动。我们不再没有药物了，我们也不再没有治疗方式，而 mid range 以上的这些，我们现在有这么多的药物可以开始做治疗。而对于整个共病的管理，我们来的更加的多一点，然后包含了就是23年的 ESC 告诉我们，我们可以做哪些的事情。那我们可以看到，就是在共病的管理里面，包含了铁的缺乏里面这件事情，23年强化了静脉注射的这件事情，它可以改善整个症状、运动能力，还可以降低我们的这个住院率。那在现在台湾，我们不断的在 focus 在除了 cardiology 以外，还包含了 focus 在我们的 renal， 包含 focus 在我们的 endocrine， 我们的整个 CKM 的 framework 应该把它建构的更加的完整一点。它是从一个 stage 0到4的一个分期，代表了这个概念上面的一个转换。它把心衰竭视为心脏、肾脏还有代谢交互影响可以被预防的，所以包含了这个Asia 的这个cardiology 里面联合的一些声明，都告诉我们，预防心脏学里面，我们应该要跟其他的次专科开始联合起来照顾我们的心脏衰竭的病人，也许会是一个比较完整的一个照护模式。所以回过头来，我们先问自己一件事情：这些药物我们都有了，这些好像很先进的仪器我们都有了，可是我们怎么样可以让我们照顾的病人可以照顾得更好一点？它的 quality 怎么样可以更好一点？所以，于是对我们而言很重要的就是我们开始要设一些 majors， 所以包括 performance 的 major， 包含 LV ejection fraction 的这个 assessment， 药物有没有给了？然后它的 SGLT2 inhibitor 4大的 pillar 到底给有没有3个月内尽量给到？那我们要怎么去看它的 quality？ 包含了它的这个出院之后 follow up 的 schedule， 然后包含了它有没有使用一些肝癌建议的 AF 的病人有没有开始使用 anticoagulation ICD 的这个 console， 或者是说开始有没有做一些运动等等之类的。那对我们而言，其实它不再只是一个肝癌建议的一个 knowledge 而已，它是可以 transform 变成真的是可以被 measurable， 可以被 trackable， 可以被 accountable 的 care。我觉得这其实是我在今天我最想要陈述给大家的。Heart failure 很多 innovation 没错，但我们有回过头来把每一步走稳，然后让它可以被测量，让它可以被追踪，让它可以被当责这件事情。于是 guideline 能不能照着 guideline 往前走，就变成是很重要的一件事情。因为 care 不是只有被设计而已，它还包含了，就是它应该是要被设计 ，sorry， 它应该包含被设计，而不是只有被advising， 不是被建议而已。所以在我们最近的这个 JAHA 最近的这个期刊里面，其实我们run 了几件事情，就是从2005年美国一直在 run 这件事情，他们总共发现怎么样可以让这17年的 gap 从我写guideline到真的落实可以把它缩短。美国超过600多家的医院里面有参与这个活动，他们透过 workshop， 然后 webinar 或者是说一些 toolkit 等等之类的，然后来达成。尽量让大家可以了解怎么做这件事情，同时可以影响它的扩散力。从美国到亚洲，于是举办了这个 Asia 的这整个的这个活动。那的确看起来，台湾或者美国，我们在执行这个计划的时候，它的确是可以让 GDMT 整个的 adherence 可以拉高，来到40对上23% 左右。那对于台湾而言，我们在2021年到2024年，总共1991个病人，里面我们把它稍微分开。462个来自于就是 HR 的这个 program 的医院，然后其他的1500多个来自于其他没有参加这个 program 的医院。我们去做 GE 的一些统计方法的一些回归，我们可以看到，在这个 adherence 的这个部分的话，从2021年从差不多的起点开始往前走，最后可以走到53对上30% 左右。而这样子的一个差距，正来告诉我们一件事情：我们想要透过一些方式，然后让病人的 adherence 或者是 heart failure 的 care 可以来得更好一点。它需要被架构化，它需要被 program 这件事情，而这些的 program 需要被创新，而不是就传统的一些方式可以做到这件事情。所以对我们而言，不管是在 4 pillar 的 GDMT， 或者是 SGLT2 inhibitor， 或者是 MRA， 或者是 follow up 等等的这些，其实都有明显的改善，在这一次的这个参加 program 的这几间的医院里面。所以回过头来，如果在照顾心脏衰竭的病人里面，我们一直在追求 innovation， 等一下后面会讲到很多。但是在这个阶段之前，我想要先讲， 我们能不能先想想看，我们还可以在照顾病人的这个模式里面，我们怎么去做创新，跟怎么去做突破，然后让我们的照顾心衰竭病人的这个计划，可以给病人更有效的照顾的这个力道。所以有几个，我们也稍微揭露了一下，就是包含持续的教育，包含了对病人，也包含了对团队，可以有一个及时的稽核，而且这稽核之后可以及时的回馈，形成是一个 policy， 或者形成是可以让这个 program 不断进步的一个回馈的一个力道，然后再来尽量让照护的整个路径可以是一个标准化的路径，出院之后一定要追踪。而这追踪并不是只有追短短的6个月 PAC 的这样子而已，而持续的可以继续往下追下去，然后看看他联络的这个力道，所以会按照不同的疾病或者病人的这个heart failure 的强度而加强追踪的这个力道，然后相对的就来得很重要。所以 innovation is convergent。其实如果我们要讲 innovation 这件事情，它绝对不是就单纯的一个药物，也不是一个 device， 还包含了接下来可能会讲到的 AI、molecular 或者是 molecular science 或者是 transplant 等等之类的。于是我等一下会开始讲心衰竭在这几年我们走了哪几个 innovation 出现。先讲到这个drug 的这个部分 ，pharmacology 的 innovation， 我们从之前的 classical base 的 treatment approach 走到 phenotype target 的这个 approach， 整个药物的创新让我们在治疗方面有了几个重点。在 HRF 除了4大 pillar 以外，在 mid range 里面我们叫phenobarbital 可以开始使用了，然后在 vericiguat 或者是说 2M 在特殊选定的病人，在这个 HRF 上面我们也可以治疗。而在 mid range 里面，在 SGLT2 inhibitor 的这一个大概是全部的这个non-reduced 的 ejection fraction 的 heart failure 病人，加 reduced 的 ejection fraction 的 heart failure 病人都可以使用。然后再来就 GLP-1RA， 然后 TIRZ type 等等之类的，可以开始使用我们这样子的一个药物。所以这大概是我很想要今天跟大家表达的这件事情。那在整个利尿剂里面呢，我们的 MRA 它也突破了这件事情，原因是因为它的这个Fine Art 的 heart failure trial， 它告诉我们它可以改善ejection fraction 大于 40% 以上的这个病人，他的 hazard ratio 可以降低16% 的一个 reduction， 它可以 total 的这个worsening 的 heart failure event 跟 CV death 可以有明显的一个改善。而我们的 GLP-1RA 的这个药物，它用在于 obesity related preserve ejection fraction 的 heart failure 的这个summit trial， 它也告诉我们，它对于我们明显的这个 primary 的 endpoint CV death。worsening heart failure 都有明显的改善，然后对于整个 KCCQ 的这个生活品质也有明显改善。好，很多人应该也都有可能有打针，或者是有测试这个体重的控制，不管在 STEP、HPF 或者是我们的 SUMMIT 这2个 trial， 我们把2个放在一起比。好，不管是 SEMA 或者 TIRZ-PA 等等之类的，他们这2个药物的 mechanism 都是 GLP-1RA 或者是一个 dual 的一个 GIP。那在 population 里面，一个都肥胖等等之类的相比，好。至少在 SUMMIT 里面，它比了一个 heart outcome， 它告诉我们，在整个 CV 的 heart outcome 的 endpoint 它有明显的一个改善。而在2025年的 Canada 的一个 society， 它也是建议，如果 LVEF 大于等于 45%，BMI 大于等于 30% 以上，也许可以考虑使用这在 STEP 的这个 HPF 的药物 SEMA 这一个部分。而在其他的药物，不管是在 vericiguat 或者是说我们的 Polypir， 或者是我们在使用临床上面跟病人讲的，你要少喝一点水，我们来看看到底发生什么事情。在 vericiguat 如果用在于 reduce ejection fraction 的病人的话，它在特殊选定的这个病人上面，它是可以使用的，它也可以明显的改善。然后它 Victor 的 trial 目前还在 ongoing， 用在于 stable chronic HRF 的病人。我们把 beta blocker、SGLT2 inhibitor 还有 MRA mix 在一起，我们变成3合1的药丸，我们直接让病人吃。我们发现病人的 LVEF、quality of life， 还有就是他们的 adherence 都有明显的增加。所以也许未来更多的几合1的药物应该会应运而生。我们再把 chronic 的 heart failure 病人，我们来限制，一个是可以自由喝水，一个是一样各管师还有 program 限制你喝水，即使他已经进入了 chronic heart failure 这个阶段。我们发现一件事情。口渴不适在被限制的那一群明显增加，因为心脏衰竭再住院的这个终点并没有明显的差异。于是，在那一个的 comment 里面的 reviewer 的 comment 里面，他们说，这30年我们不断的限制 慢性心脏衰竭的病人水不能喝更多，你水要喝少一点，不知道是为了什么，只得到了更加的口渴。所以我觉得回头了，也许我们需要去定义那一条切线 chronic 的前后的差异到底是什么。那在其他的几个不同的面向，我们把它分成3层。第一层，如果是在讲对于 heart failure 有关的这个 device 的一个 innovation， 第一个我们大概在讲 EP。在 CRT 的这个 evolution 里面，我们在 LBB 的 aerial 的这个pacing， 我们有新的一个装置。然后在2023年，它的确用在于 heart failure 的这个 prevention。在第2层，我们做了这个 mechanical circulatory 的 support。然后不管是在这个 cardio MEMS 或者是的这个monitor heart failure trial， 它可以增加我们的 quality of life， 可以降低我们的 heart failure 的 hospitalization。在 CCM， 然后在 THT 的这个2026。它也明显可以看到，可以降低我们的 heart failure 的在住院。那在 TEER 的这个 trial 里面，它发现已经可以从我们这个 TEER 可以延伸从我们的 mitral 到我们的这个 tricuspid 的这个 TR 等等这一块来做使用。那在 mechanical circulatory support 的这个 layer 3的这个部分 HARMONY 3，在 HARMONY 3出来之后，其实它的这个平均的 surviving 已经可以超过3年，而且可以降低我们产生血栓的这件事情。那在 ECMO 的 paradigm 的 shift 里面，他要强调一件事情，就是 ECMO 如果我们是反射性 routine 的在使用的话，对于病人最后的 outcome 并没有明显的改善，而是应该要选出我们特定的病人，而且不是 routine 的使用，如此对于真正的病人才有所帮忙。Elevate 从 evolution 从1990到2024这几年 ，HARMONY 1、HARMONY 2、HARMONY 3到BioVet 等等之类的。HARMONY 1它让我们可以活超过1年，这样多活1年左右。HARMONY 2它可以活到4年，增加了。HARMONY 3悬浮的，它可以让我们活超过中位数活超过7年，而可以降低里面的血栓。现在下一代的 BioVet 它一样是悬浮的，然后它正在走，我们期待它可能可以来得更好一点。它也超过了7年的中位数，目前出来的 data 后面还在追。所以回过头来，刚才前面在讲的 ECMO 的这个 paradigm shift 的这个部分，我们要怎么样从 reflex to precision， 精准这件事情就会变成是在 innovation 里面非常重要的一件事情。他希望我们可以找到确定什么样子的一个病人，他真的需要放 ECMO， 而不是只要我们之前的一个习惯或者我们的反射，现在应该要放就赶快放。所以他更想要清楚的定义在什么状况应该要来放。所以他在一个这个 EOS Shock Trial 里面，大概420个病人 ，AMI 加上 cardiogenic shock， 然后 early revascularization， 然后这样去比较，他们发现只要是 AMI 再加上新兴的休克，早期有做就是再灌流的这个术式，他们中间只要状况不太好的，他们就进来做了 ECMO，30天的 mortality， 然后最后他们的这个 survival outcome 大概是47.8比上49 ，P 等于0.81，没有统计上面的差别。所以对于 AMI 加上 cardiogenic shock 的这一群病人，他建议是可以的话，应该要更加严格的去做 criteria 的一个selection， 然后大概是他这个 trial 告诉我们这件事情。所以在 key shift 里面，第一，我们必须从 routine 的 deployment， 就是到就 precision 的 deployment， 然后 structure 的一个 shock team 应该有这样的 protocol。那感谢就是奇美医院现在也有在这样的一个 shock team 的一个 protocol， 然后可以比较容易可以改善整个 survival 的这个 rate， 然后再来就是整个 ECMO 的这个 expertise 应该要把它写进整个 protocol 里面，比较清楚的一个架构，而不是觉得应该要启动的时候就马上启动。那整个 AI 在整个心衰竭里面会有几个场景。第一 ，screen， 在这 screen 里面包含了我的 ECG， 包含了我的 device， 包含了我的讯号等等的之类的。如果我可以早期透过这样子的 device IoT， 我可以侦测到它可能会有心脏衰竭，或者它正在变差，那么我可以降低它的再住院率，或者降低它的死亡率。然后在诊断的部分的话，当我加入了这整个 AI 进来之后，举例来说，当我一个 AI 的听诊器，我可以在91秒我去诊断它可能是哪些瓣膜的问题，或者是它到底有没有心脏衰竭的可能性。然后或者是说有 AI driven 的 ECG， 例如像其他医院3种，或者是他们的这个透过波形去检测可能是高血钾或者其他的这个状况， 然后当然还有透过其他的这个 AI 的 echo， 然后 identify 就是 advanced heart failure， 然后或者是说其他的这个方式。那在整个 GDMT 的 optimization， 透过 AI 的方式，可以让我们的治疗来得更加好一点。能不能让我们看到整个治疗的这个 pipeline 到底问题到底是卡在哪一些地方？然后让我们在做 clinical 的 decision 的这个 support 能够来得更加完整一些，就非常的重要。所以在整个 AI 的这个治疗的过程里面，我们会充斥2件事情，我们出现了很多的 opportunities， 也出现了很多的我们 challenge。challenge 是在于我们开始有很多的 data 进来，开始很多的民众他们使用 AI， 然后开始告诉我们的 heart failure 开始会出现很多的 different opinion， 跟我们的这个医疗端会出现这件事情。于是，在 challenge 的部分，包含 bias， 包含的 equity， 包含的这 implementation size、cost effectiveness， 或者它的整个 framework， 目前其实都还需要在后面的继续把它加强的更加的完整，因为我们现在就遇到一样的一个问题。好，这边会跟大家分享我们目前遇到什么样子的问题。首先，过去我们大概在奇美医院，我们的整个心脏衰竭的团队，我们大概就是整个 teamwork flow。我们会在医院看，我们会让病人出去，我们会去居家看病人的这个状况，我们会办病友会，我们也拍摄了很多的影片，然后到 YouTube， 让病人在居家可以跟着这样子的 YouTube 的影片直接做复健。而这让我们在整个 COVID 的状况里面 ，COVID 那2年的过程里面，曾经因为我们的整个照护品质变差，也因为这样的方式而再拉回来，让病人他的 quality of life 或者再住院率拉回到跟我们 COVID 之前差不多的这个距离。但是其实这样子再做下去之后，我们注意到一件事情 ，PAC 就是半年，可是并不是到180天或那半年满的时候，病人就再见，或者病人就离开我们的 program， 其实并没有。而在那一天之后，病人还是存在在我们的 case manager 的 list 里面，所以变成是我们的个管师不断的越来越多的病人，越来越多病人。我想这全台湾的医疗都面对到这样的窘境。于是到底要怎么解决这个痛点，才不会让我们的个管师会burn out？有没有更多 innovation 的方式可以来协助我们做这件事情？也因为这样子，我们开始重新规划、重新设计。我们开始重新设计之后，我们希望可以有一套的这个 case manager 的软体，它可以自动去帮我们去侦测病人的风险到底高中低，它目前的风险大概如何 ，LVEF 大概有没有什么进步，住院天数大概是在什么时候？在临床中枢里面，可以告诉我们在照护的整个漏斗里面，病人卡在哪一段是最多的，照护品质的 outcome 如何？而老实说，我们过往在做这件事情的时候，我们会统计很多的 BI， 看起来好像很 innovation， 可是 BI 并不会让我们往前迈那一步。我们需要的是看了 BI 之后，后面给出自己的 suggestion， 或者是洞察 insight， 以及告诉我们到底要 recommendation， 我到底要走向哪一个地方。所以我们做了心衰竭这个个管的这个软体，它会及时的去做临床的中枢决策，告诉我们下一步，也许这个团队应该在做哪些事情。照顾团队，或者是主管、照护的主管，或者是院方高层的角度来看，这个团队在整个 DSC 的照护品质里面，它扮演什么样的一个角色。于是，当我们点了一个，这边就秀测试者1号。当测试者进来之后，他可以快速的看到这个病人用的药物，以及他全部的这个 lab 的 data， 然后 LVEF、NYHA 大概目前的状况是如何。它会自动去抓 HIS 里面的资料，告诉我们现在的病人的临床事件，它是处于在哪一个阶段，有没有做了 echo， 临床的决策是什么。可以看得到，我们总共有8位我们专业的这个AI 的团队。当我点了这个更新建议之后，这8位就按照病人目前全部他的 data， 给出这个病人对应应该哪一件应该要做的治疗，而临床人员就可以把它选择加回去我们的这个团队的决策里面。全部都可以设自动化，因为今年26年是 Agent 的1年，所以它全部都可以自动，开始全部都自动化。临床事件发生临床事件之后，启动 AI 的这个全部的团队，8位团队，然后全部决策完之后汇进去，然后去执行下一步。当我在执行下一步之后，例如该送出我的 EQ5D 的这个 message 就从 Line OA 就出去了。该去挂号就串接门诊的 API 直接进行挂号，该排检就去排检，该做什么就做什么。该今天要传给营养师，接下来这个病人的药物应该做什么样的调整的时候，就传给这个营养师做什么样的调整。而当病人给我们的回馈 Line OA 进来之后，也会直接进到 ePRO 的量表要追踪跟查询。于是我们开始可以去追踪每个病人发生什么事情，以及在行事里面病人应该接下来要做哪些事情，还包含了这个病人什么时候应该要titration他的4 pillar 药物应该要调到底了，而不是 只能被动的就是下一次门诊再做这件事情。OK， 所以我们开始让这些事情可以尽量自动化，原因是因为为了今年、明年、后年这几年在做准备 ，agent 的时代在做准备，同时间避免个管师会burn out这件事情。好，前面讲完了整个在个管 innovation， 我们做了很多的创新跟很多的尝试，不管是在住院中、住院后，还有怎么样节省能力，去精算它的 cost effectiveness。在 molecular 的 science 的部分的话，它有 precision 的 heart failure is now， 原因是因为我们大概已经可以开始用基因来做很多的检测了，还包含了就是整个决定什么时候装 ICD， 应该要怎么样子，要不要继续追下去，我的 family 要不要 screen 继续追下去。proteomics 或者 biomarker 也开始在这个时代开始不断的出来了。但是这边要讲的一件事情 ，proteomics 或者 biomarker 有越来越多，好像跟心衰竭有相关，好像可以拿来做 association 判定它会不会在住院会不会变恶化，但是还没有到很 ready 可以开始使用的这个时间，可能还是需要再往前走一下子。那在 genetic therapy 里面，不管是 CRISPR 或者CRISPR 或者是说我的 AAV 等等之类的，我们都可以看到，在基因的治疗已经有往前跨了一步，包含了它可以用 PCSK9 然后下降，或者是说其他的方式，然后不管是在脂质的控制，或者是说在其他的这个heart failure 有关基因方面的治疗，目前 trial 都在往前走。CRISPR 在心血管的方面呢，我们已经可以看到它在 lipid 的 reduction 是有很明显的一个改进。这边的 trial 我就不细念了，包含了非常多几个 phase 1的这个 trial。那比较好一点的，大概就是 ATTR 的这个的这个cardiomyopathy 的这一方面的治疗，这个大概已经进到我们的这个 phase 3的这个部分了。那 preclinical 的话，在 psychometric 的这个 HCM 的这个部分，打药物也可以拿来做基因的这个治疗。OK。那在新移植的部分，大概就把它分成这几个部分。首先，扩大捐赠者的这个 pool。过往我们在做这个donor， 其实它是很严格的在做很多的限制，但现在其实不管是在 HCV， 甚至是 HIV， 他们都可以做 donor， 但是它有他们自己的这个限制，然后像 HOPE 的 Act 里面的 trial，HIV 的 donor， 他就可以捐给 HIV 的这个 recipient。然后可能 HCV 的这 donor 在用之前，他可能就是需要经过 DAA 的这 treatment， 先把它做一个的这个病毒量的一个治愈，然后再做这个选择做 donor 等等之类的。而在整个议题移植可能早上陈副有跟大家介绍到这个部分，就是不管这个议题移植的部分，我们目前不断的在把survival 的 day 往后推，现在可以到40天到60天的一个 survival。我们当然希望未来可以拉的时间更长久一点点。那未来很多的挑战，包含了就是 immune 的 rejection 的 control 等等之类的，或者是我们的整个 ethic 的 framework， 然后或者是说公平性等等之类的。我想未来挑战那些伦理就留在我们的心里面。我要讲的是，其实未来好像看似我们一直每天都在做 daily 的这个 routine， 或者是说这个 daily 的 practice， 但 future is conversion， 它其实这几条路正汇集在一起里面。那5大的整个趋势的汇流，从 phenotype。从过往的 classical base 的 treatment， 我们现在已经走到 phenotype guided， 告诉我们什么类型应该用什么样子的药物治疗会来的比较好一点点，可以更加精准。而住院的这个出院处方，对我们而言，它不再是好像那个 trigger point， 就是时间到就是在那边，不是，而是我整个 titration， 我的 transition of care 才是我们的决胜点。我开始更在意的是能不能在3个月把这4个 4 pillar 的药物开好开满，透过其他 innovation 的方式来设计来达成。而这不再是只有一个 AI 可以做到，这甚至整个团队，然后能不能按照有一个框架来做这件事情。那在 AI 的 upstream 到 screening 到这个 downstream 到这个 titration， 它开始扮演很多重要的角色，而不是只有一个 device 的一个 AI， 不是，它包含了这整个照顾面的设计，还有整个 framework structure， 可能都需要用 AI 可以来协助我们做这件事情。那基因跟这个分子。molecular 的这个therapy 目前正在重新定义许多不明的心肌疾病。我想在我们有生之年，我们可以找到更多的 idiopathic 的这个 cardiomyopathy 出现。那 early advanced heart failure 的 referral， 永远都是 before 的 exhaustion 等等之类的。所以可以的话，尽量转给一些专家，不要等到我们治疗到整个精疲力尽，或者是整个团队都很辛苦的时候，最后那口气才把这个病人转给别人。也许知道什么时候该让病人到某些的人的身上跟手上，我觉得这是我们要过的那一个坎。所以其实 take home message 我要跟大家分享，就是the next breakthrough in heart failure is not only a molecular but a model of care。所以今天我要讲的 innovation， 我并没有介绍很多的 device， 我也没有介绍很多的 AI， 没有，我还是回过头来 innovation。如果回过头来，我们所照顾病人的每走的每一步，这些 innovation， 我们就是真的把病人的药开好开满，那在3个月内，那我觉得比我刚才所讲的全部的 innovation 来的更加重要，因为我们应该是用创新回头，让我们照顾病人可以照顾得更好更满。那在整个指引在导向的这个治疗，我想在未来一定是会发生，但是我们怎么样可以拥有一个 structure 的 system， 可以让我们的病人可以得到更好的这个照顾？那有我们曾经的经验 ，Get with the Guideline Heart Failure Asia 的这个 program， 它告诉我们几件事，不是大家都要参加这个 program， 不是的，而是它告诉我们应该透过之前所讲的这4个方式，也许可以让我们照顾可以来得更加精巧，可以更加细腻一点。那未来的整个心衰竭的管理，不管是一个 phenotype 的 directed， 或者是说一个 digital 的 enabled， 或者 biological informed， 或者是 operationally 的 accountable。它应该都是要可以被追踪的，这些的 major 我们有在心衰竭里面把它定出来嘛？如果定出来，我们怎么追踪？我们追踪好的结果，怎么让我们的下一步可以来得更好？而这就是我们整个医院在学习型组织里面我们在发展的。我们从照顾的过程里面产生的数据，这些数据堆叠出知识，而这些知识告诉我们下一步要往哪里走，而我们 innovation 就正在建构。这一个 cycle 可以让它走得更长久、更永续。以上是我的分享，谢谢。
非常谢谢廖医师精彩的演讲。相信经过廖医师的演讲，大家对 innovation 又有新的认识。那因为时间的关系，我先交给伟霆医师。
非常感谢，就是在座，我想所有的就是今天与会的贵宾，大家都做到 last minute 哦。那很感谢，就希望今天的我们带来的一些用心准备的活动，我们今天准备团队实际上非常辛苦。那事实上，也所有的讲者还有 moderator， 事实上我们就可以 deliver 很多，我觉得对心血管相关，我觉得非常 useful 的一些讯息。那在最后的话，我想要就是邀请就是陈副院长，最后我们有个 closing remark。Let's welcome the Professor Chen giving us a closing remark。
今天真的很谢谢哈，这各位坚持到最后。那在奇美真的就是30年前的3月，就这个月，那时候我们开创了我们的 program。那今天很谢谢大家来跟我们大家一起见证这个30年的努力。那今天的活动真的很谢谢我们的团队了哈，他们这一段时间也真的算不眠不休，那么来完成这样的一个活动。那最后呢，我们也会有一个影片，那么大家可以在里面找一下，因为很多人都有在里面。那我们也谢谢大家这30年的不管是整个心脏血管内外科以及加护病房以及护理单位等等，都是大家导管室啦、超音波室，等于大家都是一起努力来把我们的工作做好。那就让大家最后就欣赏一下我们最后的一个结束的影片，谢谢。
身在末端，心里激发，黑夜里心跳忽快忽慢，警报声在生命线回荡，电流画出每一道讯号，我们站在最前线守望，白袍下藏着忽拽忽挡，秒秒间和时间对抗，一条是一个决定，为你守住每一次心脏。白袍下藏着不退的胆，秒秒战和时间对抗，一条线一个决定，为你守住每一次心跳。心里激发，黑夜里心跳忽快忽慢，警报声在生命线回荡，电流画出每一道讯号，我们站在最前线守望，白 白袍下藏着不退跃的渺渺剑，为时间对抗一条心，一个决定，为你守住每一次心跳。白袍下藏着不退